the Islet CARDIOMETABOLIK CONCLAVE 2024. We are truly honored to have each and every one of you join us today for this significant gathering aimed at addressing the challenges and achievements in the field of cardiometabolic health. I am Twinkle Zala, and it is my privilege to extend a warm welcome to all of you on behalf of Islet 2024 Cardiometabolic Conclave and Life Care Hospital and Research Center, and Organizing Secretary Professor Dr. L. Sri, and obesity represent a significant burden on global. It is imperative for us as healthcare professionals to come together to explore new strategies. Further, I would like volunteers who have invaluable contribution towards this event. Your dedication and commitment to advancing cardiometabolic.
Thank you.
A warm welcome to thank Professor Dr. L. Srinivasmurthy, my dear friend, for this opportunity for us to chair this first session. And to set the ball rolling, we have a stalwart secretary of RSSDI, and he's been the chairman of Gujarat State Chapter of RSSDI. We welcome Dr. Pratap Jetwani to talk on this topic of assessment and management of obesity in
the topic now. It's assessment.
Let me thank Dr. Srinivasmurthy and the team Islet for inviting me to be part of this scientific program. So we all know that it involves multiple factors including genetic, environmental and behavioral, and it disposes person to a variety of disorders including cardiometabolic disorders, osteoarthritis, sleep apnea and some cancers. For densitometry, but in clinical practice this is not possible, so we have got fit in normal non-elderly adults, and that's why we are measuring their BMI, and this is the 1998 BMI, and these are the different grades of obesity which we know. But we both are having same BMI of 22.3, but when they underwent DEXA, the body fat percentage in Professor Yajnik was 21.2 as compared to 9.1 in Professor Yudnik. So 2 times higher. That BMI will not tell you everything about the body composition. It will just give you a hint that the patient is overweight or obese for a given height. So Asian Indians, we all know they have more fat, both total and in the abdominal region, less lean muscle mass, skeletal muscle and bone mineral than all other ethnic groups. So we are at the same BMI carrying more fat, so we are at more risk of developing cardiometabolic disorders. That's why we need to combine waist circumference with BMI for assessment of obesity in our clinic in the abdomen or the visceral fat content. The Indian consensus statement about diagnosis of obesity, abdominal obesity and metabolic syndrome for Asian Indians, and the recommendations for physical activity, medical and surgical management, which was published before few years, they have told that the same they have reiterated, that waist circumference and BMI both should go hand in hand as far as obesity assessment in our clinical practice is concerned, and that is also being endorsed by American College of Endocrinology and American Association of Clinical Endocrinologists. So for Asian Indians, if the waist circumference is more than 90, then the patient is at risk of cardiometabolic disorders, and you need to give action plan to reduce the abdominal fat. For men it is 90 centimeter, for women it is 80 centimeters, and there is an action level 1, above 78 or above 72 in women. You need to reduce the weight gain in this individual so that they do not develop cardiometabolic disorders. So for Indians, this is the classification of obesity. As per BMI, we have revised the cutoffs. Less than 18.5 is underweight, 18.5 to 22.9 is normal weight, 23 to 24.9 is overweight, and above 25 is considered as obesity. And then there are grading: obesity grade 1, 25 up to 30, obesity grade 2, 30, more than 30 but up to 35, and obesity grade 3, when it is 9 in men and more than 0.8 in women, is considered as obesity, abdominal obesity in Indians. And if you are using body composition analysis, then body fat percentage in men, if it is more than 25%, and in women, if it is more than 30%, then this is considered as obesity. So this is the way you can diagnose or assess obesity in routine clinical practice. There is another staging system to assess obesity, which was suggested by Edmonton group. And this includes BMI, plus various others, comorbidities, mental impact of obesity, and require more attention in clinical practice as far as weight management is concerned. And they've also given this flow chart of management, that if there are no risk factors, then you can do a primordial prevention with the help of lifestyle modification. If there are risk factors plus obesity, then it is a primary prevention. You use more of a lifestyle modification plus behavioral therapy. If there is a presence of disease with obesity, then that is a secondary prevention. You have to use medical therapy in addition to treating that disease. And if there are complications and significant, surgical therapy for management of obesity. Weight loss is important because weight loss will act at liver, muscle, adipose tissue, pancreas, kidney, lipids levels and cardiovascular system, and will improve all of this cardiometabolic impairment which occurs. The lifestyle modification, we all know the direct trial loss, umbrella review of past diets and their impact on weight is weak. So these are also diets, but total diet replacement or diet program with meal replacement is the best way to provide weight loss. The ADA also endorses the same weight loss benefit. And nutritional supplements have not been shown to do any indication. Or more than 5% weight loss in the active group. Semaglutide is approved for use in India, but still not available, and liraglutide probably will be approved in near future in our country, but it's still not available. The drugs mainly act on the gut, adipose tissue, and the brain, and they mainly act going to. This is the new product which is in pipeline, that is combination of human amylin analog, that is STAT. It works on energy wastage through GI tract. Otherwise, they act mainly through GLP based pathways on the brain, and they improve satiety and they decrease hunger. These are the molecules which are in the pipeline. If we focus on retatrutide, weight loss of 10%, 93% people achieved, and weight loss of 15%, 83% people achieved. And diabetes remission, HbA1c less than 6.5 was achieved by more than weight loss. Then you have to use GLP-1 and SGLT2 inhibitors. Lipase inhibitors can also be used if BMI is more than 25 kg. ADA says that guideline that semaglutide or tirzepatide, they are to be preferred without any therapeutic inertia. So this is the guideline. They say the very high weight loss is there with semaglutide, tirzepatide, followed by dulaglutide, liraglutide, and intermediate weight loss is there with SG. We all know there are a lot of bariatric surgeries which are available, and they can provide excellent weight loss and diabetes remission, but there is also a proportion of people who regain weight over a period of 5 to 10 years. So what are the guidelines about bariatric surgery? RSSDI recommends that patients with type 2 diabetes with BMI 32.5 kg per meter square who cannot achieve sustainable weight loss and improvement in the severity of comorbidities, you can subject them to any of these bariatric procedures. It can be restrictive, malabsorptive, combined, or experimental procedure. ADA recommends that people with diabetes with BMI 30 kg per meter square or more, and who are otherwise good surgical candidates, and this is to be done at a center where enough technique is there, or there are also medical devices for weight loss. And this is in nutshell: people having obesity with type 2 diabetes, diet and lifestyle and medications are must square, and who are not able to reach surgery. To summarize, I will say assessment of obesity with BMI classification may not be sufficient to optimize treatment. You need to unique approach. Pharmacotherapies that combine weight loss, long-term safety, weight loss maintenance, and reduce complications, they are needed in obesity care. GLP-1 based therapies, they are there and they are the future. and with medication, with nutrition, exercise, and if required medications or surgery, if we will be able to reach to the normal weight, then we will be able to avoid all the cardiometabolic disorders which are related to obesity. Thank you very much again, Dr. Srinivasa and team, for making me part of this evening.
I think this deserves another round of applause for the way that tackling obesity.
Whether you do in calorie restriction, that's a very good question. So I think it should be at least maintained for 6 months. And ideally for medical benefits, that should be at least.
Request that I call upon the next speaker, Dr. Alok Modi. I would like to request the chairpersons to introduce the speakers.
So the So that's my disclosure. So there is no financial credibility here, and I have used artificial intelligence library in making the slides and also doing my people are not clones over here. There should be a disclaimer. Another study, 4 more trials are undergoing in this molecule, and now what they're looking at is a Trump 1, Trump 2. Trump effects were so huge that they decided to terminate the trial prematurely. The results should be out somewhere in March. The trial prematurely. The results should be out somewhere in March or April of this year. We don't have the results, so I cannot talk statistics here. The remodel trial is a much ahead trial. What they are doing is it's a 52-week multi-center international trial, and they are going to look at the UACR, they're going to look at the natriuretic hormone, they're looking at the biopsy, they're looking at the kidney in and out. And having done that, they're going to see the progress of kidney damage at a histological structural level with semaglutide. And if that is going to be there, what they say is if this trial shows benefit, this is something which is going to be bound weight control, HbA1c control, and cardiovascular benefit. This is going to talk purely about renal. So they're saying once the remodel and the flow studies are out, we will be to as far as the kidneys are concerned. Now here comes the series of surpass studies on tirzepatide, different combinations of insulin, different combinations in the Indian population, in the Chinese population. All of lifestyle, can the weight loss be maintained and continued? Lifestyle, can the weight loss be maintained and continued? Surmount MMO recruiting, OSA and heart failure for preserved ejection fraction on statements as to how you can give both for long-term benefit. And GLP-2 stimulation simultaneously, and where they have used heart failure. We already know that when you give the combination, the risk of kidney infections is much less when you give it without DPP-4. So this is one data, and they found good amount of benefits in this study. They've also used SGLT positive and a combination. I'll change the track now. I'll shift from molecules, and I'll start coming to different aspects of diabetes. And technology is something which I like, so I'll just touch up TIR. You can start using intermittent TIR modality. TIR has given phenomenal results that you can pick up hypoglycemia, which is going to occur 3 days from now. Dr. Bansi sir is here. He has himself given a very good video on with this opportunity, and I hope I could just touch the relevant points and on time. Thank you.
So if you have any questions from the audience, you probably, the one question that the pioneers now currently will be using AI extensively as far as diabetes treatment is concerned. So could you put it in a snapshot for the audience?
So I had patients who had diabetic foot, who had fungal infection, and there was a pulmonary tuberculosis in the lung. So I had to put on AKT, this, and then I had to put on SGLT2. So I was wondering, so that forced me to create it, and I got it created. Of course, it's not validated yet. The problem with AI is there is no validation tool in India as of today. I don't want to take too much time and talk about, I'd save a lot of time doing that. Second thing, I had a lot of patients who are getting these SMBG reports. You know, we all get that. They just write it down. We say, yes, it's nice, and they say, here, see, the sugar is 120, here it is 300. And so that is where it saves a lot of trials, which says that DEPA was used all over the world to save my kidney. I said, oh, I was so wrong. I should not go against my doctor. You know, we're trying to do this kind of validation. So it brings up a big headache, deep burdening for the healthcare provider.
To Dr. Alok.
to the stage our esteemed chairpersons, Dr. Vijay Kumar and Dr. Rajendra.
I request Dr. Karthik Muni Chudappa to continue and Dr. Kiran Nidundi.
Good morning. First of all, I thank organizing team for inviting me for this well above the normal range fasting. So you cannot call it as an insulin deficient state also. So more of insulin resistance, you can see the uric acid level 8.1, which is more predictive of an insulin resistance, because insulin resistance is a high cell turnover. So you can get an hyperuricemia. And another thing was the HSCRP which has done, when it was mildly elevated 7.1, you can say up to normal up to 3. So anything more than 3 you can take it as an marker of inflammation. So low grade inflammation you can see in this patient. So I'll come back to this case after some discussion. Again, a second case, the 53-year-old male, diabetic since 8 years, irregular follow-up, and the glycemic control varies from 7 to 8 of HbA1c. In the recent visit, he had a mild hypertension, obesity of grade 2, insulin resistance signs were there, and lab values with HbA1c of 11.3 and creat of 2.3, and the urine ACR were in microalbuminuria. Again, the HSCRP was mildly elevated, 8.2, and retina was showing no NPDR. So you can see the lab values. Again, the control was very poor, even with the insulin addition and the increment. Before that, May, he was visited around in the 2020. The levels of HbA1c were around 6 to 7. In the May 21, we had seen only mild elevation of creatinine of 1.4. The metformin dose has decreased from 2 gram to 1 gram, and added insulin. Still with the insulin escalation, the HbA1c has remained on the higher level only, above the 8 only. So it's currently with the linagliptin 5 mg, dapagliflozin 10 mg, and metformin 500 mg, and gliclazide 80 mg BD with the insulin premix 50 around 26 and 20. With that, still is uncontrolled. So we'll come back to this case. We'll discuss about what is the low-grade systemic inflammation. What is low-grade, what is actual inflammation. The actual inflammation is an vigilant defense system, which is for pathogens or cancer cells. Whenever there is a normal cell escape the normal cell cycle, so it will be destroyed by the immune system. So if it is a dysregulated or a mistargeted or a exuberant systemic inflammation plays a crucial role in some of the autoimmune diseases, like you can say autoimmune disease, collagen vascular disease, even in type 2 diabetes we can call. So this dysfunctional adiposity, or you can say the rupture of adipocytes, which will initiate an inflammatory cascade of dendritic cells and macrophages. So that will secrete the cytokines, and cytokines will lead to the insulin resistance and development of pre-diabetes and type 2 diabetes. So when to call it is a low-grade inflammation. So anything above normal range of the cytokines, we can call it as a low-grade inflammation. If you say HSCRP, anything more than 3 mg per liter, we can call it as a low-grade infection. Usually it will be 2 to 3-fold elevation. So how to differentiate the acute versus chronic inflammation? Means acute is any viral or bacterial infection or any pathogens which is leading to acute inflammation. And low-grade systemic is autoimmune disease or even type 2 diabetes or obesity, even atherosclerotic disease. All these are considered as a low-grade inflammations. So in low-grade inflammation, the HSCRP is commonly used is the HSCRP. So it will be between 3 to 10. In acute inflammation, it will be more than 10. Means if you take a viral infection, it will be between 10 to 100. If you take bacterial infection, it will be more than 100. So this is a vicious cycle of an inflammation and metabolic diseases. So chronic inflammation, obesity will lead to chronic inflammation that will lead to again the dysbiosis, that is microbiota has changed in the gut, that will be more towards the storing thing, and again at the end of pre-diabetes there will be a lot of reactive hypoglycemias that will lead to irritability, social isolation and stress, sleep disorders. All this will lead to the metabolic syndrome, type 2 diabetes and non-alcoholic steatohepatitis and cardiovascular complication. Even the cancer has been proposed as association with insulin resistance and obesity. So how this diabetes and inflammation can link? So this is a typical picture, you can say. Dysregulated adipocytes, that is adipocyte dysregulation, or you can call it any rupture of adipocytes that will activate the dendritic cell, that is antigen presenting cells, to the macrophage, and macrophage will secrete along with the lymphocytes, T lymphocytes, all these cytokines, interleukin 6, interleukin 1 beta and TNF alpha. It has a minor role, it is mainly in acute inflammation. Recently the IL-17 has been proposed in many autoimmune diseases as well as in type 2 diabetes. All these cytokines will act at the pancreas, and there will be beta cell dysfunction. So there will be an insulin secretory defect. So these dysfunction adipocytes with inflammation, there will be a lot of insulin resistance at adipocytes. So there will a lot of free fatty acids will be released into the blood that will go to liver, and there will be an development of NASH. So NASH is again an inflammatory state. So it again will lead to beta cell dysfunction. You can remember some of the patients of hepatitis B and C, which are active chronic hepatitis, where you are getting a difficulty in controlling sugars. Even 2 to 3 units per kg of insulin will not be sufficient to control that hepatitis B, chronic hepatitis B infection with type 2 diabetes. You can remember that. And again, another thing is the kidney, which is micro and macroalbuminuria, leading to chronic inflammation and tubulointerstitial disease. Again, that early nephropathy is very difficult to control for the glycemia. Even you require a higher dose of insulin as well as in oral glycemic drugs. So if you see a sudden variation in the glycemic control, you can think of any development of the early nephropathy, macroalbuminuria. So that's how this inflammation causes insulin resistance. Is these cytokines will act through the JAK-STAT pathway. So this JAK-STAT pathway will phosphorylate the insulin responsive substrate, which is major thing for the downgrade pathways of insulin action. So GLUT4 expression and all those insulin sensitive factors. So only the factor is IRS is lower down. That remaining mitogenic pathway of the insulin is active. So insulin resistance, hyperinsulinemia, that mitogenic pathway will be active. So that mitogenic pathway will cause the proliferation of cell, that predisposition for the cancer, everything will be there. We will see acanthosis, all those things. But the action of insulin regarding the glucose will be reduced. That anabolic effect will be reduced. So this is a typical ominous octet of type 2 diabetes. In that the inflammation has major role. So you can add into that the inflammation is one of the factor in the type 2 diabetes. So this is all I have explained the interlink between the inflammation and the type 2 diabetes. This is a positive feedback. Whenever there is insulin resistance, so inflammation will happen. Inflammation itself will lead to an insulin resistance. So this is a vicious cycle of positive feedback. So this is a typical Indian phenotype as compared to Caucasian phenotype, where the lean body mass is more and fat mass is less. So it's more of pelvic fat. That we call it as a pear-shaped obesity. And Indian phenotype, it is more of fat and less of lean body mass. It is more of abdominal visceral obesity, that is apple obesity. So these visceral obesity, as the fat is more attracts the inflammatory cells and more inflammatory thing, more pre-fatty acids into the blood and more incidence of NASH. So this is some of the comparison of healthy obesity, but obesity itself is an unhealthy thing. But in that you can subdivide as healthy and unhealthy obesity depending on the fat distribution. More of pelvic fat will be more skeletal problems like chronic osteoarthritis. And the abdominal obesity is more of metabolic problems like type 2 diabetes and cardiovascular problems. So already I explained that how inflammation will affect the different bodies, and this is how the currently available drugs can target at the inflammation. Pioglitazone will somewhat act at the inflammation because it helps in the maturation of the fat cells, so that inflammatory part will be reduced with the pioglitazone. That metformin will act and not act at that site. And coming to the oxidative stress at the mitochondria, it will be with GLP-1 pioglitazone, and endoplasmic reticulum stress will be reduced with the metformin GLP-1. So coming to, is it targeting this inflammation will help in the type 2 diabetes management? Means all we know that is inflammation is a problem. So is it worthwhile to target that inflammation in type 2 diabetes? Currently we have very limited number of molecules to target that. And again the safety of that molecules we have to consider, because it's not that easy to target IL-6. If you target IL-6, it will be predisposed to the chronic inflammation. This is one of the trial which has been just and sub-analysis of 3 major trials of this interleukin receptor blockade. So in that they found that there was a significant HbA1c reduction in that group. Means there are 184 patients out of 2,500 patients. There were diabetic and obese. So in that case it has been helped, means there was a significant HbA1c reduction. Even that oral hypoglycemic drug requirement has reduced with the treatment of this IL-6 receptor blockade. So coming to one of the easily and commonly available molecule in India, this is hydroxychloroquine, how it can help in inflammation. This is not that hydroxychloroquine we can use it in each and every diabetes. There are some cautions, so we'll discuss in subsequent slides. This is the first thing, how this IL-6 has been significantly reduced by the hydroxychloroquine in post-MI state. Again, MI is an inflammatory state, so there was a significant, this is RCT, placebo control trial, in that they have shown that significant decrement in the IL-6 compared to the placebo. And this is another trial of hydroxychloroquine in, on the biomarkers of inflammation. It is already well proven in autoimmune disease and collagen vascular disease. It has been significantly able to reduce IL-6 and HSCRP. The same has been shown in this study. Along with that, they have shown the adiponectin, which is a factor of insulin sensitivity. It has been significantly improved in a hydroxychloroquine group. So this is a study which has compared the glycemic control versus the inflammatory markers. So there was a significant decrement in the fasting blood sugar as well as in the HbA1c with the treatment of hydroxychloroquine. Along with that, there was a significant improvement in the interleukin 6 and HSCRP levels has been come down, and adiponectin levels were gone up. So this is a just correlation of insulin resistance with the inflammatory markers. As the inflammatory markers goes down, so insulin resistance factors also have gone down. When this insulin secretion factor HOMA-B has beta cell function has been improved with the reduction in the HSCRP and interleukin 6, and as adiponectin's levels improved, that also was well correlated with the improvement in HOMA-B. This is again a small trial of showing insulin resistance has been improved, and the glucose disposal index has been improved with the hydroxychloroquine. This is one of the Indian study which has shown that significant decrement in the HbA1c that was more pronounced in the cases where the baseline HSCRP was more than 3. It's the same thing of another trial of showing insulin clearance and inflammation in the insulin resistance state has been decreased with the hydroxychloroquine therapy after 12 weeks of treatment. It's the same thing, HOMA-B and HOMA-R has been improved with the treatment of hydroxychloroquine of 12 weeks. But 12 weeks is very short period for an HYQ, because the half-life or duration of half-life only can call it is almost 15 days to 52 to 60 days. So it is very long-acting drug. So at least of 6 months is required to assess and some effect in hydroxychloroquine. It is very early to assess at 12 weeks or 13 weeks. So coming back to our first case, he was on full dose of metformin OHA and 100 units of this thing, insulin. So we added hydroxychloroquine as HSCRP was high, 400 mg per day. The required dose is, we can call it is around 5 mg of actual weight, 5 mg per kg of actual weight. If you are taking lean body mass, and you can take up to 6.5 mg per kg. So we started on 400 mg. You can see after 3 months there was a significant decrement in the HbA1c. So it went up to 7.5 from 11. With the same dose we have continued in the future, has the insulin requirement has significantly gone down. So coming back to second case, he was CKD. So in the case of non-proliferative retinopathy or CKD, you have to take it at a lower dose, and the caution should be taken in terms of retinopathy or in terms of myopathy. You have to take into consideration. So close observation has to be done in these patients. So started on 200 mg per day. You can see that the HbA1c has gone down to 7 after 6 months. In between follow-up he has not done. Even the creatinine has reduced significantly. So from 2.32 it went down to 1.6. So currently we are having one of the trial on early CKD and hydroxychloroquine as a placebo control trial we are doing in our institute. So we are getting in some of the promising results in terms of improvement in the mild creatinine. Even the macroalbuminuria has been improved in some of the patients. So results has to be published. So in conclusion, definitely the prevalence of diabetes is going to be increasing in India, and markers of inflammation has been implicated in the pathogenesis of type 2 diabetes, even in the complications like early nephropathy and cardiovascular diseases. So abundant clinical evidence explains the role of this chronic systemic inflammation in obesity, metabolic syndrome, insulin resistance, and beta cell dysfunction. You have to consider this, and we can, there are coming up, means IL-6 antagonists have been undergoing trials on type 2 diabetes and early CKDs. So hydroxychloroquine, which is commonly available, time-tested molecule which is available, means you can say in last 30-40 years it has been used abundantly in autoimmune diseases, collagen vascular diseases, with good proven safety. If you are considering as a retinopathy as a problem, it's hardly, if you use it for 10 years, it is less than 2% the incidence of retinopathy. So only thing has to be, caution has to be there for retinopathy, rarely myopathy. So it plays major role in the management of type 2 diabetes. Thank you. Not in very early in the type 2 diabetes, sir. Means, if you say a given patient, if it is well controlled with routine drugs which are very proven to be safe in type 2 diabetes, we can try with that. If it is very difficult to control, especially in early nephropathy, where there is a lot of inflammation is going on, or some of the cases even with larger dose of insulin, if it is not going down, the glycemic control is not good. If you have proven value of an chronic inflammation, in that case you can add it, sir. So it can take it as an routine drug, as after that routine drug we can place it, sir.
If there are no questions, we'll end the talk. Thank you, Doctor.
Thanks.
I request the chairperson to give a token of memento. I call upon the next speaker, Dr. Krishna Sheshadri. He'll be speaking on current challenges in diabetes management, clinical positioning of dual and triple OADs.
If you put Srinivas Murthy's photograph, it will be like a younger picture of me, so it's not. Okay. Thank you for having me here. It's always a pleasure to be here, and thanks Srinivas Murthy and colleagues for having me. So I'm going to talk about mostly fixed drug combinations. Here's an area that we, almost 87% of sulfonylurea, metformin, and other drugs that are used in India are used as fixed dose combinations. However, there's no clarity to our use, and there are lots of unknowns. So I'm going to spend some time working through this, and then there will be more questions than answers at the end of it. But it's important to understand, how do you do this? I have conflicts of interest, I have a speaking honor area, I have advisory positions. So why FDCs? Why FDCs? The most important reason, and we need to take this thing from hypertension, is to reduce the pill burden, right? If you reduce the pill burden, it can improve adherence, it can improve persistence, and possibly improve outcomes. And you can see I put a dotted line, because we really don't have data. But what we know is that when you use FDCs versus, here they use the word LDCs, which is loose drug combinations, persistence improves. That means the number of times a person actually purchases the drug back again, that's all it's measured by, has improved over a period of 1,095 days in this particular instance. Does it mean that the patient is taking it? Probably. When you buy it, you probably take it, right? The second important thing that FDCs do is they reduce medication errors, simply because you're not, for example, we have two drugs, you may forget one of those, or you may take two of the same in an older person, and again, can possibly lead to better outcomes. There are some studies that show that HbA1cs improve, but really, not too many studies have looked at actual outcomes. And of course, when you have a fixed drug combination, you have simplified dosing, okay? Now, when you manufacture them, there's a possible reduction in cost. For example, when DAPA and metformin, or Vilda and metformin came, the cost was the same as just dispensing Vilda or DAPA. So actually, there's a reduction in cost. Hopefully, some of this action is synergistic. You take a DPP-4 and a metformin, you will find that both of them have some action on GLP-1 in the liver, correct? On the other hand, if you use, there can be antagonistic actions that are useful. For example, DPP-4 and SGLT2 inhibitor. And SGLT2 increases glucagon, the DPP-4 brings it down. Hopefully, there is some action because of that. But these are the disadvantages of an FDC. One is, there's no dosing flexibility. We all know this from the insulin story, right? Fixed combination of insulin versus loose combination. Second is, sometimes you can have interactions that lead to an altered effect. Third is, if there is altered pharmacokinetics, it interferes with the pharmacokinetics, it can be a problem. Now, if you have an allergy to one of those components, you have to stop both the drugs. You can't just say, get out of it. And sometimes, of course, you can have a higher cost of these. But let's take this a little more. India was a country of FDCs, and you had all sorts of combinations, kinds of combinations that will make you mind-boggling. And that's when there was it was a public interest suit that got this banned. It is not us or the pharmaceutical industry just waking up, or the CDSCO waking up. The CDSCO has been warning us of not having rational combinations. But in 2018, a few hundred drugs got banned. And of these, many of these were combinations that the CDSCO called as irrational combination. a half dose of glimepiride with metformin, immediate release with pioglitazone, 80 milligrams of glycoside with 325 milligrams of metformin. If you look at it, you understand why it was banned, right? There was no rationale to it. So it's important for us to, when we create fixed combinations, to create a rationale to it. I'm going to go through these because it will help us evaluate not just the ones, and now there's a whole bunch coming to the market, especially the DPP-4s, the SGLT2 inhibitors. And I promise you now with the PPAR gamma data on MASLD or NAFLD, you're going to see a lot of these triple or double combinations with pioglitazone added into it. So the first thing is there a medical rationale, right? There needs to be a medical rationale to combine a drug. A DPP-4 with metformin is a good combination. A DPP-4 with an SGLT2 inhibitor is a really good combination because they work together. We'll talk about it today, right? So there needs to be a rationale to it, and maybe tomorrow an SGLT2 inhibitor with a TZD, in my view, is a good combination because it addresses a specific population. For example, if you have NAFLD, SGLT2 inhibitors bring down the fifth score, the thiazolidinediones bring down the FIB-4 score. That combination is synergistic, and our own data supports it. The second question is the efficacy of the combination better. Let me do this for a second. I'll go back to my talk, but if you remember this, there is an equation that predicts efficacy. For example, 1 plus 1 is not equal to 2. If you give 2 drugs, the A1C benefit of it is never additive. And when you add a third drug, 1 plus 1 is 1.6. 1 plus 1 plus 1 is only 1.8. But if you notice this next slide, you will see that the predicted A1C versus the observed A1C for some of these are actually higher than the predicted A1C. And that's simply because when you use them in combination, as I said, when metformin is used with the DPP-4, the GLP-1 reductions are higher. When you use an SGLT2 inhibitor with the DPP-4, the glucagon reductions are higher, right? So actually, some of them can increase the efficacy. Not by much, and if you see the studies, you won't see really too much. But certainly, the most important question is the efficacy not reduced? That's one part. Then are the adverse reactions lower? For example, you combine a DPP-4 and SGLT2 inhibitor, what happens? The incidence of genitourinary infections actually comes down. So it's a natural match, right? But the important question that we also need to ask is, are these components physically compatible? It's all right if they are given together, but when they're given in the same pill, will they destroy each other, right? Some of the problems with the immediate preparations metformin combinations is actually the lack of physical compatibility, but the sustained release seems to work. Does the one drug boost the action of the other? This is more in antibiotics. You'll find some drugs that boost the action of the trimethoprim, sulfamethoxazole, the same, boost the action. Some antivirals, it works. But what is important for us is there a pharmacokinetic match? For example, metformin is traditionally given after food, but when you combine it with the sulfonylurea, you're giving it before food. Some people tell you it's okay, but you'll find a higher incidence of adverse reactions. But when you use a sustained release metformin in the same formulation, that problem is taken away. You can take it a little later. Does it simplify therapy? That's an important question. If you give a drug, it should make a single drug once a day. So if you're using metformin and you're using a DPP-4 and you're using an SGLT2 inhibitor, if the metformin is an immediate release metformin, it doesn't make sense. So you want a sustained release metformin, you want a single daily dose. So if you're using a vildagliptin 50 milligrams, that's twice daily. You want a single daily dose of 100 milligrams of vildagliptin. You want an SGLT2 inhibitor that's used once a day. Therefore, the whole 3 is given once a day. So that simplifies the regimen. On the other hand, if you have to write another dose of metformin at night, that doesn't simplify the regimen. The next question is, will separate titration of the components be required? If you have to titrate them separately, then using a fixed dose combination doesn't make sense. That's when you get all these irrational prescriptions that you'll see. You'll see one combination in the morning, a metformin in the afternoon, another drug in the evening. That's because we've not thought through the combinations. The other important question is, will dose ratios change at different stages of the disease. For example, if you're using a DPP4 metformin SGLT2 combination, remember, if the eGFR is less than 45, the metformin dose needs to come down. So that population, you cannot use it. So some nuances are there when you use it, and when the industry creates it. So if you suddenly create a product for which there is no population, then it doesn't make any sense. And this is a big thing. Will the size of the product increase significantly? So I use a lot of, I'm a big fan of these triple dose combinations now that has metformin, the DPP4, the SGLT2. But I didn't realize it, that patients came back and told me, sir, do you know the size of that pill, sir? The metformin's giving it that volume. The sustained release metformin is huge, and the triple dose combination is big. So I said, but there are smaller preparations of metformin available, but not with this. So it's important to understand that each of these put a factor. I didn't find any of this in a book, so I put all of this together, and hopefully, we should write an article with this. But these are the things, the questions to ask. Is there a medical rationale? Does it address a population that will benefit by it? In hypertension, this has been fairly well solved. We know this. Are there lower adverse reactions? Are the components physically compatible? Is there a booster effect? The PK/PD compatible? That's very important. Does it simplify therapy? Will titration be required? And will different diseases change the ratio? And the ease alone is not enough. The size is important. Where do we use FDCs? Today, a lot of my patients, I start them on 1, 2, or 3 drugs. I don't. If somebody comes to you early in diabetes, your target is not 6.5, it's 6, it can be 5.6. And one drug never does that, right? So initiation can be a combination, it can be a fixed dose thing. Now you're on one drug, and the second drug automatically means that's 2 drugs. So an add-on can be a fixed dose combination. Then let's say you're on 2 drugs and you've taken it for a while, and the patient's comfortable, and you're sure that the therapeutic thing is right. Okay, let me make his life easy for him. Let me substitute it with a fixed dose combination. These are 3 positions where we use FDCs, right? The important thing is this. What else? When you combine drugs, are you trying to address different pathophysiologies? And that's a new phenomenon that people are talking about, right? For example, if you use, this is the egregious 11 that is a successor to the ominous octet. I'm sure now there is the tiresome 13 or the fabulous 14 or even the fantastic 15. But what it does is that different drugs have different pairs of actions, and does address more than one. So when you use a dapagliflozin and you use a DPP4, you're already addressing 2 different pathogenesis. And along with metformin, a 3rd one that works on each of these. And some of us use 4 drugs, a thiazolidine-dione on top of it. You really have something that addresses many things, and so they work well together. This is Gunny et al. That looked at initial triple combinations, and what they felt that the initial triple combination has greater benefit, and they used a glitazone, they used a DPP4, they used an SGLT2, showing that this actually works better than most of the others. Also remember that the first year of therapy is as important, and this is Kamlesh Kunti's data, but there's other data, but it shows that if your A1C is not, a reduction of A1C by 1% in the first year translates to a benefit at 5 years, and there was a Chicago paper that showed that it translates to a benefit at 20 years. So clearly, the first year is important. You want to hit it hard, you want to bring it down really nicely. Combinations get you down to target. Combinations do not increase hyperglycemia unless sulfonylureas are used. And at least a verified trial and other trials have shown that initial combinations increase durability of the drug. I won't get into this, I talked to you about. So I'll close up with SGLT2 and DPP4s. One, they have complementary mechanism of actions. They do different things. One brings up the glucagon, the other brings down the glucagon, so they actually work together. Together, they have low risk of hyperglycemia. Their drug interaction is low. In fact, they have some better benefits. They reduce the adverse events of the other. And seems to be a very rational combination. So the SGLT2 works mainly on the kidney, this mainly on the gut, but they all do things together as well. And interestingly, the important thing is, does the combination hurt? Now remember that individually DPP4 is a cardiac neutral. They may even be a little harmful because we know that the risk of heart failure is there. The SGLT2 protects against heart failure. We really don't have large studies on this, but here's an animal study that looked at vildagliptin with the DPP4 as a combination. So look at the infarct size, better with the dapagliflozin, but even more better with the dapagliflozin plus vildagliptin. Again, animal study. You're never going to get a really nice combination study looking at infarction and heart failure, but at least we know that it's not harmful. And this data just says that over a period of time it's cost effective, better, and delays insulinization, does a whole bunch of stuff. And showing that the A1C is lower, the glucose is lower, the blood pressure is lower, the LDL is lower. So to summarize, and I thought I'll stop here, but happy to take questions. The idea is FDCs are important. They are here to stay. They improve patient persistence. Unfortunately, we don't do good studies on them, and I think Sanjay is here, a lot of other people are here. Our real world studies need to get published on using, when we switch to FDCs, what happens. Our real world studies really will tell people whether A1Cs improve, outcomes improve, quality of life improves, adherence improves. So it's a big, and India is a big market for FDCs. This is where we need to do these studies, right? But what I've given you is a little thing to walk through whether an FDC is required. And when you sit on that ad board of those companies to recommend whether you're going to recommend that this FDC be brought in. So data on patient impact is sparse, but we know that patients really like it. With this, thank you so much for your time and patience. So can you speak up? I can't hear you. Yeah.
Is there any rationale in combining sulfonylurea like glimepiride and DPP4?
So, in a single drug.
Yeah.
So we know that that both of these work very well as add-ons, right? And the way the unfortunate problem on sulfonylureas is that the dose needs to be titrated. For example, using glimepiride, it's 1, then 2, then 3, then 4, right? Yeah. Or if it is glycoside, it is 30 or 60 or 80, whatever you use. So there, it somewhat hurts unless you have multiple doses. On the other hand, when do you use a sulfonylurea DPP4 cutoff? Either using it initially, FDC. So instead of doing that initially, you get to the titrated dose, and then you're adding the DPP4. If you have a fixed high-dose sulfonylurea plus a DPP4 combination, it will work well. This is what I meant by titratable. Otherwise, the company has to bring in 4 combinations of a DPP4 with sulfonylurea, right? Otherwise, what will you do? I'll do 1 milligram of glimepiride, 100 milligrams of sitagliptin, and then I will add another 2 milligrams of glimepiride. So, in my view, that's not a great way to combine.
Thank you.
One question.
Yes.
So, you were mentioning about the fixed dose combination, especially glimepiride and metformin. So, as you mentioned that we usually give glimepiride before meals and metformin after. So, how do we...
So that's really why it was struck down. I don't know if you saw the number of drugs with the glimepiride metformin combination that was struck out. So the smart thing to do with this is, let us say you're starting the patient on metformin, and you've added glimepiride, and you've reached a titratable dose, and let's say that has a FDC, then use it. So for example, you have a 4 milligram glimepiride with 1 gram of metformin sustained release. That's a great way to use it. Otherwise, you have to have 4 doses of glimepiride plus metformin, glimepiride plus metformin, glimepiride plus metformin. See, if you're using a sustained release, it really doesn't matter. Give it before meals because the sulfonylurea works well when it's before meals. Metformin also works well before meals, right? But the reason we don't use it before meals is because of GI toxicity. So, unfortunately, you have to go with the SU because the SU action is a meal-based action. Oh yes, and that's another combination. So see, this is where, Our own, we should also be leaders in doing this. This doesn't make sense, correct? Yeah, there is a combination. Sulfonylurea, metformin plus voglibose is a combination, correct? But unless titrated, does it make any sense? To me, it doesn't, because it confuses the patient. So what people do is end up doing, and you'll see these prescriptions always, is you'll have a drug like this, you would have started one dose, and then you'll add another sulfonylurea in the afternoon. I'm sure you've seen these prescriptions, right? And that's why when it's titratable, get it to a titrated dose that you really want, and then if there is an FDC, substitute it. Otherwise, stay off it. Thank you so much. Really appreciate it.
Thank you, Dr. Seshadri sir. I request the chairperson to hand over a memento to Dr. Seshadri.
Thank you, speakers, for giving such valuable information. To go further, ladies and gentlemen, please welcome our chairpersons, Dr. Vikram Kolhari and Dr. Sagar Biradar.
The speaker for the next talk will be Dr. K.N. Manohar. He will be speaking on combination therapy for holistic and cardiorenal metabolic protection.
Hello everyone, and at the outset, I would like to thank LSM for giving me this opportunity and also placing this talk immediately after a prolific speaker who has spoken almost everything what we need to know. And I'll be talking about on similar counts, but with a slightly different angle of how can we converge this gluco, cardio, and renocentric management in diabetes. The crux of the talk will boil down to the use of a combination pill as a single pill. So I'm sure everyone were enlightened with what Professor Seshadri has already told us. And he also mentioned about the size of the tablet, which is very, very important, especially 1000 XRs. People find it difficult to swallow. But this combination, what I will talk, could be kept aside, and we can titrate with the glimepiride or any other doses what we can do. So that's one small advantage what we have. Another thing what I wanted to make is, sometimes we write 4, 5, 6 medications, and sometimes the patient decides to leave 1 or 2. But if you are managing with only one drug, and which is a combination of these 3, and the patient decides to omit it, then also I've seen this happening in my practice, and it is a big loss that they have not taken 3 medicines to be used. So we all know about this. Cardiovascular, renal, and metabolic condition pose a high disease burden globally. And the common soil hypothesis, what we talk about it, diabetes, obesity, inflammation as the base, and then it contributes to all of these comorbidities or multimorbidities, causing complications and worsening the cardiovascular risk for a diabetic patient. And of course, the prevalence of diabetes is rising, and so the risk of these complications are on the higher side. So they always coexist, and 40% of our diabetes, if you really look seriously into, have some amount of CKD. It could just be sometimes proteinuria, which we neglect or don't look at the microalbumin creatinine ratio. So always important to look at that and calculate your eGFRs. And 1 in 3 people with diabetes have CV disease. So 40% have renal, and 30% have cardiovascular disease, and 20 to 40% of people have heart failure also. So that's why we always talk in all these forums that diabetes management should move away from being glucocentric to reducing the cardiovascular, renal, metabolic risk reduction. So sometimes we were trying to see if the nomenclature also has to change, because as the doctors we may realize that, But as patients, why are you giving so many medicines? You're saying you're protecting the kidney, heart, and let's look at the glucose itself. So that's one thought we get it. And of course, all are multifactorial intervention, because pathogenesis he showed clearly from octet to now people talk about dirty dozen in diabetes. So which all pathways would you really target it? And if you're targeting it, it can't be one drug. It has to be combinations, which will also help in reducing the side effect profile and improving the compliance, and of course cost effectiveness. These are the three main things what we look at when we use this combination therapy. Otherwise, there is no great science behind putting these combinations, but these three things are equally or even more important. The drug may be good if it is unaffordable, or if it is too many drugs and patient is not taking, but just improving the compliance, you can reduce the mortality, morbidity. So that is the point, the single most important message what we are trying to drive in this talk. And we all know, we always equated diabetes to coronary artery disease. It got a bit into controversy, and then we have resized. But of course, always the cardiovascular risks are much, much higher in a diabetic as compared to non-diabetic. So if you look at what is happening in the real world, the sir was telling about we should have a good real world data, but if you look at our Dr. V. Mohan's ICMR INDIAB study, where we saw that only about 1/3 of our patients are under A1C target. If you want to add lipids and blood pressure also to look at how many of them are in target, it will be in single digit. So that's where we need to, as much as conferences, to enlighten about the new molecule, just to get back to our patients and enhance and reinforce compliance becomes as much or more important. Well, we all know this story, isn't it? It was always LSM first, lifestyle modification, then add a drug, then you add another one, then you add another one, then you think of insulin, discuss. So as you can see, as we keep waiting for that, we are losing a lot of time. So this was the initial approach where to start with a drug and add another drug, but how much time are we losing it? If you want to start insulin, many of the data says 7 to 8 years is the lag period, if you, the time you think that it is needed and the time actually we add it. Of course, newer guidelines have moved away from this hypothesis, mainly because of this data from UKPDS, where it showed and reinforced and re-emphasized what is called as the legacy effect. Early diabetic, especially young, go aggressive, hit hard. You may lose them after some time, but in spite of that, the metabolic memory of initial good control takes them to have a much lesser cardiovascular risk, complications, and so on, even when they are beyond 5 years or 8 years of into diabetes management, but they are not as good control as it was done initially. So this is one of the big selling points. It's like a studious student who studies from day one and not cramping at the end. After there is a complication, there's no point doing it. So if someone is studying very well from initially, he will do very well later in his exams, isn't it? So it's as simple as that of about legacy effect. And that's why what we are trying to put forward here is using combination therapies, trying to hit hard, especially with the combination having least risk of hypoglycemia. This will be a great advantage for us. So the Discover study insights, what did it say? From early intensification to late intensification, whether you look at the patient at 6 months or 36 months, always they fare better. They are the studious type of students who are focused from day one, rather than the last minute people who study. Some of us are like that, but then if you really look at the risk and the pressure what we go through in the last minute is always higher. So initiate a combination therapy. This is another message. Of course, the guidelines have changed, the ADA and even the RSSDA has adopted it. If someone's HbA1c target is beyond 1.5, 2, someone comes with 9 or 10, starting him on lifestyle and only one drug is no way going to achieve the target, even if we do the fullest, isn't it? So that is a simple logic. And then again, they've broken down into if someone's heart disease is an issue, renal disease is an issue, cost is an issue, or hypoglycemia is an issue. So if someone comes with 9.5 HbA1c, no point trying to give him only on metformin, or even if you think he has higher CV risk, to just put him on enagliflozin and send him back. So there, again, the emphasis is early combination therapy. And we all know this benefits of tight control. All the complications risk comes down, morbidity, mortality improves. And from what it was from 1990 to 2007, after 30 years of treatment, that's what reinforces the legacy effect. The first half of people who were treated early aggressive treatment still had a morbidity, mortality advantage even when they were off this tight lens and their sugars were not as great as controlled as before. So why should it happen? Yeah, we all know when we started MBBS, there were only two mechanisms: insulin resistance, insulin deficiency for type 2 diabetes. We kept adding, and we talk about omnious octate, up to dirty dozen, up to 24 mechanisms have been proposed. So no one drug could fit all the pathways. But we know also in practice that some people fare better to some type of drugs. Like in some people, DPP-4 may not be working well. In some people, SGLT2 may not be working well. So my own hypothesis there is maybe someone has a dominant arm. So if DPP-4 defect is a dominant arm, and if you address it, they will do well. And if DPP-4 defect is not a dominant arm, many people we remove initially, especially when the gliptins were launched, we have seen this mechanism, and then definitely. So that is one way. So it is always prudent to use multiple pathways so that the dosage of the drug also could be come down, and most importantly, the adherence improves. So just by improving the adherence, we can reduce the mortality. Because just by improving the adherence, it can improve the A1C reduction by 1%. So these are very, very important points. As much as the science, the practice, the art of medicines, trying to re-emphasize what drug to be used and what combinations helps better is for all of us to understand and implement. So the poor adherence translates to an increased risk of hospitalization and all-cause mortality. It is not just a saying, but it is a data which we have looked at it, and about 40% increased risk of all-cause mortality just merely due to poor adherence. This has also been shown in statin studies also, where we have seen people who were not using statin regularly had a higher risk of cardiovascular disease. So emphasize adherence to all of your patients. Pill burden. Again, the last talk they were saying glimepiride before meal, voglibose with meal, metformin preferably after. So we know by combining these three things, our science goes for a bit of a toss. But if you have to choose between science and adherence and the improvement in the morbidity and mortality, somewhere we need to look at this balance very well and then opt it for it, because the mere increase in the number of tablets and the rigidity with which we say, because it's not one time or a few days, isn't it? It's a lifelong affair. How many times they will sit in front of the plate, have the first morsel and swallow one of the tablets, and the remaining before or after that. So those things should be kept in our mind. And this is what I was saying, breaking the cycle of failure. Starting one and adding one is wasting a lot of time, and we need to look at and try and target multiple pathogenic mechanisms by using a single drug in combination. So what does it benefit? It will have a robust lowering of HbA1c. Clinical inertia is a very big important topic where we all understand the relevance of the discussion topic, but we don't somehow put it into practice and make the things happen. That is inertia for all of us. And early combination therapy, especially when we use the set combination of gliptin, gliflozin, and metformin, can give beta cell rest and potential to use less than maximal dose. And sometimes some side effects get nullified. It was beautifully explained in the previous talk also. DPP-4 inhibitor being added with SGLT2 inhibitors can reduce the risk of euglycemic DKA and minimize the risk of genitourinary tract infection. I was a part of that study, the Genius study, where we saw when we started together the combination, the risk of genitourinary tract infection is much lower rather than adding DPP-4 and then adding sequentially. So even starting together, if not sequentially, also makes a lot of difference for the prescription. So complementary glucose lowering activity, especially when you talk about non-insulin dependent mechanism of action, get the good glycemic control, reduce risk of hypoglycemia, reduce risk of weight gain, or even promote weight loss, and with the innumerable CV benefits, especially from SGLT2 inhibitors and CV neutrality from DPP-4 inhibitors and renal benefits, we should keep all these things in mind, and this is a good yes for using this sort of a combination in the management. So how does it act? I think this has been already alluded. Metformin, for most often than not, it is used as a first-line therapy. There is a small slide which questions the utility, and now I think sooner or later we will try and see whether any other drug could be put it as a first-line therapy. Dapagliflozin, we all know the mechanism of action, and more importantly, it started as a drug for diabetics. Now we use it in non-diabetics, being tried in type 1 diabetes. That is the wealth of evidence which is generated. So it's a great combination. Sitagliptin, of course, one of the largest CV outcome trials, especially after the heart failure signals were given by saxagliptin, reassured us that it is CV neutral. So these combinations, are they just bringing into the market without any evidence? It can't be. So this was a study which was done by using this combination from visit 1 to visit 8 over a period of 18 weeks. And what they looked at is the adult population on maximum tolerated dose of metformin after a run-in period. One group had FDC of dapagliflozin, sitagliptin, metformin combination, and the other had sita and metformin. The other one had dapa and metformin. Of course, so one had all the three drugs, the other two had DPP-4 or SGLT2 inhibitor, with metformin being the common denominator. So no great prizes for guessing. Of course, the triple combination definitely did well because of glycemic efficacy and 1.73 or 1.8 reduction in the HbA1c as compared to the other two groups. And of course, more number of patients achieved the set target of less than 7%. When you look at the bar graph there, for triple combinations by week 16, many of them started achieving the HbA1c level. So this is the question which was posing: should metformin be the first line of therapy in any case? And we always have been using, first it was abandoned, then we accepted it and we made it number one. And of course, to ask for a independent CV outcome trials or renal outcome trials is too much to ask for now. So with the wealth of evidence what SGLT2 inhibitors have been throwing it at us, they have not become useful not only for diabetic but even in non-diabetic patients. So not as great as it sounds is the opinion echoed with respect to the use of metformin as a first-line drug in all cases. Of course, many a times we see HbA1c above 1.5 to 2 as a target, so then we need to use the combinations. So again, I think this was alluded nicely by the previous two speakers, Alok Modi and Dr. Krishna Sheshadri. I won't rush. Published SGLT2 and the DPP4 data. Of course, most of the time the DPP4 had neutrality, CV neutrality, and of course SGLT2 inhibitors, cardiovascular and renal benefits are profound. Don't go by the numbers, what is different with EMPA-REG, CANVAS and DECLARE or VERTIS, because most of it, especially the hospitalization due to heart failure, is a class effect. Everyone does well. Based on the population chosen, the percentage of benefit could be different. For example, EMPA-REG showed very, very high risk individuals. So the degree of benefit, what they got in the trial, if you can look at it, I don't know, the pointer is not working. So it could be much higher by numerically, but the subset of patients what was chosen also should be kept in mind. So it's safe to say that CV out hospitalization due to heart failure all do equally well, except for maybe L2, gliflozin didn't do as well. But mortality, morbidity, more or less, we agree that SGLT2 inhibitors are beneficial. So this all data translates into the guidelines, what we see. So don't treat the patients just everyone as the same. Look at the A1C, look at the risk profile of the patient. Is heart failure an issue? Kidney disease is an issue, cost is an issue, hypoglycemia is an issue, and make your combinations. And of course, there are no dearth of combinations in our country. Any combination you name, we have it, and we can go about by that. And don't forget the legacy effect. So again, coming back to the slide, there are multiple pathogenic mechanisms in type 2 diabetes. We can't expect a single drug, but when you use the metformin, DPP4 and GLP-1 receptor agonist, we cover many of the mechanisms for the omnious actate, what is been described, and sometimes pioglitazone, if you add, all the things will be taken care of. So where do I use these combinations? Can I initiate with these combinations? Yes, if the A1C is more than 9, we can initiate with this combination, or someone is on metformin or metformin and DPP4 inhibitor, and you can explain them that tablet pill is a bit bigger than usual, but if you miss it also it is a problem. Even that we need to emphasize onto the patients, and we can move on. If they are already on DPP4 plus metformin or SGLT2 plus metformin, you can increase it to this combination therapy. So to conclude, most clinical guidelines advocate an individualized approach. We should look at the A1C and also the risk profile of the patients. The triple combination of SGLT2, DPP4, metformin is a great combination. Of course, this combination doesn't require much of titrations as we were discussing in the previous talk. It improves definitely adherence. It is cost effective. And this is also suitable in established atherosclerotic cardiovascular disease, established heart failure or CKD, but as the previous speaker alluded, look at the EGFR. Not for all CKD, this combination has to be used. Thank you very much for the patient listening.
Life care. That was a wonderful talk, sir. Next, we move on to the next topic, importance of preventive cardiology in current era by Dr. Rajesh Rajput. Now we'd like to give the memento.
Rajesh Rajput. Hey. Yeah, it's coming. Okay. So, good morning, friends. Well, I am going to have a paradigm shift. I am going to discuss actually a different approach regarding cardiometabolic disorders. And at the onset, I would like to thank Srinivas for inviting me for this meeting. And my job is basically preventive cardiometabolic approach. In India, we are sitting on a time bomb. We always talk about treatment. Now, it is better to prevent rather than to treat, and this has been taught to all of us in medical schools, but unfortunately in real world that is not practiced. So I'm going to briefly give you this concept, and as has been told to me by the organizers, I have to finish 2 minutes earlier because he has to save some time. So moving forward, we know there is an exponential advancement in field of interventional cardiology. Our colleagues are doing excellent. But does that has resulted in reduction in cardiovascular mortality and morbidity? Answer is no. And why this is not happening? If we see the soil on which cardiovascular disease mortality and morbidity is increasing, these are the 3 big risk factors: prevalence of overweight and obesity, prevalence of diabetes, prevalence of metabolic syndrome, which is clustering of various metabolic risk. And these have increased exponentially in our country, Southeast Asia, across the globe. And probably that is one reason that we are not able to reduce morbidity and mortality associated with cardiovascular disease. And that is why Asian Society of Preventive Cardiology has given this statement. And this is very important statement, that preventive cardiometabolic approach is a proactive patient-centered approach in which, and this is very important, clinician, a team of clinician or a non-clinician from community medicine. Probably we need a team to find out a comprehensive strategy to evaluate such patient and to find out them at an earlier stage. Now, whenever we talk about prevention, there are 3 levels of prevention, and I hope we remember our medical school teaching. There is a primordial prevention, there is a primary prevention, and there is a secondary prevention. What is primordial prevention? Primordial prevention is prevention of development of risk factors. Now, it is very easy to say. For that, we need lot of social changes. We need policies at the level of government, at the level of schools, so that good habits to be inculcated right at the school stage,
so that minimum degree of risk factors should develop. So primordial approach is a good way to talk about, but actually it is a long dream for this to come into true in real world practice. So therefore, primordial approach should begin right after the birth, which means changing the societal pattern, how we are living nowadays. What is important is primary prevention. Primary prevention is patient has developed risk factors, but then we have to prevent development of cardiometabolic disorders. And for that, we have to remember life essential 8. Now, these are life essential 8, and if we are able to maintain these life essential 8s within the target, probably we will be able to achieve primary prevention at least, which is not as difficult as achieving primordial prevention. And what are these 8? Nicotine exposure. Answer, it should be 0. Body mass index, it may be less than 25. Somebody may argue for Asian Indians, for us, it may be less than 22, which is very difficult to actually achieve and maintain, considering that we are living in an environment which is an obesogenic environment. We eat even when we does not have hunger pangs. We nowadays eat by time. Yesterday night, we have a wonderful night where people finished their meal by 12 o'clock in the night, got up early in the morning and have gone to the breakfast because it's breakfast time. They have not listened to their stomach that it is not needed, please do not eat. So that is actually need of the hour, that we should eat by brain, not eat by time. So physical activity, 150 minutes, standard recommendation, we have to incorporate diet, blood lipids, and nowadays we have moved from HDL to non-HDL target, from LDL to non-HDL, which incorporate all ApoB proteins. It should be less than 130. Blood pressure targets, blood glucose targets, and healthy sleep, which is very important. 6 to 8 hours of sleep a day, which is very important for restoration of our all body functions. So this is golden 8, and if we are able to achieve this, you know what is you are going to do? Longer survival, at least more than 11 years in men, and at least more than 8 years in women. Apart from that, with these healthy 8 metrics, there is a substantial reduction in various cardiometabolic complications. So primary prevention is, we can achieve it, but we have to remember this important 8 metrics, and we should give it to our patients. Then comes secondary prevention. Patient has developed a disease. Now we have to prevent development of the second episode. That is a secondary approach, and what we are talking from the morning. So we now have wonderful drugs available to us, and if patient has developed a cardiovascular disease, remember within next 5 years, chances of recurrent myocardial infarction, stroke, heart failure, or cardiovascular death is 20 to 30%. And in a given patient, it may be more than 50% if that patient is having polyvascular disease, which means disease present in more than 2 vascular beds. If it is there, it is more than 50% chance that this patient in next 5 years will not be among us. So we have to understand the importance of all 3 levels of prevention at which we are seeing. These are standard risk factors which are given by Framingham Heart Study. We will come to it. Cigarette smoking, high cholesterol, blood pressure, obesity, physical activity, and type 2 diabetes. But then it has been seen a new thing, that CKD, which is less than eGFR less than 60, or presence of microalbuminuria, huge population is having CKD. We have done a study, which is a pan-India study, involved more than 30 centers, recruited more than 3,000 patients, and we have 3,000 eligible patients. These are type 2 diabetic patients who does not know that they are having CKD. Both eGFR and microalbumin has been assessed, and you know 48.4% prevalence of CKD in our type 2 diabetic patient who does not know that they are having CKD. And once patient develop a CKD, the next 5 year chances of developing a cardiovascular complication is very high. So again, an undetected problem. Lastly, thrombotic risk, aspirin. I do not know how many of you are nowadays writing aspirin for primary prevention. Virtually it is out. For more than 60 years of age, primary prevention, aspirin is not to be given because risk of hemorrhage is more than the preventing the ischemic. Only in patient of 40 to 59, if risk is more than the benefit is more than the risk, we can give in a select patient. So it has a sea change. Aspirin is no longer, but then a new thing has come up, which again I will show the new guideline, coronary artery calcium. If a patient has a coronary artery calcium more than or equal to 100, probably it makes a case where aspirin as a preventive measure can be used in a subset of patients. There are many risk calculators available in our country, in the world, and this is a wonderful study which actually assessed various risk calculator like Framingham risk calculator, Joint British Society risk calculator, ASCVD risk calculator, which predict best for us, for in our country. It is very important what risk calculator we are using. And in this study, it has been shown that Framingham risk scoring CVD risk calculator is probably the best for Asian Indians. And how to use it? It is available online. You can download the app. It is very simple. Step 1, depending on these parameters, age, HDL, total cholesterol, systolic blood pressure, smoker, diabetes, you put down and it will give a total score. Then the step 2, using step 2, you will have a total score and then you will determine your 10-year cardiovascular risk. This is for risk stratification. And then on the other panel, at the same time, when you put down the score, you will have your heart age. What is your biological age? It will be different from your heart age. So that is how we should use this Framingham risk calculator, and then based on the risk, we can have high risk individual, intermediate and low risk individual, that is score less than 10%, between 10 to 19% is an intermediate risk, and more than 20% high risk individuals. So therefore, friends, what are our primary and secondary prevention guideline, which is my topic, that preventive cardiometabolic approach? We have to understand for primordial prevention, lifestyle intervention, which is easier to say, difficult to practice, but things will change over the time if we practice. For primary prevention, aggressive control of blood pressure, cholesterol, glucose, obesity, which is your body mass, and smoking pattern, and then we have different drugs. This is a busy, complicated slide, and to save some time as he is sitting there, I will not go through this slide. But as you see very clearly, when you see your patient with, stratify them based on the investigation. What is the baseline LDL cholesterol? If patient is diabetic, between 40 to 75 years of age, whether risk is high or risk is low, and then in a non-diabetic individual, using risk factor, 10-year ASCVD risk score, and then low risk, borderline, intermediate and high risk, and that is how we are going to decide about our targets. So although this is a busy looking slide, these are standard risk factors, but as I have told you, this we should adopt more and more in our all patients, irrespective of the specialty we are practicing, when such a patient is coming to us. And why it is important? If you see, if you change the diet change alone is going to bring probably the biggest change in the risk factor for various cardiometabolic disorders. And why I am saying so, if you see regular physical activity, it has psychological benefits. There is reduced stress, reduced depression, anti-arrhythmic effect, because with increasing physical activity, you tame down your sympathetic nervous system. There is upregulation of parasympathetic nervous system. Your heart rate comes down. Your heart rate variability changes. You have an anti-thrombotic benefit. You have an anti-atherosclerotic and anti-ischemic benefits. So simple adopting regular healthy lifestyle, which include diet and exercise, is more beneficial actually than any of the drug available in this world actually. But this has to be practiced regularly. The benefit of exercise is short-lived. So if you have done a very good exercise for 10 days and then for next 10 days you are not doing anything, you will lose all the benefits which body has tried to gain out of doing this exercise regularly. Coming to primary prevention, that is cholesterol, which is one of the very strong surrogate marker for future development of cardiovascular disease. There is one bigger trial in primary prevention setting, that is Jupiter trial. Rest all are secondary prevention. In this Jupiter trial, patient who does not have a cardiovascular disease, whose hsCRP is more than 2 milligram per deciliter, they were given rosuvastatin and future cardiovascular risk were assessed. And it has been seen that with 50% reduction in LDL cholesterol level, irrespective of your baseline cholesterol, what it has resulted, 44% reduction in primary endpoint for all vascular events. And why this? Because fatty streaks start developing even at 10 years of age. And in a given ethnicity, it may be accelerated. So this is a wonderful study which has shown that rosuvastatin is beneficial, and Jupiter and Prove-It-Timmy actually have shown the link between inflammation, cardiometabolic disorders, including cardiovascular disease and diabetes. So 2019, AAH study has recommended that in those with an hsCRP of more than 2 milligram per deciliter, even if they does not have any cardiovascular disease, it makes a case for using statin therapy as a primary preventive. This is very recent, even not published. This is a pre-press which we have done throughout the country. We as a group, we have developed an updated Lipid Association of India guideline for management of lipid disorders in Indian patient. So this is an updated version of what we have published in 2016. Now in this, for the first time, we have shown an extreme high risk group. What is extreme high risk group? Category A and B, which include presence of ASCVD with more than one of the higher risk. Again, this is a wonderful table. You can take a pick, or even this is going to be published next week. This is how we should classify our patients into low risk, moderate risk, high risk, and very high risk. And our society has recommended that in extreme high risk individual, we can even target LDL cholesterol to less than 30 milligrams per deciliter. If we see worldwide recommendations for various lipids, LDL cholesterol, right from American Society, European Society, and LI, which I'm saying new is coming in 2024. It is just going to be published. Already we have recommended in very high risk ASCVD less than 50 and extreme risk less than 30, which means polyvascular disease. So at least remember less than 70 and less than 50 if less than 30 is not practiced. But we have already recommended that in polyvascular disease, when you have vascular disease in more than 2 vascular beds, they are at a very high risk of developing future cardiovascular events. So therefore, probably it makes a case even to go down. Coming to blood pressure control, again, very easy to speak, but very difficult to achieve. Majority of patients who are having diabetes, they need more than 2 drugs actually to bring blood pressure into the target range. Unfortunately, even 3 drugs might be needed, and at that time, judicious use of diuretic is warranted, apart from use of what drugs we are using. Not only that, but we have seen in endocrine practice that large number of people who are having uncontrolled hypertension, endocrine causes of hypertension are not picked up. There are 2 big causes of uncontrolled hypertension, or so-called secondary hypertension or resistant hypertension. One is undetected kidney disease, which we have shown you the data. Second is undetected endocrine disorders. There are at least 12 different endocrine disorders which are responsible for uncontrolled hypertension. So therefore, bringing blood pressure into control. Control of diabetes, we will not discuss. Already Manohar and all the colleagues have discussed that for diabetes, we know metformin, SGLT2, GLP-1RA. Until and unless contraindicated because of cost reasons or because of some side effects or other reasons, these 3 drugs primarily now should be used in all diabetic patients: metformin, SGLT2 inhibitor, and GLP-1 receptor AGA. Which you are going to use, I leave it to you. I am not going to say that one drug is better than the other. There is an umbrella effect largely on major outcome parameters. So choose according to your wisdom. Now coming to CKD, which I have told you, again SGLT2 are the drugs which have shown a significant decline, 44% relative risk reduction in composite outcome of decline in EGFR, progression to ESRD or renal death, and 29% reduction in CV death or heart failure. Therefore, again, as we have shown in our own study, 48.4% have undetected renal disease, even if you are missing. But even by default, if you are using SGLT2 inhibitor, you are actually benefiting those group of patients. And lastly, thrombotic risk. I have told you, for primary prevention, aspirin nowadays has a limited role. But there is no controversy, there is no doubt. Once patient develop a cardiovascular disease, aspirin is the cornerstone. But then there is also a concept of DAPT, dual antiplatelet therapy. Patient undergoing intervention, patient at high risk, have diabetes, more than 2 atherosclerotic cardiovascular disease, a single antiplatelet agent is not going to do the justice. We need dual antiplatelet agents. How long to give is a big controversy. Conventionally, it has been taught that if patient has undergone a cardiac intervention, not more than 1 year of dual antiplatelet agent is given. But Pegasus TIMI 54 trial, Pegasus TIMI 54 trial has clearly shown that those patients who have developed an acute myocardial infarction, who have been given dual antiplatelet therapy, aspirin, clopidogrel for 1 year, and then they have stopped. They have reclassified and they have given them a combination of ticagrelol and aspirin. So the dual antiplatelet even given for next 3 years substantially fare better in these high risk group individual as compared to low risk. So if your patient is at a high risk of future cardiovascular event, if they have a polyvascular disease, continuing dual antiplatelet therapy for more than 1 year makes the case. Another very important message from Pegasus TIMI 54 trial is, what is a conventional dose for ticagrelol? It is 90 milligram twice a day. In this study, they have studied both 90 milligram twice a day and 60 milligram twice a day after 1 year. And it has been shown that even at a reduced dosage of 60 milligram twice a day, benefit in ischemic risk reduction is considerable. There is 34% relative risk reduction in CV mortality, which translates into absolute risk reduction of 1.1% and 21% risk reduction in CV death, MI or stroke. So benefit is seen even with the lower dosage of dual antiplatelet agent, which is 60 milligram twice a day. So friends, if I summarize, in this preventive cardiometabolic approach, I have tried to tell you about unmet need. We will not go through this slide to save some time. I have told you about various risk factors which are seen commonly in our patients, and based on this, there are 3 approaches: primordial prevention, primary prevention, and secondary prevention. Primordial prevention largely is a societal approach. Society has to change, government policies has to change, what food is coming, food packaging, labeling, all those things have to be seen. So it's a policy making decisions. But primary prevention and secondary prevention at least lies in the hands of physicians. So we have to understand that in our patients, we should have an aggressive approach toward primary prevention of future development of cardiovascular diseases. Thank you very much. Absolutely exceed.
Rajesh, just a minute, I'm here. So I just want that aspirin as per ASCVD risk score. I mean, when to use it.
Right.
That's a confusing, because what happened with coronary calcium score more than 100, it's very clear that for primary prevention you should use. Because each and every patient may not go for calcium scoring. We normally use either QRISK or ASCVD risk score. At which risk score for 10 years they should be given?
Okay. So if a patient age is more than 60 years of age, because as we ages, the risk of bleeding complication increases exponentially. There is no role of primary prevention for aspirin at any risk factor. This is very clear nowadays in current recommendations. For those between 40 to 59 years of age, we should calculate the risk. And if the risk is more than 20%, if patient is having more than 2 atherosclerotic cardiovascular risk factor present, then probably it makes a case that in those select patients, we can use aspirin, and the dose recommended is 75 to 100 milligram. Precisely, it is 81 milligram. 81 milligram is not available in our country, so either 75 or 100 milligram. So this is only subgroup.
But Rajesh, it will create more confusion. Suppose you have started somebody at the age of 55, just considering the risk factor.
Yes.
And now he had crossed after 5 years, he had come back to you, now he's 60. And
We will continue with aspirin.
So whether what you will do,
we will
whether
continue
you
with
continue
aspirin.
or you will not do it.
No, we will continue. There is no confusion in it.
No, because after
we
the
are
60
telling,
you should not start.
No. You try to understand what we are saying. Somebody coming to you for the first visit, the age is more than 60 years of age. In that patient, we are not going to initiate. This is like how we are going to modify doses of metformin. Doses of metformin when eGFR is less than 45. For a new prescription of metformin, we know that the dosage is this. But patient who is already stable on dosage of metformin, we does not change the dosage of metformin. Similarly, if somebody where we have started ecosprin at an age of 55, this drug has given him prevention because he is at an exponentially higher risk. So the drug has given him the prevention for next 5 years. So it does not make a case that today it is his birthday at 60 years, so we will stop. We will not do that.
And what about the clopidogrel as a primary prevention?
Right. Clopidogrel has no role in primary prevention. There is only one trial.
Is having aspirin bleeding.
There is only one trial. Actually, there is a dearth of trial. These are common clinical questions. There is only one clinical trial which have head-on compared aspirin with clopidogrel. But then the trial is so small, and in that trial I am telling you, clopidogrel fared better than aspirin. But unfortunately, the trial is so small that it can never come into the guidelines. So what is currently recommended? Those who are aspirin intolerant, there we can use clopidogrel / even ticagrelol. The difference between clopidogrel and ticagrelol is that clopidogrel is a prodrug. It causes irreversible inhibition of platelet. In contrast, ticagrelol is an active drug. It causes reversible inhibition. It causes faster onset of action. So there are some advantages and disadvantages, but currently considering the other things, if patient is aspirin intolerant, then we can use either clopidogrel or ticagrelol. Absolutely. Anybody who has gone any surgery, any bleeding risk, and there is an HES-blood score. HES-blood score is again available online. So say patient is having atrial fibrillation at an age of 40 years. We have to actually prescribe him anticoagulant drugs, not aspirin, not antiplatelet. So basically, whenever we are prescribing dual antiplatelet agent, or nowadays we have triple. Triple means 2 antiplatelet and 1 anticoagulant. We have to calculate the baseline bleeding risk, which can be done through HES-blood score. If the bleeding risk is more, then probably it does not make a case, to, as you are saying, to use these combinations.
And PT-INR, how frequently we have to do?
Pardon?
PT-INR for these patients.
Sir, PT-INR has no role for antiplatelet therapy. It does not. PT-INR is used when we are using anticoagulant therapy. We are here talking of antiplatelet therapy. When we are using anticoagulant therapy, say warfarin, say newer type of DOACs like rivaroxaban, apixaban, then PT-INR actually is not done. For warfarin only we do. For these type, we assess factor 10 activity. So PT-INR routinely.
This 75 milligram and.
सर जी PT-INR नहीं करते प्लेटलेट थेरेपी के लिए. PT-INR नहीं मेजर करते. There are new ways to assess platelet activity which are not commercially available easily. In future, when they will be available, we are moving into a new direction where we are going to classify a patient, what is a platelet aggressibility in this individual. If that is proved, then it probably makes a case for aggressive antiplatelet. And please do not use PT-INR for antiplatelet therapy. Welcome. Thank you very much.
Thank you, Dr. Rajesh Rajput, for sharing such wonderful information.
श्रीनिवास फोटो तो खींच ले। अच्छा थैंक यू भाई, थैंक यू।
Thank you, Chairpersons Dr. Vikram Kolhari and Sagar Biradar. To move further, ladies and gentlemen, please join me in extending a warm welcome to our Chairpersons, Dr. B.S. Nagaraj and Dr. Jayalakshmi.
Speaker for this session will be Dr. Melinda George. I would like to request the chairpersons to introduce the speaker.
The next, after a series of talks about the oral diabetic drugs, we're now moving to the insulin section. So the role of degludec and its co-formulation in therapy, the diabetes therapy. And to speak on this, we have Dr. Melinda George. Ma'am, over to you.
Thank you, ma'am. At the outset, let me thank Dr. Srinivas Murthy for this opportunity. And sir has already told me that we are running late, so I will try and keep my talk as short as possible. So today we will discuss about the role of degludec and idacaspat, which is its co-formulation in tailoring diabetes therapy. This is my disclosure. This session has been sponsored by Novo, and the slides have also been made by the Novo team. So we will look at both degludec and idacaspat and what its clinical attributes are. So we'll start off with the case. This is Mr. Ajit, a 50-year-old engineer who's had diabetes for the last 11 years, and you can see that his A1C is around 8.8%. He's also obese with a BMI of 27. If you look at his glucose parameters, his fasting glucose is around 188, and the postprandial excursion of 218, which means the difference between the two is not that high. He's also experienced hypoglycemia in the past, which means he's a little reluctant if you mention the word insulin to him. Otherwise, his blood pressure is decently well controlled. His dyslipidemia is not optimized yet. He also seems to have reduced EGFR with elevated albumin excretion, which puts him at high risk. And he also has history of alcohol intake. But otherwise, hypertension and dyslipidemia, again, therapy is not optimized. If you look at his treatment history, with regards to the anti-diabetic therapy, he is already on 2 grams of metformin, 25 milligrams of empagliflozin, and 1.8 milligrams of liraglutide. So he's sort of optimized all the non-insulin options that's available to him in a patient who is at high risk for developing a cardiovascular disease. So what are the challenges remaining that we have? There is uncontrolled hyperglycemia that we need to adjust. And patient has already experienced one episode of hypoglycemia, which means he's a bit reluctant to initiate insulin because there's significant fear of hypoglycemia. And the patient also has a fairly erratic lifestyle. He travels a lot, his meal time is not fixed. So all of these are challenges when you counsel the patient and tell them that you have to initiate on insulin. So which insulin would be ideal in this scenario in this patient? So if you look at the ADA 2024 guidelines, as you come further down, once a patient is ready for injectable therapy, always the first drug of choice recommended is GLP-1 receptor agonist, and then if you have not met the A1C target, then we have to add. Almost all guidelines say you can initiate with basal insulin alone and then up titrate it if the A1C is not met. So which basal insulin and why basal insulin in this patient? So this is a nice article written by Dr. Kalra in 2015, which helps you sort of identify which patient should require both basal and prandial component addressing right in the beginning, and which patient you can initiate just basal and expect that the prandial component will take care of itself. So for this, we can actually look at the difference between the fasting and the postprandial glucose values. So if the difference is not much, and here he has proposed that if the difference is less than 40, this is a patient in whom ideally basal alone will take care of the deficit that is present. So the fasting glucose is high, A1C is not at the optimal target, but the postprandial excursion is less than 40. So in this patient, you don't really need to add a prandial component. Continue whatever the regimen the patient is on and add only basal component. If the patient's postprandial excursion is much higher and he has propose 74, that is the difference between 126 and 200, in which case you will also additionally need to add a component of prandial insulin as well. So if you remember this patient's values, it was 188 and 218. It is less than 40. So this patient would ideally be the candidate in whom you can just use basal alone. So what are the first generation basal insulins and what were the issues that we had with them? They were truly not once daily because their coverage was not 24 hours. They had a high variability. There was a fixed time dosing. The patient could not the timing was not flexible, particularly for patients who traveled and had erratic meal times. They were not truly peakers. There was some amount of peaking. And of course, related to that directly is the fact that there was always some risk of nocturnal hypoglycemia. So the newer ultra-long acting basal insulins, you have two insulins, degludec and glargine U300. And if you compare these two, they actually perform somewhat similar, but degludec has a earlier onset of action, and of course the duration of action of degludec is definitely longer. It acts around 42 hours. So there is a dosing flexibility of 8 to 40 hours. So the patient can space the next degludec injection anywhere beyond 8 hours and less than 40 hours. So that gives a huge advantage with regards to use of degludec in a patient who has a little erratic lifestyle and is likely to do a lot of traveling. And this is another study which has compared day-to-day variability of U300 glargine versus degludec, and you can see that degludec actually performs better with regards to day-to-day variability within the patient. So degludec had less amount of variation, whereas U300 glargine had slightly higher amount of day-to-day variability. So this is another data from real-world evidence, a confirmed study which looked at hypoglycemia. And here you can see that the reduction in hypoglycemia was more favorable in patients who received degludec when compared to U300 glargine. So they had a 30% lower rates of hypoglycemia in comparison to U300 glargine. And the change in proportion of patients experiencing more than one episode of hypoglycemia was also less in the degludec group when compared to U300. So if you look at all the parameters that an ideal insulin should have, degludec seems to fit the bill perfectly because it's a flat, peakless insulin. It has very low risk of hypoglycemia, particularly nocturnal hypoglycemia. It has a true basal because it has long duration of action, and this also allows dosing flexibility, and the day-to-day variability is minimal when compared to other basal insulins. Now we look at another case scenario. This is a 53-year-old gentleman who's had diabetes for 7 years. Here his HbA1c is slightly higher than the previous case. He's also obese with a BMI of 25. And if you look at the glucose values, you will see that the fasting glucose is 206 and the postprandial of 288, which means his post-glucose excursion is much higher than compared to the previous patient. Otherwise, pretty much the parameters are similar. He also has his dyslipidemia is not yet optimized, and his eGFR seems to be okay. So his treatment history, again, very similar. He is already on metformin, sulfonylurea 2 grams OD, and dapagliflozin. And here, the primary challenges that we have is that, again, patient has fear of hypoglycemia, is not very keen on taking insulin, has erratic dietary pattern and often travels, and also has a significant postprandial excursion. So which is the insulin that is ideal in this patient? So here, if you look at the article that we mentioned earlier, you will see that because the postprandial excursion is significantly higher, adding a basal insulin alone will be inadequate for you to reach your optimal glucose target. So this is a case for a combination of prandial insulin along with the basal insulin. And again, we have a preparation called idec-aspart, which combines degludec with aspart, and aspart provides the prandial component, and degludec will provide the basal component. So here, when you look at efficacy, safety, quality of life, and flexibility, all these parameters are in favor of using idec-aspart. So again, here they have compared idec-aspart with insulin glargine. May not be a very fair way to look at it because glargine doesn't have any prandial component. So if you look at the reduction in fasting process, whereas when you look at the PP variation, obviously it will be increased in idec-aspart because that is the one which has a prandial component. And if you look at the change in HbA1c, again, it is similar across all the three groups. So when you switch from idec-aspart to idec-aspart from glargine U100 or U300, you can see that the patient's quality of life also improved. This is diabetes-related scores. So again, you can see at the end of the study, the quality of life is improved in patients who were switched from idacaspat to idacaspat from either U100 or U300. So the patient's preference, probably the glycemic control was obviously better if you have addressed the prandial component. So 78 or 80% of patients, close to 80% of patients were willing to continue with idacaspat, and 75% of them preferred idacaspat over the previous basal insulin alone. So what are the advantages? When you talk about flexibility in dosing with U100 glargine, you can take it once daily, yes, but the time of taking the insulin has to be fixed. There is not much flexibility that's allowed here. For U300, there is some amount of flexibility. It can be about a 6-hour gap, either 3 hours before or 3 hours after the usual injection time. However, with idacaspat, you have a much more wider range. You know that the range is 8 to 40 hours. So that is the biggest advantage of idacaspat or even degludec when compared to the other agents. Only thing to remember, because there is a prandial component, this dose has to be taken prior to one meal. So how do we initiate? If you want to give it once daily, usually start with either 10 units and then up titrate or down titrate it, and you use it with the largest or the most carb heavy meal of the day. If you want to use it twice daily, again, you can actually use it. It doesn't have to be morning and night. It can even be afternoon and night if those are the two carb-heavy meals. But ensure that there has to be a split of at least 6 hours to avoid the stacking of the aspat component. So in special situations, is it safe to use idacaspat? Yes, in elderly individuals also it is safe. In individuals renal impairment also we can use it safely. Renal, hepatic, or any other major organ involvement. Even patients who are undergoing religious fast, you can titrate the timing according to when the patient is going to eat. And also in type 1, we know that it can be used easily. So summarizing my talk, so degludec, the key attributes of degludec is that it is a ideal once daily basal insulin. It has a very long duration of action, very minimum variability, gives us a lot of flexibility with regards to the dosing schedule. And if you look at idacaspat, again, it is safe, efficacious. It does have enough evidence. There's a positive impact on quality of life. And even idacaspat gives us flexibility in dose administration. So with that, I'll end my talk. Thank you.
Thank you, madam. Very brief and very informative, very practical point which you wrote, how to choose degludec and when to choose it for combinations. Very nice. We take one or two.
So if you have initiated on idacaspat, initially you can use the fasting glucose to titrate it. And even after you've achieved an appropriate pre-meal or fasting, if the post-meal is still high, for instance, if you're giving idacaspat twice daily and you've given it with breakfast and with dinner, sometimes the post-lunch excursion may not be covered because there is no prandial insulin coverage there. So there, if it is not met with twice daily, you might have to introduce a plain aspat in the afternoon. So ideally we have to target both because that's our aim. We have to get both under control.
But is it rational to give idacaspat twice or aspat before the major meals and once a day idacaspat?
Yeah, that depends on the patient's postprandial excursion. So if the patient is having the heaviest meal once, you can try idacaspat just once because the basal requirement will anyway be covered, whether it's once or twice. But the necessity of 2 doses will be only if there is postprandial excursions are high with every meal. So there, of course, you will have to use more than once and maybe introduce another third aspat alone for the third meal.
The role of fasting or postprandial HbA1c, which one is here? The value which is HbA1c?
So the HbA1c can be done in any state, whether it doesn't matter whether it's fasting.
7.5 to 8.5 or 9, or what is the value?
The target HbA1c. So target HbA1c will depend on the patient. The patient's clinical...
65, less than 65, more than 65.
So older patients with more comorbidities having longer duration of diabetes, we will relax the target. Maybe 7.5 is all right. But if you have a young patient, a recently diagnosed diabetes, then our target HbA1c would be keeping it as close to normal as possible without having hypoglycemia. So that is the only caveat you have to remember. Every time, the closer to normal, the better. In a young individual,
Maybe they're like in younger patients.
I'm sorry, sir?
No, if it is 6.5 hypoglycemia, then 7 to 7.5 is ideal, like that for younger patients.
For younger patients, now that we have so many drugs which has very minimal risk of hypoglycemia, we are able to achieve 5.7, 6, those A1Cs without any risk of hypoglycemia. So if you're able to achieve that, you please target as close to normal as possible.
I'd request our chairperson to hand over the mementos. Our next topic is 2G and 3G are the multipeptides future of diabetes and obesity care. I'd request the chairperson to introduce the speaker, Dr. Matthew John.
Thank you. Thanks, Dr. Murthy, for this opportunity. And I'll be running through this topic of 2G and 3G multipeptides. So I think most of you would be thinking that the future of multipeptides is yet to come. But if you look at the 2024 clinical practice guidelines of ADA, you would realize that tirzepatide, which is a 2G peptide, has come as a recommendation in terms of intensive glucose lowering without increased risk of hypoglycemia. So basically that thing that you have already these things in the market, at least not in India, but elsewhere in the world. And if you look at the spectrum of peptides in both obesity and diabetes treatment, you would realize that there are various peptides which can be manipulated, which can be the GLP-1, which we already have, the GIP, the glucagon, the amylin, the PYY. So it's an entire spectrum of peptides. And when you join 2 of them, you call them the 2G, or when you join 3 of them, you call them the 3G. And they have variable effects in terms of insulin secretion, in terms of the glucagon inhibition or secretion, gastric emptying, in terms of energy expenditure, and also in terms of appetite regulation. So you could join many of these peptides together to get the benefits that you want. Now, I'll just run through the physiology of incretins before we go ahead. We know the incretin effect, and what exactly the incretin effect is. I think most of it has come when the DPP-4 inhibitors came into the market. So when you give a intravenous glucose, or you give an oral glucose, the oral glucose actually elicits an increased response of insulin, and that is what is an incretin effect is. And this incretin effect is impaired in people with type 2 diabetes. And what happens to GLP-1 and GIP in type 2 diabetes? Traditionally, it was believed that there is a reduced production of GIP and GLP-1 in people with type 2 diabetes. But now the new studies with the newer assays have shown that they are similar. The levels of GLP-1 and GIP is similar. And when you do a glucose-stimulated GLP-1 secretion, again, it is found to be almost similar. The total GLP-1 secretion found to be similar in NGT, IGT, and type 2 diabetes. Similar thing with GIP. But what is different is that when you compare these effects of exogenous GIP or GLP in people with diabetes versus normal people with normal glucose tolerance, the ability of these molecules to elicit insulin secretion is less in people with diabetes in comparison to people who are normal. So the blue line on top, what you see is the normal. And this is the CLAMP studies to show that the insulin secretion elicited by exogenous GLP or GIP is impaired in people with type 2 diabetes. So this is the overall picture to demonstrate that. I'm not going into details, just to show you that there are variable effects of GIP and GLP-1 on different aspects of management of diabetes in terms of insulin, in terms of glucagon, etc. Now coming to the molecules which are in the pipeline and which is yet to come into the market. So I'm not going into any of the detailed descriptions, I mean some of the detailed descriptions, but in this particular picture I'm not going. But only to tell you that if you look at these molecules, these are actually unimolecular. Basically, these are not GLP and GLP-1 joined together at some point. These are molecules which are unimolecular and have certain sequences from GIP and GLP so that they act on both the receptors. Unlike there is one molecule which is a combination, most of them are single molecules. This is the tirzepatide which I told you about in the initial slide. This is again a combination of action of GIP and GLP, and just like the other molecules that we have in like insulin space, like degludec, it's attached to an albumin by a free fatty acid. Now, I'm not again going into the pathophysiology of GIP and GLP. Both of them actually secrete insulin secretion, but they have got variable effects on the glucagon. And when you take tirzepatide, all these actions of GIP and GLP-1 translates into increased insulin secretion to control the glucose. It has got variable effects in terms of appetite regulation. The weight loss has got an effect in terms of improving insulin sensitivity, and it has got also benefits on the cardiovascular and the renal system. Now, if you look at the trials of tirzepatide, SURPASS trials are a group of trials, SURPASS 1, SURPASS 2, 3, 4, and 5, in people with type 2 diabetes to show that there is a average A1C reduction of around 2 to 2.5% in people using the highest dose of the drug, even in comparison to the injectable semaglutide that we already have in the market. That is a SURPASS 2, where you would see a 1.86% reduction in HbA1c in comparison to tirzepatide, which produces something like 2.46% reduction in A1C. So very powerful in terms of A1C reduction. And it comes to reduction of weight, again, you can see approximately 13% reduction in weight, even in people with type 2 diabetes, where these drugs don't really perform well. And again, SURPASS 2, you can see the comparison with semaglutide, 6.2 versus 12.4. It has got cardiovascular benefits, but the cardiovascular trials are ongoing. And SURMOUNT trials are like a group of trials in obesity, the tirzepatide in obesity trials. Again, you would see there are multiple trials. I'm not going into the details, but just to show you that this particular trial called SURMOUNT 3, where you can look at the amount of weight loss which it has produced, 18, 21. It's the massive weight loss which it has produced. And if you look at that particular graph on there, you would see that this is on top of optimal lifestyle intervention. So you first have a lifestyle intervention which reduces the weight by around 5 kg, and you then get randomized into drug versus placebo to show that there is a further reduction of around 25% weight loss on top of that. Safety and tolerability, just like the semaglutide that we use, and we have heard many times, gastrointestinal adverse effects are the predominant adverse effects of these drugs. Tirzepatide is already approved for both type 2 diabetes management and also for weight management in people with obesity with a BMI more than 30, more than or equal to 30, or BMI more than or equal to 27 with at least one comorbidity. Now the second one is the 3G peptide. That is a triple combination of GIP with GLP-1RA with glucagon receptor agonist. So here it's a retatrutide. And again, you can see the massive weight loss which it has produced from around 25% of weight loss which is produced in the in a clinical trial of people with obesity. Trials are ongoing. The TRIUMPH program is ongoing, and which will again throw more light on how this drug is. This is not approved. This is a combination of drug called the cagrilintide, where cagrilintide is an amylin analog which is combined with semaglutide to form something called cagrilintide. Again, you can see the massive weight loss these drugs can produce in people with type 2 diabetes. This is pure obesity. Then you have a series of drugs where GLP-1 and glucagon co-agonists are there. It's something, there is someone called the survodutide, which is in advanced form. There is different drugs in the same category where you would again produce massive benefits in terms of weight loss. Now coming to the last part of my talk, what are the things which we are looking at for the future? How do we redefine the role of bariatric surgery? We know that bariatric surgery like Roux-en-Y gastric bypass could produce something like 30-35% weight loss. But if you look at the 2G peptides and the 3G peptides, they are almost reaching there. So will bariatric surgery still continue or will it be given up? This is again one more data from the SURPASS-3 trial where they looked at liver fat in digludec versus tirzepatide. And you can see here, there's a significant reduction in liver fat which happens with these drugs. There is a weight loss, there is a reduction in liver fat. And you know from studies of diabetes remission that once you reduce the liver fat dramatically, it may change the natural history of the type 2 diabetes. So are we looking at a changed natural history of type 2 diabetes in the future? And adverse effects is again something which we are concerned about. Regarding GI adverse effects, the ileus, risk of intestinal obstruction, we are concerned about lean body mass wastage or sarcopenia with these drugs. But studies have shown that the fat loss in these drugs are much more than the muscle loss. So overall effect is better. And the other GI adverse effects which can limit the use of these drugs. So thank you very much. The only thing is the future of obesity management is very bright. Thank you. No, oral semaglutide is not approved for obesity management. You are possibly going to see a higher dose like 50 milligram coming in, which may be, as of now, it's not approved for obesity alone. If you have type 2 diabetes and obesity, yes, you can use it.
Hello. We see a lot of weight loss with tirzepatide. What's the exact mechanism when compared with injectable semaglutide? The weight loss is definitely much more. What's the exact mechanism?
In fact, the exact mechanism is not very clearly known. But what is sort of postulated is when you activate both the GLP-1 and the GIP-1, other than the G-protein activated mechanisms and the downstream, there is another thing called a beta-arrestin mechanism. Beta-arrestin is involved in GLP receptor catabolism. So what happens is when you have a GLP-1 and a GIP-1, the GLP-1 is able to act much longer, and that is possibly the reason why it is happening. And there are some other postulates also. Now this is believed to be the most likely reason, in the mechanistic reason why these two things happen. On top of that, GIP-1 has got an independent action in terms of appetite reduction, and also in terms of reducing some of the gastrointestinal adverse effects of GLP-1. So combining them, you may be able to give a higher dose of GLP-1 rather than the smaller doses that you use with semaglutide. That is possible. That is what I could read.
Thank you.
Thank you, Dr. Mathav John, for sharing your valuable insights. Now, let's break for a quick tea. When we return, we will hear from our next speaker. Enjoy your tea.
this fiber, due to the diabetic neuropathy, there may be more collapse during sleep. So this is the most likely pathophysiology by which presence of diabetes can increase the likelihood of OSA. So OSA and diabetes is more interrelated. Presence of one can increase the incidence of the other entity. So that is why in 2017 ADA has recommended OSA as a significant comorbidity in diabetes mellitus. So there is need of screening of OSA in presence of diabetes, and there are several methods. Polysomnography to do every patient of diabetes patient is not very easy. It takes time, it needs a technology. But the question, there is a question of issue. So CPAP is the principal treatment of OSA, and it is seen if you put the patient of CPAP that increase the insulin sensitivity in both obese and non-obese patient, also in pre-diabetic patient. So in a pre-diabetic patient, if you put the patient of OSA, put the patient of CPAP, the conversion of from pre-diabetes to diabetes will be decreased, and at the same time insulin sensitivity will be increased. So the requirement of anti-diabetic drug may decrease. So now we are coming to the three situations on the CPAP without diabetes. In this group of patients, if you with the CPAP, the 7 studies we have taken together, but without diabetes, if you use the CPAP, there is not much changes of the insulin sensitivity or resistance. But if you put the patient on exercise, conversion from patient without diabetes to pre-diabetes or diabetes will be increased. Next is the CPAP patient with the pre-diabetes. This is the group where if the patient on OSA and pre-diabetes put on CPAP, definitely the transition from pre-diabetes to diabetes will be much delayed. That is a very definite benefit. That is why in OSA patient, if you want to use CPAP use early. That will prevent the development of diabetes in patient in that group of patients, and also other cardiometabolic complications. So now we are coming to the effect of CPAP on diabetes. There are several studies, and some of the studies there is a conflicting results. Some of the studies there is no change of A1C, but overall there is an increased insulin sensitivity and A1C decreased significantly. And mostly we get benefit if the patient have moderate to severe glucose imbalance. So in the presence of moderate to severe diabetes, if the patient use the CPAP, we will get the better benefit out of the therapy of OSA. So duration is very important. So one indication is the pre-diabetes, then in the diabetes, then for timing and duration. Timing, usually duration, you have to use a longer period, more than 3 months. Just give. So conclusion, OSA have an impact on glucose homeostasis. Result of CPAP on glycemic control is conflicting. Still, using of the CPAP in a OSA patient, there is a benefit of the blood sugar control, but never forget to lose weight, because there is the key factor of development of OSA and its complication. Thank you. Thank you.
Thank you very much, sir. My apologies to not follow the protocol of oration. Now I request Dr. Chandraya and Dr. M.A. Shekhar, sir, and Dr. Srinivas Murthy to felicitate the doctor. Thank you very much, sir. For the next oration, I invite Dr. Shashank Joshi, Padma Shri awardee. Please. And I invite Dr. Muruganathan and Dr. Basangodappa, sir. Always be remembered as a beacon of wisdom and a source of enduring inspiration.
Really humbled, and I'm grateful to Islet team and Professor L. Srinivasmurthy and his grandfather, under whose name the oration is. I find the term a little differently because we are in the state of mind-body medicine. So I'm really going to talk today on ancient wisdom and modern medicine. And it's a cardiometabolic conclave, so I don't have any duality or conflict of interest for this talk, but I hope what you listen, you learn, what you learn, you adapt. And my only disclosure for this oration is that I'm a close friend of L. Srinivasmurthy. So put your hands together for Professor L. Srinivasmurthy. He's really done a fantastic job. But I'm going to start with Vedic medicine because we often are critical, and I'm not an Ayurveda acharya, but I'm going to try to see how can we scientifically interpret some of the Vedic philosophy. A little bit on sleep medicine because it is in continuation of what Dr. Jyotirmay Paul, who is rushing for his flight, and a little bit of clock and mind. A little bit of food and Indian medicine, gut microbiome, and we are changing seasons now. It's called Ritucharya. And then, a topic which is very closely linked to my heart, which is AI, artificial intelligence and diabetes remission. Then yoga, and generating evidence on yoga and lifestyle mantras. The last lifestyle mantra is digital detox. I can see so many people with their mobile phones. So just like Lent fasting has started, Ash Wednesday was this Wednesday. We have Ramadan fasting coming up. We have Ekadashi fasting coming up. We need to understand that we should also do dopamine fasting every day, which is a digital detox. And that's my last take home message. So clearly, we need to recognize that just like we look west, we should look at India and Bharat again. And we need to integrate and evolve our ritualistic Vedic practices, which have transited through philosophical insights of Upanishads. And the concept of self-reality liberation are nothing but sage Patanjali's inscriptions of the classic yoga system. And the compilation of Yoga Sutras was done by sage Patanjali. And all he did is, he was like a scientist. He put all that in a system of yogic philosophy. So if you see Vedaraksham, what is Vedaraksham? It's Vedas, and Atharvaveda is from where Ayurveda took its birth. And Upanishads is where yogic philosophy took its birth. And all of us have 5 elements we live in: the earth, the water, the fire, the space, and the air. And then in the traditional Ayurveda or Vedic philosophy or Vedic medicine, they have 2 components: the dosh and the guna. Dosh is physical constitution and guna is the mental constitution. So in the doshas we have the vitta, the pitta, the kapha. And vata is nothing but air and space, pitta is water and fire, and kapha is water and earth. And in the mental constitution, we have the gunas, which is the rajasic, the sattvic, and the tamasic. And based on the balance of the physical, so if you look at it from a holistic standpoint, our Vedic medicine is a balance between mind, body, and spirit, and it is not just an absence of disease, but a complete state of physical, mental, emotional, and spiritual well-being, which promotes longevity and good health. And they have then used from Katha Upanishad the chariot analogy. Body is the chariot, horses are the senses, reins are the mind, charioteer is the intellect, and the passenger is the self or the Atman. And the relationship between the chariot and the Atman is controlled by our senses, the horses, through our mind, the reins, guided by the charioteer. Many of people call charioteer. And fundamentally, any practitioner of yoga, which is a yogi, will try to look at developing some kriyas, which are nothing but cleansing processes. And it's not just strength and athletic abilities, but you have to control the body or the Atman with abstinence or yamas, purity and moderation, and then niyamas. Niyamas are disciplines or rules of discipline. And it's a process. But when we understand this whole process of total energy expenditure, resting energy expenditure, basal energy expenditure, we clearly see that there is a science from the old Kundalini Shastra. We also have from the Hatha Yoga a combination of asanas, postures, pranayamas, which are breathing exercises, dhyana, which is meditation. And we can actually study it and quantify it because we need to do science and research around this. So if you look, so it could be a low intensity protocol with limited cardiovascular benefits. We could do a high energy protocol, and we can even do pranayama and concentration. So asanas are not mere postures. We think asanas are postures, but they have much more than postures. Asanas are important for flexibility, for muscle tone, for muscle strength, but also for cardiorespiratory health. And they protect us from injury. But am I talking quasi-science? No. We are modern medicine doctors. We need to recognize this in the modern medicine way. So yoga has been compared with usual care, and there are randomized controlled trials. So this is a systematic review and meta-analysis of yoga in management of chronic diseases by Brooks et al. And when they look at two outcome measures, just like we have cardiovascular outcome measures, exercise capacity and health-related quality of life, you can see a statistically positive construct that yoga affects exercise capacity and health quality of life in chronic diseases. Similarly, we are all here for a cardiometabolic conclave, and diabetes is the core of this meeting. And we can clearly recognize that yoga practice improves both diabetes and pre-diabetes state. It improves lipid profiles, it improves biomarkers, and when there is an intervention and there are well-designed RCTs, you can clearly see that it's an excellent adjuvant overall in health and disease. The next step of yoga is breathing techniques, the prana, and which from prana, which is nothing but air, it is pranayama, which improves not only cardiovascular health but reduces stress and anxiety symptoms. And when you do slow pranayamic breathing, there's data now to suggest that it stretches fibroblasts around the lungs, causes a hyperpolarization current, it modulates the neurohypothalamic pathways, and improves the parasympathetic dominance. See, yoga is nothing but a state to improve parasympathetic dominance. And similarly, when there is slow pranayamic breathing, it stretches the SARS, there is slow adapting stretch receptors, which generates inhibitory neural complexes and then decrease the action potential on the neural tissues. The next step after pranayama is dhyana, which is meditation or meditative practices, because they reduce stress, anxiety, depression, memory, attention, and emotional regulation. Again, is it quasi-science I'm talking about? No. We are evidence-based scientists. And this is a meta-analysis done from Asia on all the randomized controlled trials looking at the medical application of meditative techniques. Because whether it is sleep quality, whether it is persistent fatigue, whether it is people with mental health disorders and antidepressive effects, there is clear data to suggest that meditative techniques improve attention, awareness, point of focus, and even transcendence. Finally, I am moving gears from postures, from pranayama, from dhyana to food habits. And we are a fasting and feasting country across religions. As I told you, Lent is on. Ash Wednesday was on Wednesday. That is the Lenten fasting in the Catholics. Ramzan is coming up in a couple of weeks from now, which is in our Muslim brothers. And in Hindus and Jains, the fasts are intermittent. So intermittent fasting is a health trend because there is a cycle of eating fat. In India, in the Hindu philosophy, we have Ekadashi. Ekadashi is a traditional Indian fasting practice observed on the 11th day of the lunar cycle. And it has a role in detoxification. So we dismiss it. But actually, if you do periodic fasting, it improves the cellular cleanup and autophagy. It improves metabolic flexibility, mental clarity, and there are clear-cut parallel equivalents of intermittent fasting in research. So if you see some of the traditional fasting practices, independent of the religion, there is some biological basis to it. And there is something which is linked to it. Finally, the types of diet we consume. They are linked not just to spirituality, but to enhance longevity. The classic is the Sattvic diet, a diet which has been defined in the Mahanarayana Upanishad for spirituality, for happiness, for calmness and mental clarity. Saints used to have those foods. It was fresh fruits, nutritious and tasty, and fresh fruits, vegetables, sprouted grains, roots, tubers, nuts, milk, curd and honey. And this is a prudent diet. Then we have Rajasic diet, which fuels passion and activity. It used to be used by leaders and fighters to excite and boost confidence and intelligence. It but had emotions on it, because there is jealousy, there is anger, there is selfishness. These foods are bitter, tarty, salty, spicy, hot and dry, and they have a direct impact on IQ and intelligence, but they also have a negative impact on emotions and fantasies. And humans are very fallible to that, and the food you will have after a couple of talks is going to be related to a lot of Rajasic diet from this opulent hotel. Then of course Tamasic diet, Sust and Must. It's a pre-lunch talk, post-lunch talk is very Tamasic because it contributes to laziness and pessimism. Again, these are negative foods, stale foods, overfried fat foods from tamed animals, and it can enhance anger, criminal tendencies and lower life expectancy. So there is an actual classification in Vedic medicine on guna-based classification of nutrition and mental health. Sattvic food has the highest micronutrient density, promotes clarity and calmness. Rajasic has moderate micronutrient density with action and passion. Tamasic has lowest micronutrient density, induces lethargy and negativity. And the fiber content is similar in all the three types, but the fat content varies. The fat content varies. It's like a keto diet. You can see Tamasic is 72% fat, Sattvic is 18% fat, Rajasic is 42% fat, and the daily intake also is variable. And if you do a construct of these diets, Sattvic is balanced on all the micronutrients, Rajasic has thiamine, and Tamasic has zinc, iron and anxiety. So there is evidence that some of these foods are going to get us some good health, and therefore we need to nourish us. And these are seasonal. As the season changes, we can see that we are balancing it out. For example, we are also having ingredients now. Vedic practice like ashwagandha for stress, turmeric for inflammation. And what are they doing? They are balancing our prakriti. We wrote an article, whether it is Surya Namaskar, asanas, kriyas. You know, clearly there is data to suggest that it improves overall metabolic health through behavioral changes, through psychological changes, through physiological changes on body weight, blood pressure, and it's a perfect adjuvant for cardiometabolic health. When it comes to sleep, the balance is to balance three doshas: the sleep, the circadian rhythm, and the metabolism. And unfortunately, we have these bright lights, we are not sleeping appropriately, we don't sleep for 7 hours, and we have disturbed it, and therefore we have disturbed the dopaminergic tone in the hypothalamus. And when that is disturbed, and when there is a blunting of hypothalamic response to glucose and lipids after meals, you get insulin resistance, and you get excess glucose diarrhea from the liver, and you fundamentally get diabetes. And we have disturbed our biological clock. Even biological clock was well defined. You can see Pitta is red, Kapha is blue, and yellow is the Vata. And we have chronotypes. And clearly there are sources of melatonin. So when you sleep, sleep without any screen. Any light from a screen, including a mobile phone or television screen, will switch off the melatonin. And red light is the best light to sleep. Of course, Jumani is going to talk more on sexual health, but I'm not talking on sexual health, I'm talking on sleep medicine. Don't have intoxicants and clearly have a light dinner. So sleep hygiene is important. It's very important to have a good sleep hygiene, including taking a bath, and some don'ts which are there. Yoga has a real role, but there are superfoods for sleep. There are some foods which we avoid in sleep, and music therapy is also important. Various ingredients are useful, right, from magnesium, tryptophan, and various extracts. So if you see the modern advices today, even the ADA-ESD has recognized yoga and Tai Chi in their guidance of ADA-ESD guideline and has set the 5 S's. Sitting is the next smoking, so don't keep sitting. So people who are walking and standing, I appreciate them. Sweating is important, sweat it out. Keep stepping. If you do a 10,000 step, it's great. Sleep for not more than 10 hours like Kumbhakarna, which Dr. Jyotidev showed, but not less than 5 hours. And strengthen your muscles. So it's very, very important to recognize that. But sleep is very crucial for diabetes. And the chronotype is important. If you have early morning chronotype, it's more useful. The next thing is gut microbiome. Gut microbiome was best described by our ancestors, and it was all written down as Agni. And to control the Agni, and there's a chapter in Gita, and I won't go into details of that, it is important to recognize that we have different seasons. We have summer, we have winter, we have spring, and actually in the Ritucharya, we are adopting seasonal regimen, and the foods which we serve at different seasons actually balance different Agnis, whether it's Visham Agni, the Tikshna Agni, the Manda Agni or the Samay Agni, and balance the doshas. And they correct the microbiome. They say that we have more microbiomes inside our body than actually human beings. And you know, Dr. Balasubramanian wrote this very nice paper which said that it is not important how much bank balance you have in your bank, but it is how much good bacteria you have in your gut. That determines how healthy you are. So intestinal hotspot is a big spot for diabetes, and we need to balance it. We need to have healthy gut microbiota. So if you have a high fat, high sugar diet, which you will have at lunchtime today, then there is stress or antibiotics, you will actually destroy all the gut microbiome. And if you have a healthy diet, don't eat, do little fasting, do have some curds or curd rice, or also do fecal transplantation, you might have some better options available. And the gut microbiomes and fiber, we are fibrogenic India. There is data to suggest that when dietary fiber is processed by gut microbiota, they have short chain fatty acids. They process through different receptors, whether it is the intestine, the adipose tissue, the pancreas, the sympathetic canal, and the blood vessel, and they have biologically positive effects. And they actually are healthy for cardiovascular and cardiometabolic disorders. Even the gas is good. You know, when you push the gas in the intestine, actually you are improving and causing cardiometabolic benefits. And this is Japanese study to show that if you have flatulence, and somebody who has flatulence, don't get embarrassed, it is a novel antioxidant and might protect you from cardiovascular health. So gut health has some science around it. We are living in a dysbiotic environment. Our gut bacteria are polysaccharide substrates, and adapting different foods for different seasons is important. You can't eat a winter food in summer and a summer food in winter. You will disturb your gut microbiota. And therefore, in winter we are hibernated. Even animals are hibernated. There is a lot of biology around it. And therefore, the season as it changes, the diet changes and the gut microbiome changes. Of course, we are a global hotspot. If you just reduce carbs and add proteins, you can actually reverse diabetes. Diabetes remission is big, and artificial intelligence is nothing but mimicking human cognitive function, and we can tap it and create digital twins. And we have done that. We have actually created technology and used applications of twin to modulate stress and behavior, because no one size fits all. You know, it's precision medicine today, whether it's genomics, environment, lifestyle, and therefore 3 terms are used very commonly: artificial intelligence, machine learning, and deep learning. Artificial intelligence is nothing but a intelligent task like season, reason, and act. Machine learning is automatically from the data, and deep learning is deep neural networks. Let me explain. We do this twin, and you can go on the exhibit booth here. 3 billion data step points, 3 billion meals logged, 16 terabytes of data. So they will keep taking data for you. And we can't just tell, eat less, eat healthy, eat more, sleep more. No. For you, this food is better. For example, me and Dr. Narsingan and Dr. Srinivas had Mysore masala dosa in the morning. All three will have a different response. Okay, if you have to add, you saw in this hotel, the sambar is also different. Tamilian sambar is different from Karnataka sambar. And there was a fight between Krishna and Srinivas that both were fighting which is a better sambar. And Kannan is smiling here. But by AI, we can decide that you should have more sambar and less idli. Okay, and that can modulate it. You can tell some people they walk only for 3,000 steps in silence. Finally, as I said, Srinivas told me, connect ancient wisdom to modern medicine. And Maharshi Charak, long time back, before Christ told us, the author of Charak Samhita, that you have to be in dhyana and Surya Namaskar. The most simple form, most comprehensive exercise we have today is Surya Namaskar. And Surya Namaskar is biologically very sound exercise. It has 12 components. Each posture is critical. Each posture has a pose like the prayer pose, the raised arm pose, the hand to foot pose, the equestrian pose, the mountain pose, the salute with 8 parts pose, the cobra pose, the mountain, equestrian, hand to mouth, raise and prayer pose. And they have got names. There is no religious connotation to it. There is some Bij mantra or chanting which is involved in it. And clearly what does it do? If you do Surya Namaskar every day, it's a perfect balance of sympathetic and parasympathetic system. It clearly will get you that parasympathetic domination you need. If you are sympathetic all the time, you are looking at flight and fight and the adrenal activity. And if you want to balance your body and you want to go into a homeostasis of autonomic balance, you should do Surya Namaskar, which is a universal exercise. And we have done some data. My friend Dr. Shambho Samajhdar from Calcutta School of Tropical Medicine, we did a study on young athletes who gets very stressed out before their race. And we just told them to chant the Gayatri Mantra. And we studied attention, memory, anxiety and mental state in a prospective RCT and we published that. Okay, so remember that some of the chanting like Om chanting or mantra chanting is nothing but they can be like CBT or cognitive behavioral therapy. The biggest problem world will face today is digital internet addiction disorder. All of us are addicted to that. If somebody is not having a mobile phone without internet, then there's a challenge and we are all addicted to that. And we all need to do dopamine fasting. And we all need to do half an hour before you get sleep and half an hour after you get up, not to see your mobile phones. That is called dopamine fasting. So I'm going to stop here by just giving you some simple take-home messages. Though AI has arrived, we need to embrace simple things in our lifestyle. And embrace the pearls of wisdom of our ancestors, put them through the throughput of evidence-based filter and do some science around it. So my idea was to stimulate people in the audience, if they can do research on some of our simple grandma's tips or Vedic scriptures or ancient wisdom and use their modern medicine techniques to analyze them. For preventing cardiometabolic diseases, eat slowly, don't clean up your plate. I can see my good friend Bansi and Brij are standing here because they feel sitting is like smoking with Amit. Okay, eat less, eat slowly, don't eat fast. Okay, eat on time and eat right. We all need to do physical activity. We all need to do yoga, sleep well and smile. Don't give stress, don't take stress. And again I thank Srinivas because please do a digital detox every day for an hour. And don't only look at health as an outcome, also look at happiness as an outcome or bliss as an outcome. Thank you so much for a patient hearing.
Thank you sir for the wonderful oration. I'm sure sir deserves a standing ovation. Thank you very much. I request everyone for a standing ovation please. Thank you, sir. Thank you very much. I'm speechless after this oration. So, we'll break for lunch now. and there are many more interesting topics to discuss, and we'll break for half an hour. We'll reassemble at both the halls at 1:45 p.m. I request everyone to come back to the halls at 1:45. We have many more topics and interesting topics. Thank you, one and all.
Check, hello. Super ಅಂತ ಸೂಪರ್. ಅಡೆ ಚೆಕ್ ಮಾಡು.
ಯಾವ್ದ ಸಲ ಅಲ್ಲದು ಮತ್ತೆ ಒಂಬತ್ತು
ಸೌಂಡ್ ಇದು ಮಾಮೂಲಿ ಚೆಕ್ ಮಾಡ್ತಾ ಇಲ್ವಣ್ಣ? ಹಾಂ
ಹಾಕಿದ್ದೇನೋ
ಕಾಣಿಸ್ತಾ ಇದ್ದೀನಾ?
ಯಾಕ ಆಫ್ ಮಾಡಬೇಡ, ಪಟ್ ಪಟ್ ಅನ್ನಿಸ್ತದೆ. ಹಾಂ ಮ್ಯೂಸಿಕ 9 ಈ ಪಿಕ್ ಬಲ್ ಹಾಕಿದ್ದೆ ನೋಡು. ಕೇಬಲ್ ಹಾಕಿಲ್ಲ ನೋಡು. ಕೇಬಲ್ ಹಾಕಿದ್ದೀನಾ ಇಲ್ಲ?
check, hello, check.
ಯಾರು ಗಣಪತಿ ಬಂಟ್ವಾಳ
ಮತ್ತೆ ಹೋಗ್ಬಿಟ್ಟು ಯಾವಾಗ ಬರ್ತಾರೆ ಅವರು ಬರ್ತಾರೆ ಮತ್ತೆ ಯಾರೇ ಇದ್ದ ಕಾರಣ
ಕ್ಯಾಮ್ರಾ ನೋಡ್ಬೋದು ಹೋಗ್ರ ಅಲ್ಲೇ ಊಟ ಮಾಡ್ಕೊಂಡು ತಪ್ಪತ್ತು ಬೆಳಗ್ಗೆ ತಿಂದಿದ್ದೆ ಎಲ್ಲೋ ಅದೆಲ್ಲೋ ಚಿಕನ್ ಎಲ್ಲ
ಕುರ್ರ ರೋಹಿತ್ ಅಂತ ತಗೊಂಬರ್ತೀರಿ ಅದು ಬೆಳಿಗಾನು ಮಾಡಿಲ್ಲ
ಆಯ್ತು
ಇವತ್ತು ಏನಾಗಿತ್ತು ಜಿಲ್ಲೆ ಆದ್ರೆ ಈಗ ಹೋಗ್ರಿ ಬೇಗ ಹೋಗ್ರಿ ಯಾರಾದರೂ ಹೋಯ್ತೇನಲ್ಲ
ಊಟ ಮಾಡ್ಕೊಂಡು ಅದು ಇಲ್ಲ ಕೇಟಿ ತಿಂತಾನೆ ನೋಡು ಎರಡೇ ಮುಂದಿನ ಪಾಲು ನೋಡು ಹಿಂಗಿಂಗ್ ತಗೊಂಡು ಹಿಂಗಿಂಗ್ ಬಾಯ್
ಅವ್ನು ವೆಜ್ ತಗೊಂಬರ ಏನೋ ರೈಸ್ ಬಾತ್ ತಗೊಂಬರ ಎಲ್ಲ ಸಾಂಬಾರು ರಸಮ್ ಎಲ್ಲ
ಏನಾದಲ್ಲ ಎಲ್ಲ
Good afternoon, everyone. I request everyone, all the delegates and faculties to come inside the hall. We'll start the afternoon session. I request all the delegates and faculties to come inside the hall. We'll start the afternoon session in another 5 minutes. Yeah. Good afternoon, everyone. I hope you had a wonderful lunch. For the post-lunch session, the first session, I would like to invite our chairperson, Dr. Balchandar, and the speaker, Dr. Narsingan. I would like Dr. Balchandra to introduce the speaker.
Yeah, welcome. Sir, I welcome you, Dr. Narsingan, sir. Narsingan, sir, will be highlighting about current trends in hypertension and its management. Over to you, sir. Welcome.
Slides are not coming. Yeah, good afternoon, everyone. At the outset, I would like to thank Dr. Srinivasamurthy for giving me this opportunity to be here this afternoon to talk on the current trends on innovations in hypertension management. Hypertension is a major cardiovascular risk factor, which not only increases the morbidity but also mortality. We know very well that it is responsible for increasing number of strokes, heart attacks, heart failure, and renal failure. It is not uncommon to see people with hypertension going in for atrial fibrillation, peripheral arterial disease, and aortic dissection. Never forget to think about dementia, which can occur as a complication in people with hypertension. It not only occurs in elderly people, but also in the middle-aged people when they have uncontrolled hypertension. Ladies and gentlemen, death occurs if hypertension is not detected early and treated appropriately. With this small piece of introduction, let me now take you to the global scenario of hypertension prevalence. The prevalence overall is increasing globally. It is estimated as per the WHO. In the year 1990, it was 650 million, and the year 2019, it is 1.3 million globally. You can see the alarming numbers, what we are now witnessing globally as far as hypertension is concerned. What about the prevalence of hypertension in our country? It is estimated, as per the data available now, it is about 31% of the population is suffering from hypertension. What about the mortality? Look at this particular study called GBD 2019. It is clearly seen that out of all the risk factors which were taken into consideration, the hypertension is the most important risk factor for increasing the mortality or the death occurring due to uncontrolled hypertension. It is estimated that about 10 million people die every year due to uncontrolled hypertension. Can you believe it? We lost 2 million people during COVID period for 2 years. It is now possible to think about the alarming figures, what has been projected now. 10 million people are dying due to hypertension, which is uncontrolled every year. That shows the magnitude of the problem and how aggressive you should be to control the hypertension, to make them comfortable and live for a long, long period. Ladies and gentlemen, we know very well that these cardiovascular risk factors are always seen in conjunction. If you take people with hypertension, 65% of them have dyslipidemia, 45% are overweight, 16% have type 2 diabetes. If you take population with type 2 diabetes, it's not uncommon to see people with hypertension also. 60% of them found to be hypertensive. 60% have dyslipidemia, and 90% of them are overweight or obese. Take only people with dyslipidemia to start with, you can just see 48% of them have hypertension and 35% are overweight or obese. So the obesity is probably playing a central role in not only diabetes, dyslipidemia, hypertension, and we need to keep in mind that these reversible cardiovascular risk factors are responsible for increasing the atherosclerotic cardiovascular risk to the extent of 400 to 700%. Having seen this, I think I should probably take you to the publication of 2017 by ACCHA guidelines, ACCHA guidelines of 2017, the management of hypertension. It is clearly classified in a different manner. Till that time, we were not aware that this classification is going to come. In fact, many people criticize this classification even in the United States. Nearly 14.8% of the people in the United States became hypertensive after this classification. But very simple, I like it. Normal blood pressure 120/80. What is elevated? 120 to 129. Diastolic again less than 80. What about the hypertension stage 1? 130 to 139, and anything that is above 80 diastolic and 89 diastolic is considered as stage 1 hypertension. What is stage 2? 140 and 90. What is the recommendation in our country? Anything that goes beyond 140 and 90 should be considered as hypertension. Recommendation by ESC guidelines, 140/90. International Society of Hypertension guidelines, 140/90. Whereas this is something different, I think they are fully justified in coming out with this sort of classification of hypertension, because we know very well that people in whom you have blood pressure of 130 to 140 systolic had an increased cardiovascular risk when compared to people above 140/90. That shows that you need to bring down the level of threshold of systolic blood pressure to diagnose hypertension. This is not something new. What was designated as a pre-hypertension by the JNC7 was divided into two categories. One is elevated, the other one is a stage 1 hypertension. The European Society of Hypertension recently came out with these guidelines. In this, the classification is again mentioned. Nothing new as far as the classification is concerned. Optimal, normal, high normal, stage 1, stage 2, stage 3. The numbers that are given, Sorry, I am not able to remember any of these numbers. I try to omit reading it out. But I still remember ACCHA guidelines, how simply these people have classified. But one thing that attracts my attention after the publication of 2023 guidelines is the one that is depicted lower down. They have divided into stage 1, stage 2, stage 3. What is stage 1? Uncomplicated hypertension without hypertension-mediated organ damage, diabetes, cardiovascular disease, and without the stage 3 CKD. Stage 2 is presence of HMOD, diabetes, or CKD stage 3. Stage 3 is the presence of cardiovascular disease or the CKD stage 4 and 5. Somebody is talking there. I think they should stop doing it. Please, please, don't talk in between. Okay. Now the choice of the drug combinations for the initiation of treatment in people with hypertension, this is the best way of doing it. Even International Society of Hypertension starts telling you, start 2 drugs in a single pill. Don't use a monotherapy. Monotherapy is indicated only for frail individuals, very elderly people, or people with an elevated blood pressure in whom high cardiovascular risk is there. Try to treat with monotherapy. But rest of the people who are designated as hypertension, you need to give them only a double drugs to start with in a single pill. If the fellow is not responding, go for the single pill with the 3-drug combination. The best thing is to start ACI or ARB plus CCB or diuretic. What sort of diuretic? Thiazide, thiazide-like diuretic like indapamide or chlorthalidone. If the person is not responding, in spite of increasing the dose, many people will respond. 60% of the people will come under good control. In case those people who do not show a response, combine all 3 drugs. ACI or ARB plus CCB plus diuretic, give it. Fellow is not responding, you give him a label as resistant hypertension. But now recently the terminology has been changed to true resistant hypertension, where you need to identify those people who are really resistant hypertensive cases. That means only about 5% of the people are found to be having resistant hypertension, and not everyone. Please remember that important statement. You need to consider giving single pill, multiple drugs, 2 to start with, 3rd one that can be added, 4th one probably the spironolactone or other drugs can be tried in those patients with resistant hypertension. There's a recent article which was published in New England Journal of Medicine, where they'd used the chlorthalidone, which lowers not only blood pressure, but also albuminuria in those people with an uncontrolled hypertension, in people with the CKD stage 4, very difficult to control blood pressure in CKD stage 4, where the eGFR is less than 30, very difficult. In those patients, already they are receiving drugs, plus diuretic like loop diuretic. Over and above, you add chlorthalidone, another diuretic, you get a good response. Not only the blood pressure reduction, but also albuminuria reduction, thereby showing the drug chlorthalidone, the so-called thiazide-like diuretic, has got the potency to increase the susceptibility of these individuals to show the reduction in the blood pressure, particularly in those people with the CKD stage 3 and above. Fidilo TKD study, which had used the finerenone, the drug which had reduced the cardiovascular outcome, which reduced the risk of getting renal outcome, probably is reduced by the using this particular drug. It is a mineraloreceptor antagonist, which is a non-steroidal drug, which was used in those people with the diabetes with CKD, and they have shown good improvement, not only in cardiovascular outcome, but also in the renal outcome. Having seen this, I think I should now talk to you about how to manage people with the CKD. Very simple. Divide the patient into 2 groups. On to the left side, you can see from stage 1 to stage 3, where the eGFR is more than 30 ml. How do you do that? Give 2 drugs to start with, give 3 drugs also. Fellow is not responding, put him on an aldosterone antagonist like spironolactone, not responding, add a beta blocker, not responding, alpha beta blocker or an alpha blocker, and then try to manage. That is the best way. Suppose the patient has got the other end, less than 30 ml, increased disease in the kidneys. In that case, how are you going to manage? At the stage when you have started the 3 drugs, at that stage you need to add chlorthalidone over and above loop diuretic, that is the diuretic which I had used like the furosemide, plus chlorothalidone. At that stage, in those people with the eGFR less than 30 ml, will help them to bring down the blood pressure, particularly in those with CKD. If they are not responding, add a beta blocker, add an alpha blocker, alpha beta blocker. Like that you try to manage. But where is the role for finerenone? Finerenone in those people with the diabetes and the CKD, you can add finerenone. But I need to tell you, SGLT2 inhibitors have shown beyond doubt that they are wonderful drugs in reducing the renal morbidity and cardiovascular disease risk also. In that case, to improve the significance of the prognosis in those patients with the CKD, you need to use SGLT2 inhibitors also. SGLT2 inhibitors plus finerenone can be ideal combination. ADA started recommending in a different way. Look at the blood pressure. If the blood pressure is more than 140/90 and it is less than 160/100, those patients can be given a single drug to start and then add one more drug, control the blood pressure. Fellow is not responding as you do it for other people, you do it. Whereas people in whom you have more than 160/90, you try to use two drugs, particularly the ACA or ARB, plus diuretic or a calcium channel blocker. That is how you should proceed. But identify in both segments whether the fellow has got albuminuria or a coronary artery disease. Depending on that, you need to choose the drugs. That is the recommendation given by ADA. I will not dwell here because somebody is going to talk about diabetes and hypertension probably in the next hall. What is the BP goal? Ladies and gentlemen, there is a huge study called value study where people who were recruited in this study were given this drug. They were followed up. Those people who have shown a reduction of blood pressure, reaching the goal of less than 140 during that time, has shown a significant benefit in cardiovascular outcome, not particularly the fatal and non-fatal events came down by 25%, fatal and non-fatal stroke came down by about 45%, all-cause death came down by 21%, myocardial infarction by about 14%, and heart failure admissions by about 36%. What more you want? The message is very clear from value study. If you start treatment for any patient, see that the patient reaches the goal as early as possible so that the benefits will be given for the patient to live for a long period without any problems like stroke or heart failure. Having seen what should be the goal? Shall we stick on only to 140, less than 140? You look at this data from accomplished study. If you keep the levels at 140, the cardiovascular problem primary endpoints are higher. Bring it down to less than 130, it is improving. Less than 130 to 120, much more. Below 120, no, the events are increasing. So the systolic blood pressure should be between 130 and 140. You should try to go on adjusting the dosage of the drug so the fellow becomes normal and gets the benefit of cardiovascular risk reduction. What about the death? Death is also same. 140 higher, death is higher. 130, death has come down. But 130 to 120, death is much more reduced. Below 120, the deaths probably will be higher. So don't do that. So keep the blood pressure between 120, 130, 130, 140. That's the ideal way of doing things. And that is a message, ladies and gentlemen, which we had obtained from the so-called accomplished study. There's a meta-analysis which started showing. I have simplified because we cannot read this. I have simplified it. About 123 studies, nearly 614,000 patients recruited for this study. When the systolic blood pressure came down by about 10 millimeters, it resulted in the reduction of cardiovascular mortality by 13%. How? The systolic blood pressure was brought down less than 130. This meta-analysis started showing us an important message. Keep the levels less than 130, you get the benefit in all parameters, including the all-cause mortality, and that has benefited number of people with diabetes, with the stroke, with the coronary artery disease, and both men and women, everybody was showing a benefit. Taking all this evidence together, including the SPRINT study, which got published in 2015, the ACC-AHA started telling you one message. Diagnose blood pressure if it is more than 130. What is the goal? 130. Diabetes, 130. CAD, 130. CKD, 130. So whatever is the thing, very simple to remember. Classification, I remember it. I know when to diagnose hypertension. I know when to keep the goal for every patient. Only one number, 130, 130. Diastolic blood pressure, 80, 80. I think that message should go on and on. We should spread the message among our own colleagues. At the same time, we should also tell the patient what is expected to reach that number. That has to be emphasized and re-emphasized as and when the patient seeks advice. The recent study, a sprint study, which got published only in 2023, November, that tells you that the benefits are much more if the systolic pressure is less than 120 millimeters. That is, again, another important. Resistant hypertension, how will you manage? Again, the stage, the same thing what I mentioned about CKD, the same thing is applicable even for resistant hypertension. For resistant hypertension, lifestyle modification, good. RAS inhibitors to be used. Step 2, slow salt and fluid accumulation, use diuretics. Arterial tone improvement, use calcium channel blockers. Reduce the renal sympathetic tone, how will you do that? Renal denervation therapy. Central sympathetic system involvement can be reduced by beta baroreceptor activation therapy. Arterial tone can be reduced by other means. They are all only in experimental stage. Ladies and gentlemen, now I'll take you what is the next approach, which we have not seen. Endothelin receptor antagonist in patients with the true treatment-resistant hypertension. True resistant hypertension, TRH. Endothelin receptor antagonist. Endothelin is a powerful vasoconstrictor. There is A, B. Both can be blocked. The drug is available mainly to treat pulmonary hypertension, not for systemic hypertension. There is one study which had used Durocentan, but proved to be ineffective because of the side effects. So people stopped it, but they did not lose interest in again studying it. There is a molecule called aprocitentan, which has been tried now in phase 2 trial. Phase 3 trial is now ongoing. That is called precision study, which will throw more light because it has shown reduction of systolic blood pressure of 10 millimeters and diastolic blood pressure of 7 millimeters when compared to lisinopril. Seems to be a promising molecule which probably may be introduced into Indian market or other global scenario after the phase 3 study outcome. All of you know about SGLT2 inhibitors, which I don't want to dwell. How to reduce the blood pressure by using SGLT2 inhibitors? Yes, osmotic diuretics, weight loss, improving the endothelial function, probably the blood pressure comes down. This is ARNI. Can you use ARNI in patients with hypertension to reduce it? At present, we don't have any recommendation. India has not recommended, US has not recommended, Europe has not recommended, Japan has recommended, China has recommended. Because of the huge data that they have. It is a Japanese study which started showing the improvement in people with hypertension, particularly the nighttime blood pressure comes down by using ARNI. So sacubitril valsartan probably is another molecule which you can try in those people in whom you have a true resistant hypertension. This is a meta-analysis also confirmed the data of sacubitril valsartan. Novel anticipated drugs, vascular targets, you have endocrine targets. This is about the phase 2 trial of baxdrostat, which is again the aldosterone synthase inhibitor, which has been tried in phase 1 study where it reduces the blood pressure. These are all the drugs which are in the pipeline, which are being tried in the management of hypertension. Renal denervation, not approved in 2018 by European Society of Hypertension, European Society of Cardiology. Now there is a recommendation to use this as a method of treatment for hypertension, particularly true resistant hypertension. And then the device-based therapies, baroreflux activation therapy, carotid body ablation, central iliac arteriovenous anastomosis, these are all the technologies which are emerging. Time study, when to give the morning time or evening time, the drug should be given. The study has not shown any sort of advantages by giving drugs only in the evenings. It can reduce the frequent falls in those persons who receive the drugs in the evening. That's all. No other message. Future approaches, pharmacogenomics, antisense oligonucleotides. Again, human studies, CARDIA is undergoing. And this study is a very, very important study which started showing much improvement in those patients who are receiving this gene silencing. 2022 World Hypertension League came out with the recommendation to reduce the salt in those people with hypertension. And it is coming as a message from me because I'm attached to World Hypertension League. Reduction of salt has shown reduction in the blood pressure. Please remember that. Never forget to emphasize the DASH diet all the time. At least try to hang this photograph in all your clinics. Tell your patients what to use, what not to use. Artificial intelligence, ladies and gentlemen. Only 1 minute, Chairman, please. Artificial intelligence, it will pave a way for us to proceed further. Yes, for measuring blood pressure, for predicting the problems of arterial hypertension development, diagnosing arterial hypertension, predicting arterial hypertension treatment success, predicting the arterial hypertension prognosis, everything probably the artificial intelligence will play a major role in future. This is my last slide, which I always like it. The cartoon. Look at the fellow who is asking for tablets from a doctor. The doctor examines the blood pressure in an inaccurate way, a wrong way. Fellow is inserting the one, fellow is measuring the blood pressure in the forearm, and the fellow is standing there. The doctor has not opened the door. This fellow is not he's in a hurry to go to his office. He's drinking alcohol. He's a smoker, very obese, metabolic syndrome plus or minus diabetes. Unless you open the door and allow the fellow to come in, you may miss many, many things. And what the doctor is doing wrong, you will also be tempted to do the same thing. Never do that. Thank you very much, ladies and gentlemen, for patient listening. The last one, in 2025, February from 21st to 23rd, World Hypertension Congress is going to happen. First time in India, first time in Chennai. I am the chair for the organizing committee. The World Hypertension League has requested me to be the chair. Dr. Chandrasekhar, Dr. Kannan, Dr. Prabhakar, all of them are with me in Chennai. And this is going to be a good Congress. I am requesting you to register as early as possible so that the Congress will become a success. We need to prove that India is showing the way how to manage hypertension in future. Thank you very much, ladies and gentlemen.
One question, sir. So, one question, sir. How to go about controlling blood pressure in a kidney transplant patient?
In a kidney transplant patient, when a patient is receiving a lot of drugs, immunosuppressants and all, the same way of managing the blood pressure as you did it, depending on the problems, what he had encountered, what are the problems in the before submission for the transplant, you need to select the drugs and give him a benefit of calcium channel blockers, a benefit of other drugs, including the beta blockers, to prevent him from getting into heart attack. In addition, you can use, depending on the improvement in the kidney function, you can use ARBs.
Thank you, sir. Yeah, thank you, sir. Thank you for your wonderful presentation. I think he needs an upload for this. Thank you, sir.
Thank you, Dr. Narsingan. We are truly grateful to you for sharing your valuable insights. Up next, please give a warm welcome to the chairpersons. Up next, please give a warm welcome to our chairpersons, Dr. R. Anil Kumar and Dr. Manju. I request our chairpersons to introduce our speakers.
Hello. Welcome to the next session. I think today it is, now it's the era of combination. Either it is in diabetes or in hypertension management. Now Dr. Mohan Badagandi, the senior consultant endocrinologist from Manipal Hospital, will speak on the combination of linagliptin and dapagliflozin in the management of type 2 diabetes. Over to you, sir.
Thank you very much. all of you. I must thank Dr. Srinivas Murthy and Islet organization for inviting me here. And also I thank Anil Kumar, chairperson, and Dr. Muthu, chairperson. And my topic for today is the synergy of success. And this topic has been supported by Abbott and exploring the linagliptin-linadepa combination in type 2 diabetes care. If you look at the last 2 decades, we are almost sure that the type 2 diabetes management has been going through a lot of evolution and revolution, both. And there's a large body of evidence which has taken us through and gives us an idea about using various combination products in the management of glycemic profile for an individual. So if you look at the burden of undiagnosed and poorly controlled type 2 diabetes in our country, there are about 6% prevalence of undiagnosed diabetes, and there are prevalence of known diabetes about 13%, and out of this almost 40%, 40 to 50% have HbA1c more than 9%, another 20 to 30% have more than 7 to 8%. So in all, 2/3 of our patients are not controlled, and they all need a good control. And in order to control, we need better molecules. And why we need to control? We need to prevent long-term complications. So this, as I was mentioning you earlier, we have now understood the ominous octet, and we have also got fair idea about how to manage type 2 diabetes. And what is our goal today? Today, we are more interested in the quality of life in a patient and to prevent hypoglycemic episodes and reduce the cost of type 2 diabetes management as an inpatient as well as a type 2 diabetes management at the outpatient level. So the ominous octet, you know, there is a pathophysiology defects in different places in the body, and we want to use molecules which take control of all these spots. And there has been enough evidence today that there is not a single molecule which addresses all these defects. That is why we need to look at dual therapy without precipitating hypoglycemia. And there is a good evidence that there is a bad glycemic memory leads to more severe complications, and good glycemic memory for 1 year or 2 years gives you a protection for almost 5 to 10 years. Now, what are the indications for combination therapy today? We always look at HbA1c as the benchmark, and HbA1c of 7.5 to or 8.5%, 9.5%. If it is more than 9% HbA1c, you must think in terms of an aggressive management of type 2 diabetes, where you would require oral medications as well as a basal insulin therapy in order to get a good glycemic control. Some patients may respond, some patients may not respond to this, where you want to consider again a prandial insulin. Suppose if somebody's HbA1c is 7.5 or 8.5% or in between that, you can always think in terms of adding dual combination drugs or FDCs to lifestyle management as well as metformin therapy. Now that is the main idea today of using FDCs. Now what is the focus of areas in type 2 diabetes management today? We are looking at, one is glycemic control, and second is we want to prevent weight loss. Third is we want to prevent hypoglycemia. Most of these things we have been addressing for a large number of years, but the results have not been very promising. Now today we are able to address this because we have got molecules which reduce the weight by about 3 to 5 kg. More than that is very difficult to achieve. One needs to really look at low carbohydrate diets and various other alternative therapies. Now the other thing that we are also looking is we want to prevent cardiovascular complications and renal complications, because these are the two leading causes of death in type 2 diabetes. And when you look at cardiorenal metabolism, and cardiorenal mortality in our patients. These two drugs, that is DPP-4 inhibitors and SGLT2, have addressed this situation or addressed this phenomena and given us a very good guidance in the management of type 2 diabetes. Now, glycemic control, all of you know, I told you earlier, the earlier, the better. That means if you have a good control, the good memory is carried on for at least 4 or 5 years, and your patients do better, and they do not develop long-term complications, and their hospital admissions come down, and the cost of treatment comes down. And patients with shorter duration of diabetes, you can always think in terms of adding these FDCs, and they will do well. And you can also prevent complications in these patients. And if somebody has got acute hyperglycemia, especially after having, say, a big meal, or after having a steroid therapy, or after they have had an episode of, say, septic focus, these patients also need a good glycemic control. In such patients, again, you can look at aggressive therapy for a short while. But what really you want to do is you want to reduce the burden of the glycemic burden in these patients by starting the therapy as early as possible. Not wait for 2 years, 3 years, 5 years. So UKPDS showed that if you reduce HbA1c by 1%, you can reduce the cardiovascular risk reduction is there by 37%, and myocardial infarction is reduced by almost 15%. Then advanced trial also showed similar effect, and also the Turnbull et al. Meta-analyzed all these data and showed that there was a similar result seen in their analysis as well, and there was a good reduction in the cardiovascular mortality. So to summarize, the long-term effects of early glycemic control, good glycemic control, are always very good, and they pay off very early. So you must look at the duration of diabetes. If it is less than 10 years, try to manage with your FDCs and oral combinations along with metformin and lifestyle modification. If more than 10 years, always think in terms of adding a basal insulin or basal prandial along with these medications. Now, Lina-DEPA combination has not undergone many studies because what was available initially was the EMPA-Lina combination, and it showed a very good evidence of type 2 diabetes management with good goals and good results, and HbA1c reduction is closer to 1.8% in 4 months. So if you start with Lina-DEPA to a lifestyle or add to metformin, you can get HbA1c reduction as low as 1.3, which is very good actually. Now, what are the other cardiorenal benefits that we have? Cardiorenal benefits really come from 2 important problems. That is, one is the duration of type 2 diabetes, and other is the arterial risk factors. When we say arterial risk factors, hypertension is the commonest, dyslipidemia is the next one, then the family history, then comes the smoking, and then comes the weight, like either you are overweight or obese. These are the few arterial risk factors you need to identify and address them as early as possible. Now, these risk factors, along with the duration of diabetes, always play in concerto, and they affect the complications of diabetes, and that is why coronary artery disease is more common in type 2 diabetes, and again heart failure is more common, and stroke risk is more common, and all these are based on how much atherosclerotic evidence is there in that patient related to type 2 diabetes as well as the arterial risk factors. Now again, there is a vicious cycle, worsening of heart failure, worsening of renal failure, or worsening of renal impairment. When the diabetes is not controlled, hypertension is not controlled, and you don't address the arterial risk factors, and you don't treat aggressively these parameters. So that's why you need to understand the pathophysiology and treat aggressively as early as possible. Now, DECLARE study was done, which had 1/3 of the patients who didn't have any cardiovascular event because they were as good as primary prevention candidates. The remaining 2/3 had some event and they underwent this trial, and they also showed benefit from this dapagliflozin therapy. And this is one where there are sub-analyses now which have also shown there are very good renal benefits, reduction in the microalbuminuria and reduction in the progression of EGFR. That means you can protect your kidneys. Now 10, 11 years back, IDF came up with the idea that their slogan was the most important thing that you need to do in type 2 diabetes is nothing but organ protection. You can achieve your glycemic goal, you can identify the arterial risk factors, you can treat your patients aggressively, but ultimately what you need to do is you need to protect the organs. You need to protect the retina, you need to protect the heart, you need to protect the kidneys, you need to protect the feet, nerves, and ultimately the patient's, all this protection depends on how aggressive is your treatment. So again, so based on this, dapagliflozin, in my opinion, is slightly better than empagliflozin or other gliflozins because it has got a primary prevention data. So weight loss. Now weight loss is again not a phenomenal weight loss, but still most of our patients who are on dapagliflozin, 10 milligrams, they do lose 3 to 5 kg weight, which is very beneficial to the patient because patients cannot get that kind of weight loss just doing exercise or trying to cut down their, or go for a meal plan or cut down their carbs. So now SGLT2 and DPP4 combinations, most of them give you on an average about 2.5 to 3 kg weight loss. Some of them get up to 5 kg, some of them get almost, sometimes get very rarely 1.5 to 2 kg. Now again, there is a good evidence today, even in Indian data, that our patients also have shown 3 to 5 kg weight loss when we start them, and this continues for some time and then it becomes a static. That is why you need to enforce lifestyle management and low carb diets in these patients. Now, less incidence of hypoglycemia. Now this is something that is very important in our patients. Most of the time we feel that the patients have a fear of hypoglycemia. It is not fear. Hypoglycemia is real. Hypoglycemia can take your patient for admission, take him to the casualty, and the patient has to get admitted for a hypoglycemia. It costs him 30,000-40,000. Patient may end up staying in the hospital. Patient may develop convulsions. Patient may develop stroke and anginal episodes or increased risk of arrhythmias. So all these are very important. And also from history of fall. Patient may be having silent episodes of hypo or nocturnal hypo, or he may bang somewhere. And sometimes even patients are known to behave confusional state in hypos. So all these are detrimental to his day-to-day activities. That is why I think we need to take it very seriously, and we know who are the patients who are more prone to: elderly patients, handicapped patients, patients who are visually impaired, and patients who are on multiple medications, patients who are on a big dose of insulin at night, patients who have got renal impairment, patients who have got recurrent sepsis. These are the few who are more prone to, so you address them and you can prevent hypoglycemic episodes. And by using LINA-DAPA combination, we have made sure that most of our patients are less prone to hypoglycemia because DAPA is a insulin independent pathway regulator, and linagliptin also is not known to cause any hypoglycemic events. Now today, when we are using these two drugs, what are the other things that we have been able to achieve? Our patients have less genital infections, no evidence of ascending urinary tract infections, or patients don't have, like before, weight gain. And these drugs can be combined with lifestyle, metformin, they can be combined with basal insulin, and they can be combined with basal plus or basal prandial insulin therapy. So finally, why do we want to combine DPP-4 inhibitors with SGLT2? Complementary action. Both have got complementary action. DPP inhibitors also reduce HbA1c by about 0.7 to 0.8%. SGLT2 gives you another 0.8 to 0.9%, and it reduces the glycosuria, and it increases the glycosuria, and the hyperglycemia comes down, insulin resistance comes down, and the patient starts feeling better. And there is a weight loss, and there is a less glucotoxicity, and the systolic blood pressure comes down by about 3 to 5 millimeters. And there is supposed to be also, there is an indirect pancreatic effect where there is a beta cell sensitivity increases and glucagon increases. But if you look at the other side of the balance, DPP-4 inhibitors give you the incretin effect. GLP-1 becomes more active, GIP becomes more active, and they are weight neutral, and again they are no hypoglycemia, and both together reduce the hyperglycemia in this patient. And they also have a pleiotropic effect. That means they reduce the macroalbuminuria, and they also reduce the progression of EGFR, and they have a cardiorenal protection. So this is one of the best things that has happened in the management of type 2 diabetes. So just to summarize and tell you, prevalence of diabetes in India is considerably higher than what we thought earlier or what was estimated. And according to the guidelines, anything above 7.5, always think in terms of starting FDCs. Lina-DEPA is a good molecule to start with. And if the patients are not able to tolerate metformin, in our clinical practice, I think 20 to 30% of the patients, without, even if you don't take history, have evidence of, clinical evidence of dyspepsia, indigestion, loose motions, vomiting. So in those patients, you can always think in terms of starting Lina-DEPA. And anybody who has got 8% and above, definitely add on to metformin, or you can also combine them with sulfonylurea. Otherwise, you can always combine with the basal insulin, long-acting. Today, you have access to very good basal insulins, cost-effective. And even these have become more cost-effective now. Lina-DEPA are very cost-effective as compared to the earlier molecules which were from Germany as well as other countries. And the DEPA-Lina have shown good efficacy. Efficacy is very nice, very good and acceptable, and without weight gain and without hypoglycemia. That is one of the best things. And additional pleiotropic effects is they have organ protection, they have cardiorenal metabolic protection they provide, and efficacy, safety, tolerability data, all these things, if you think in terms of the molecule, I think these Lina-DEPA have done a very good strategy in the management of type 2 diabetes. And I think today, if you compare 10 years back or 20 years back what we were using, and today we can select our patient, normal weight, overweight, obese patients, and accordingly we can start the therapy. And Lina-DEPA fits in very well with the overweight as well as the obese patient, and also along with the insulin, where you counter-regulate or reduce the effect of weight gain because of the insulin therapy. Thank you very much.
Hello. Hello. Thank you, sir. I think it was an excellent presentation. I have one question. So AMPA and Lina is available since few years. So do you find any difference between these two in our clinical practice?
I've not really compared them as such, but what I find is that definitely now because of the cost, there are more patients ready to take Lina-DEPA as compared to AMPA, Lina-AMPA. But otherwise, efficacy-wise or even tolerability or safety-wise, I think more or less both these compounds are. In fact, among the DPPs, Lina is the best molecule today what is available, because we have large body of data and evidence. And anything that combines with Lina-AMPA or DEPA, I think should be doing well. But only question is today we also want to provide a affordable and easily available therapy to our patients.
And again, these two combinations, LINA and SGLT2 inhibitors, whether we can see any addition of reduction of proteinuria, because both have that tendency to reduce
Whenever I start in my patients, whenever I start this FDCs, what I normally do is, first I reduce the night dose of sulfonylurea if there is one, or night dose of insulin that is long acting, and by about say 25%, 20 or 25%. And if the patients are normal weight, sometimes I don't reduce that because their insulin requirement is always higher. If the patients are obese and if the patients are overweight, I always try to reduce the dose in the evening. But most of these patients, what happens is, as long as patients are with you in your office, they say yes to everything. The day they walk out of your room, they do whatever they want. You have no control over their insulin dose or the tablets. Many of my patients, if I have given a 20 units to them, they come back saying that they are taking only 16.
Thank you, sir. For want of time, we will go to the next session, sir. Thank you.
Thank you. Thank you.
I request the chairpersons to honor the speaker with a memento. I request the next speaker, Dr. Brij Mohan Makka, who is going to speak about unlocking obesity management with simple algorithm speech.
Hello. Hello. Yeah, we'll start the next session. I think Dr. Makkar, everyone knows about Dr. Makkar. He was the immediate past president of RSSDI, and he is the senior consultant diabetologist from Delhi. Over to you, sir, for the next talk.
Thank you, sir, for those very kind remarks. Good afternoon, everybody. It is best to have session post-lunch because, everybody enjoys sleep and you speak whatever you want to speak. At the outset, I would like to thank my dear friend Srinivas for this great opportunity to be here, and must congratulate him for this wonderfully organized meeting. Do we have presenters? No. Okay, fine. So I am going to speak in next 15 or 20 minutes max, unlocking obesity management with a simple algorithmic approach. In obesity management in current era is very, very relevant, and I think we all need to understand that obesity management possibly will be the major component of diabetes management in times to come. So I think I had some more slides added. Why this has gone off? So this is, Novo presentation, and this is my disclosure here. In this presentation, I am going to speak obesity management in 4 steps. First is anthropometric evaluation. Second is the clinical evaluation, which includes lab tests and evaluation for comorbidities and the consequences of obesity. Third is the risk stratification based on this evaluation. Fourth is, of course, the management and follow-up. So first thing is we need to measure the anthropometric measures very correctly, because based on that only we define obesity. Obesity by definition is excess fat in body to an extent that it is harmful for body. But we don't measure fat. It is very difficult to measure fat, so we use surrogate measures like body mass index or waist circumference or other parameters based on weight. So obesity in India is defined as a body mass index more than 25. 23 to 25 is defined as overweight. 18 to 23 is defined as normal body weight. And a waist circumference of more than 90 centimeters for men and 80 centimeters for women is defined as abnormal or presence of central obesity. Now we have parameters of body percentage fat, a cutoff of more than 30 for women and more than 25% in men is considered abnormal based on DEXA measurements. But DEXA we are not doing routinely, so we don't need to actually, bother about that. What you measure with the bioimpedance scanning, that is not very accurate, but it helps in doing sequential monitoring or follow-up of the patients. Now, step 2 is the clinical evaluation, which includes the evaluation for complications and consequences. That means comorbidities and the complications of obesity. Endocrine evaluation is required only if you feel there is an endocrine cause, especially in people who are in children and adolescents where there are indications that there may be endocrine problems and you have to investigate. Otherwise, routinely we don't need endocrine investigation. Of course, we have to look at socioeconomic status because obesity management again is going to be lifelong and the medications currently that we have are expensive. So once you have done the evaluation, once you have looked at the anthropometric measures, then you go for risk stratification. So you have to look first whether the person has obesity or no. So if the body mass index is less than 23, person is non-obese, then the focus is on prevention of weight gain, healthy lifestyle, physical activity, and so on. Somebody already has overweight or obesity, then we perform what is called staging. Staging of obesity, which is based on the Edmonton obesity staging system. And this focuses on 3 parameters: the medical comorbidities, the impairment of psychological function, and other mechanical functions in the body. Now, based on this, you divide the staging goes from 0 to stage 4. Stage 0 is no impairment of psychological or functional parameters in body and no medical comorbidities, no risk factors. Stage 2 is you have preclinical stage, mild impairment of body functions, mild impairment of psychological function, and there may be some parameters abnormal, which is pre-diabetes, pre-hypertension, or dyslipidemia. Stage 2 is the frank clinical comorbidities or significant or clinically visible impairment of body functions, including the parameters of mental and mechanical functions. Stage 3 is end organ damage, you have heart failure, things like that. So based on this, you classify based on BMI in 3 classes. Class 1 is the overweight or between 25 to 30. This is the Western classification. So Indian classification, we look at up to 30. 30 to 35 is class 2 and more than 35 is class 3. And from stage 0 to stage 4 is depending on the other parameters that you see. So once you have combination of 2, you have staging based on the class of obesity and the stage of obesity combined, it actually gives you much more clinical information and it is much more relevant approach to management of obesity. Now this is the EOSS or Edmonton Obesity Staging System. So you have obesity, somebody has obesity, now obesity is present. Now you have to classify the stage. So stage 0 is when there is no impairment on medical front, the functional components or mental health. That means there is only increased BMI, no parameters are different, blood pressure, lipids, physical symptom, no psychological problem, no impairment. Stage 2 is preclinical stage. That means person has borderline hypertension or pre-diabetes or mild physical symptoms with dyspnea on exertion, difficulty in walking, knee pains, something like that. And you have to focus on investigation for contributing factors. You have to look at what kind of management we have to put him on or her, and we have to focus on diet and lifestyle interventions and try to get them lose weight to come back to stage 0. Stage 2 is the presence of comorbidities, and you have hypertension, diabetes, dyslipidemia, sleep apnea, PCOS, limitation on walking, difficult to from sitting to standing position, all those parameters. And you have to focus on intensive obesity management, which includes behavior therapy, pharmacological management, and if required surgical management, and essentially it is very important to closely monitor and manage the comorbidities in these patients. So it is not just management of obesity, it is management of comorbidities and mental health also important. Stage 3 is the end organ damage or significant impairment of functional parameters or mental health, which is like somebody has got heart failure or myocardial infarction or severe osteoarthritis, is not able to walk, severe depression because of obesity and comorbidities, and requires aggressive obesity management, including behavior therapy, lifestyle changes, pharmacological management, if required surgical management, and management of comorbidities. And final stage 4, person has severe comorbidities, and the treatment involves first on management of obesity, aggressive management of obesity and comorbidities. But at times these people may not be able to follow all the management, and then you have to focus on more on palliative therapy. So this is a person, typical example 1, 24 years, active male, body mass index 32, so obese class 2 or class 1 by Western standards, no demonstrable risk factors, no functional limitation, no mental health issues, so class 1 stage 0. Only lifestyle interventions and prevention of weight gain. That is most important thing. No aggressive management required because there is no significant comorbidity. Another person, 32 years, BMI is 37, so class 3 or class 2 obesity, whatever you want to put, but has hypertension, sleep apnea and depression. So class 2 or class 3 and stage 3 obesity, stage 2 obesity. Stage 2 obesity already. And clear-cut benefits are there for aggressive obesity management, and we have to manage hypertension also. 63 years old, 54 BMI, disabling osteoarthritis, hypoventilation, general anxiety disorder, class 3, stage 4. And you need aggressive management, but BMI of 54, and if person has severe heart disease, may not be a fit candidate for surgery also, so you may have to focus on palliative management. Aggressive obesity management, unless it is contraindication, you have to focus on palliative management. So if you look at this slide, stage 0, stage 1, usually you have to focus on lifestyle interventions and prevention of weight gain. Stage 2 and 3, depending on the presence of comorbidities and severity of comorbidities, you have to focus on pharmacotherapy or surgery in addition to lifestyle interventions. In times to come, I am very sure surgery will become the last option because we are getting very effective anti-obesity drugs, very likely to be introduced in Indian market also very soon. And once person is not responding to medical therapy or medical therapy is a failure, surgical therapy becomes an option. Now, once we look at the pharmacotherapy options, we have number of molecules which can be used in management of obesity, but unfortunately most of these drugs have their own issues and side effects. The ones available in India are only Orlistat currently. The approved one is semaglutide, injectable, but it is still not available in India. We have the lower dose version of semaglutide, which is Rybelsus oral, and people are using that off-label. It is not approved for management of obesity. It is approved for management of diabetes. Now, semaglutide 2.4 milligram, which is approved and is very soon likely to be launched, has been studied very extensively in STEP program, which is semaglutide treatment effect and in people with obesity. And these are semaglutide trials, STEP 8. There are 8 STEP studies which were the part of semaglutide clinical development program. The major ones are STEP 1 to STEP 4. And STEP 1 was monotherapy for management of obesity. STEP 2 was semaglutide in people with type 2 diabetes and obesity. STEP 3 looked at the addition of behavior therapy versus no addition of behavior therapy. And step 4 was the long, sustenance of weight loss. So these were the 4 major trials. And if you look at the So if you look at the outcomes, almost all studies showed significant 17%, close to 17% weight loss. Starting point was 105 kg to 100 kg, some place 96 kg also, and about 10 to 11% weight loss in people who had type 2 diabetes. Interesting thing was people with diabetes who lost more than 10% weight, there was A1C reduction going to 2.2%. And the starting A1C was 8.4%. Now, if you are getting 2.2% reduction starting at 8.4, most of the people will be in remission of diabetes. And that is the beauty of weight management in people with diabetes. Now, then we have, if you look at the parameters beyond weight management, there is significant reduction in A1C, there is significant reduction in waist circumference, that is central obesity, which is again marker of metabolic derangements. There is reduction on blood pressure by 6/3 millimeters of mercury on an average. There is 3% reduction in LDL and about 22% reduction in triglyceride levels. And as I mentioned, 84% of the people achieving remission of diabetes in people who lost more than 10% versus only 48% achieving in placebo group. Now, it has been studied as a CV outcome study. Semaglutide's CV outcome study was SELECT trial, and it has already been published. This was a very robust trial involving 17,500 people with obesity treated with injectable semaglutide 2.4 milligrams and follow-up of almost 3 years plus. On an average, now look at the outcomes. There was 20% statistically significant reduction in 3-point MACE, 15% reduction in cardiovascular death, 18% risk reduction for heart failure, 19% reduction for any cause mortality, 73% risk reduction for developing diabetes, and 22% risk reduction in kidney disease and renal death. So you have reduction in risk of diabetes, you have reduction in all-cause mortality, CV mortality, renal mortality. And this is the data from SELECT trial, which was published late last year, looking at the CV outcomes with injectable semaglutide. So once you have induced weight loss, second important component or more important component is to sustain weight loss. And that is where you have to maintain a regular follow-up. Treating obesity is like treating diabetes, like treating hypertension. You put them on lifestyle interventions, diabetes person, put him on lifestyle intervention and medication, achieve good glycemic control, stop medication, everything will come back. Same is with hypertension, same is with obesity. You have to put them on medication, you have to treat them long term. There will be people who are very good with lifestyle interventions and will be able to sustain weight loss without medication also. But you have to keep a good follow-up. You have to plan 2 months, 3 months, 6 months, whatever you want to plan. But always keep track of their weight, and in case they are gaining back weight, you have to put them on medication again. So, as I mentioned, there is 4 steps of evaluation: anthropometric, clinical, followed by risk stratification and management, and then you have to maintain a good follow-up to achieve good results in management of obesity. So to sum up, BMI-centric approach for diagnosis is good, but must be complemented with the risk stratification using a EOSS or some other staging system also you can look at, but this is the best one. The complication-centric obesity management is much more relevant, helps in individualizing therapy, optimizing patient outcomes, improves benefit-risk ratio, and cost-effective interventions. Pharmacotherapy is the vital cog in obesity management and possibly needs to be used or continued on long-term basis. The proposed algorithm could help in the comprehensive assessment and hence appropriate selection of treatment modality in management of obesity in a primary care setting. With that, I conclude my presentation. Thank you so much. I have finished very much in time.
So, it was an excellent presentation, sir.
Thank you,
I
sir.
have one question. We don't have injectable semaglutide now. Of course, oral semaglutide has not been approved for obesity. But somehow we are using off-label.
I mentioned off-label use we all are doing, I think.
So do you have, what is your experience in obesity?
See, just prescribing semaglutide is not the answer. You have to have a comprehensive obesity management plan in place. Like, can you treat diabetes by simply giving a combination of SU-MET or SU-MET DAPA or whatever? 3 drugs or 4 drugs. You just prescribe the patient and tell him to take drugs. Will it be okay to treat diabetes? No. You have to focus on diet. You have to focus on physical activity. You have to focus on regularity of meals. You have to focus on monitoring. You have to focus on pharmacotherapy. And you have to focus on behavior therapy. You have to focus on the psychological aspects. Same is treatment of obesity. Semaglutide is, or for that matter, any drug that is used for management of obesity is integral part of obesity management program. A comprehensive evaluation followed by a complete, overall, what you can say is a holistic approach to management involving lifestyle, behavior therapy, psychotherapy, and pharmacotherapy, if required, bariatric surgery. After that, ongoing re-evaluation or periodic re-evaluation and modification of therapy. So it has to be a comprehensive program to manage obesity.
When will injectable semaglutide available in India? Any idea?
Pardon?
Injectable semaglutide. When will
We don't have it in India.
We don't have launched in India. Whether any idea about that?
No, it is already approved. It is going to be launched, but worldwide there is shortage. So, it is going to take some time.
If there are any questions, I think we can have 1 or 2 questions.
I think everybody understood everything. Thank you so much.
Thank you, sir.
Thank you. Amit, बस खत्म हो गया. We are okay.
Thank you, Dr. Brij Mohan Makkar, for giving us insights on obesity management. To go further, please welcome our esteemed chairpersons to the stage, Dr. K. Vijay Kumar and Dr. Chirag. I request our next speaker, Dr. H. Basavanna Gaudappa, to come on the stage, who will be giving us insights on diet for diabetes, myths versus facts. Thank you.
Thank you, Chairpersons, and at the outset I thank Dr. Srinivas Murthy for giving me this opportunity to talk on a very, very tough topic, that is myths and facts of diet and diabetes. Friends, we all know, greetings from JSS Medical College, Mysuru. What is in a name? Dieta means daily food allowance. In classic Greek, dieta means way of living, and it's actually the way of living with diabetes. And better terminology to be used in management of diabetes is medical nutrition therapy. This is the area where we all do not spend so much of time than trying to analyze and pick up a medication to be given to a patient. Of course, LSM, L. Srinivasmurthy, lifestyle modification, he practices, we only preach and we do not practice. That is one of the most important cornerstone in the treatment of diabetes. Then physical activity, behavior, mental health, tender loving care added to that. Then your medication, where we spend a lot of time in prescribing, monitoring and adjustment of therapy, surveillance and prevention of complications. Ultimate goal of a clinician is to see that the patient's quality of life improves. Having said this, we have heard two fantastic talks in the morning. To start with, Jetwani gave an importance of diet in general, health improvement. Then a mesmerizing oration given by Dr. Shashank, who spoke about Satvika Ahar and so on. There is nothing left for me to talk, but there are quite a few myths, plenty of them among the patients and even among the clinicians. Let me pick a few of them where medical nutrition therapy is a fundamental in overall diabetes management plan and should not be forgotten as once administered, counseled, forget about it, you think the patient is going to fall. The myth is once diet counseling is done, it's up to the patient to manage himself about the diet. Because we don't spend the next visit, you only look at the numbers and try to see what more to add, what more to delete, or what more to modify. The fact is, regular reassessment and review to know the complaints of the individual for the diet that you have advised. And we need to spend more time in that area than trying to think of looking at the numbers and adjusting the treatment. The patients are misled by most important counter counselors are the neighboring patient. He believes him more because he says, I am eating this, I am doing well, and my sugars are well controlled. So whatever you have done is washed out, and he believes him more. That is the fact. The goals of medical nutrition therapies, basic plan is promote and support healthful eating patterns. Nutrient-dense foods in appropriate portion size and the way it has to be prepared and eaten. And as we look at, always we talk about individualized medication, the same thing is applicable to a diet plan also. It has to be individualized depending on the needs. Maintain pleasure of eating than giving him pain of administering him a counseled diet which he is not enjoying at all in life because he has to live with that kind of diet plan for life. So we have to divide and decide and advise practical tips to a day-to-day meal planning which depends on what he is eating. So myth is goal in medical nutrition is to make the patient to simply adhere to the advice by a clinician. Fact is to support healthful eating, personalized, individualized eating needs, which will all be determined by taking a detailed evaluation at least for the first time when you have diagnosed and your patient is sitting in front of you. You need to know what all he is eating and what is the pattern of eating that is prepared and given to him at home. Unless you have that background knowledge, you cannot just give a blanket statement that you have to eat this, you should not eat that. Maintain pleasure of eating with positive messages. Maintain core principles. Don't impose stringent guidelines in diet because he has to live at least happily for the rest of life. The macronutrients consensus recommendation. The evidence is there is not an ideal percentage of calories from carbohydrates, proteins and fat for all people who are with risk or already diabetic. The recommended proportion is 45% carbohydrate, 35 to 40% fat, and 15 to 20% protein. Should be based on individualized assessment and current eating patterns, preferences, and metabolic goals. So it has to be individualized guidance, encourage dietary fibers, preferably through vegetables, fruits, and grains, whole grains, not refined grains. So eating patterns, summary points of recommendation as of now in position statement is variety of eating patterns are there which are acceptable to that individual in that area, what he is practicing. Emphasize non-starchy vegetables, minimize added sugars and refined grains, and reducing overall carbohydrates and which are refined. The next myth is starchy foods are off limits and should be avoided. That is the myth. The fact is carbohydrate foods, particularly starchy foods such as rice, bread, noodles, cereals, form the major component of body's energy source. All starchy foods break down ultimately to glucose, which is the body's preferred source of energy. The key is knowing how much your personalized requirements are there for that patient from carbohydrates, and it is the quantity and the way it is prepared and the way it is taken is important than simply administering, telling that you don't eat rice at all, I don't eat, minimize totally quantity of rice. So that is a wrong thing that is there, and it should be emphasized to the patient. The second myth is all sugar-free products are calorie-free foods. Not all sugar-free products are calorie-free. The whole market is basing on these things, and you go to the sweet stall, there are sweets which are available which are claimed to be diabetic sweets, diabetic biscuits. Friends, please do be aware they are not calorie-free. They may be sugar-free. So they also contain carbohydrate in the form of starch and can still increase your blood sugar levels upon consumption. Don't get carried away, or don't make your patient to get carried away with so-called claimed available diabetes sweets and diabetes chocolates and diabetes protein foods. So don't fall prey for marketing gimmicks. There is no need to purchase specialty diabetic products which are there in the market. So you may be able to consume regular food as part of a sensible eating plan. That is the fact. Of course, I'll skip this. Common myth among the public is bitter tasting foods, starting from bitter gourd to neem leaf, will help lower blood glucose levels. The fact is, bitter tasting foods such as bitter gourd may not really help in lowering blood glucose levels. So he is already safeguarded by telling that I have taken bitter gourd juice, 1 glass of it, so I can eat anything I want because bitter gourd will protect me from that. So glucose levels in your blood are driven by amount of carbohydrate and calories consumed, not protected by bitter gourd which is pre-mealed or taken as a pre-meal. A good understanding of individualized carbohydrate requirements and keeping to it is the key. The next myth is switching to whole grain rice means I can eat more rice. Friends, be aware that carbohydrate content of whole grain rice as well as regular rice is same. So the calorie content is important, though whole grain rice provides more fiber, making it as a better choice over the refined, over polished rice. The next myth is I can eat as much of protein as I want as long as I cut down my carbohydrates intake. This is again a myth. Fact is excessive intake of any nutrient can lead to weight gain, and weight gain is going to add to the escalation of sugars and other comorbidities. So increased protein intake will also invariably increase your fat intake. The key is to have a good understanding of your personalized requirements, keep within limits of any nutrient. Too much of protein and cutting down too much of carbohydrate may not be a very good idea. It's a myth. Then the next myth is it's okay to eat my favorite sweet when I have hypoglycemia. Friends, patients who want to eat sweet will express, he will have tutored by you in the previous visit, these are the symptoms of hypoglycemia. So he will demonstrate and generate hypoglycemic symptoms because he wants to eat sweet. And they want to overtreat themselves by eating 2-3 pieces of sweets of their liking, and hypoglycemic episode is not an excuse to your favorite sugary snacks uncontrollably. So they will be at risk of overtreating and causing a spike in your blood sugar. So you must caution them to that effect. They should simply take 15 to 20 grams of carbohydrates just to overcome that episode of, the body will also be trying to overreact and then bring out pure blood sugar through glucagon and through other sources. Next myth is fat does not matter, so I can ignore the fat content in my meals. The fact is large amount of fat in a meal can delay the stomach emptying and slow the digestion of carbohydrate, keeping your blood sugar levels elevated for a longer time, making it difficult to keep your blood sugars within the desirable range. The fat will have more than twice the calories that the protein and carbohydrate has. So this is not helpful because individuals can gain more weight, then can be undesirable lipid profile. So restrict fat to 35 to 40% of the total calories. The next myth is people with diabetes should not eat fruits. Of course, clinician would not have advised that, but the neighboring person would have advised never touch a fruit. Okay? So people with diabetes should eat fruits. Though fruits contain carbohydrates, they should be eaten as they are rich in antioxidant source, vitamins, minerals, and are also a source of fiber. There is no best fruit and a worst fruit to eat for diabetes. Only thing is you have to warn them. They will be asking, can I take fruit juice without sugar? Tell them, eat fruit, don't take canned juice and juices made out of fruits, because you will be losing a fiber which is otherwise not going to be there in the juice. Next is very important component, protein in a patient of CKD. I'll touch upon that. The protein is a bonding medium material, flattens the glycemic response to food, reduces GI, and high satiety index is there for protein, so it may make you to eat less. But usual recommendation is 15 to 20% of the total calories has to be contributed by proteins, roughly about 1 gram per kg of an ideal body weight. In case of ESRD, nephropathy, it should be reduced to 0.8 gram per kg, but listen to this carefully. In those who are diabetic, the diabetic kidney disease, who are on dialysis, don't reduce their protein. You must increase it to 1.2 to 1.5 gram per kg per day, because they will have a risk of getting into sarcopenia and malnutrition. Friends, historically, low protein diet is advised to reduce the albuminuria and progression of DKD. Average intake of protein is 1 to 1.5 gram per kg per day, or 15 to 20% of the total calories. There is no evidence supporting restriction of protein will be beneficial. So, on the contrary, there can be risk of malnutrition. Hence, especially those who are nephropathy on dialysis, don't restrict protein. So, the next myth is about a specific type of diet, like keto diet, Mediterranean diet is a sure shot for weight loss in diabetes. Given the limited evidence, it is unclear which of eating patterns are optimal. Most of the extreme diets are not sustainable. They will never be able to sustain it for a long time. So all these are only convince him that, oh, short term he practices that, it will never be lasting longer. So some temporary benefit will be there. He will be rebounding back to what he was eating earlier. So reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia, and may be applied in a variety of eating patterns that meet individual needs and preferences. About the trans fat, there is a meta-analysis of 7 RCTs on trans fats. Increased intake of trans fat did not result in changes in the glucose, insulin, or triglycerides, but it definitely caused an abnormality of lipids like increase in total cholesterol, LDL cholesterol, and decrease in HDL cholesterol, associated with all-cause mortality, CHD, and CHD mortality. So trans fats should be avoided. The next myth is so-called diet soda. Diet soda is okay. SSBs can be taken. That is a wrong notion. SSBs, that is sugar sweetened beverages, in general population significantly increase risk of type 2 diabetes, weight gain, heart disease, and NAFLD and caries of teeth. So meta-analysis showed the consumption of 1 serving of SSB per day increased the risk of pre-diabetes by 26% and type 2 diabetes by 13%. And consumption of so-called diet soda increases type 2 diabetes risk by 8% in a non-diabetic individual. So please be aware that diet soda is not really good and it's a myth. Impact of sugar substitutes. Very, very commonly asked question by a patient to you. ADA says supports with the restricted use. On the contrary, AHA says using sugar substitutes does not make an unhealthy choice healthy. It also mentions that there is not enough data for safety and benefits of these sugar substitutes. Hence, better discourage them using that. Somebody is very, very crazy, ask them to use it very limitedly. Only a cup of coffee he wants to have with a sweetened this thing he can take, but not adding these sugar substitutes to prepare a sweet and make it as a diabetes diet. Okay, that is not acceptable. It's a myth. So when sugar substitutes are used to reduce overall calories, people should avoid compensating with additional calories from other source. That is what happens. Then this is another mania, millet mania. Now India is celebrating as a millet year. And everybody says, sir, I'm not at all touching rice. I'm eating navane anna, save anna. So why my diabetes is not getting controlled? So they are overdriven to say that all millets are very, very good and very safe. No doubt it has more fiber. It does not match with other refined cereals like maida, but they are good, but not that they are going to do extraordinary benefit. So you should convince them you are able to tolerate, eat well, eat in this thing, but don't believe that you are, okay, last 1 minute. So myth is about prescribing multivitamins should always be co-prescribed in all diabetics. That is the practice some of the clinicians, but be aware the routine use of multivitamins is not recommended. It is a waste of money. Deficiency, you replace that. Especially those who are on metformin therapy, annual B12 status assessment has to be done and should be replaced. Routine use of chromium, vitamin D, herbal supplements, not supported by evidence and therefore not recommended. The last one is replacement of saturated fat with unsaturated fat reduces the total cholesterol and LDL cholesterol. Diet counseling on low carb diet is important. Low salt diet for hypertensives. Healthy food habits with the 2 servings per week of fish or non-veg consumers. The last is diet in CLD. Patients, the myth is patients with CLD in diabetes should restrict proteins. Friends, as long as they are not in the hepatic encephalopathy, don't restrict protein. So this is the recommendation. Diagnosing obesity in a CLD patient, because if he has ascites, will have a little difficulty because BMI is not the real option. Optimal daily energy intake should not be lower than 35 kilocalories per kg actual body weight in a non-obese individual with CLD. Optimal protein intake should not be lower than 1.2 gram per kg till he develops hepatic encephalopathy. Then only you have to reduce protein. Otherwise, don't have the myth that all liver disease patient, because if he consumes more protein, he will go to hepatic encephalopathy. Don't restrict that. So this is the dietary recommendation. And lastly, basics of a diet in cirrhotic is avoid alcohol fully, limit fat, avoid raw or undercooked meat and seafood. Eat less sugar because you are already sweet enough. Thank you for patient listening. I have thrown up some of the myths. There are so many hundreds of myths which are there. I just picked up some of those which are in existence for among the clinicians and among the these things. And CLD, CKD related myths are there among the clinicians which need to be kept in mind. plenty of myths are there among the patients who are counter-counseled by the neighboring patient. Thank you all. Absolutely. Thank you for not asking question, because
I request the chairpersons to honor the speaker with a memento. I'd like to call upon our next speaker, Dr. Lily Rodriguez, who will be speaking about management of HDN and diabetes.
Thank you. CV. It's okay. It's there. Thank you very much, the Chairperson, and thank you, Dr. Srinivas, for having invited me here. I bring greetings to you from Hyderabad, and to introduce my topic, I have put this picture. Can anyone guess what this is? Yes, Golconda Fort. To reach there, you have to walk up, and that's what we need to control hypertension. That's why I chose not Charminar. I chose this as the introductory picture. So now, coming to diabetes and hypertension, it's a toxic combination, and we need to prevent and manage this once it is there. The content of my talk would be hypertension in patients with diabetes, a little bit of expansion on that, blood pressure monitoring in patients with hypertension, management recommendations, particularly of RSSDI recommendations, and finally I'll summarize the whole thing. Now, coming to the prevalence of hypertension, from morning we have been hearing about hypertension. Dr. Narsingan has so elegantly talked about hypertension as a whole. I would be restricting my talk only to management of hypertension in diabetes. Hypertension is a major public health issue in India, and according to accounting for almost 11% of total mortalities and 4.6% of disability-adjusted life years. The prevalence of hypertension is higher in patients with diabetes. We all know this, and 50% of cases of hypertension also being diagnosed with type 2 diabetes. So which comes first? The hypertension may give rise to diabetes, and the reverse also can happen because the risk factors for both are common. I'll come to that in a bit. The prevalence of hypertension is nearly double in those with hypertension than those without diabetes. And then risk is more marked in the elderly population. So coexistence of diabetes and hypertension is much more in India as compared to the global scenario. Now, hypertension and diabetes Coming to the relationship, why are we more concerned? As we see here, it is a complex cause and effect relationship between the two. Involves obesity, visceral obesity, adiposity, and insulin resistance as the main pathogenic factors. So both on either side, but the microvascular and macrovascular complications are led by both of them. That's why they're toxic combination. Now, coming to a bit about the pathophysiology, we all know here, but elevated BP is closely related to the increased circulatory fluid volume and peripheral resistance, vascular resistance, and increased peripheral arterial resistance caused by the vascular remodeling, increased body fluid volume associated with insulin resistance leads to hyperinsulinemia and hyperglycemia. So both of these mechanisms elevate the systemic blood pressure. As you can see here, diabetes and hypertension in red, they share common risk factors like genes, of course, and insulin resistance, dyslipidemia, and obesity. Both of them lead to atherosclerosis, endothelial dysfunction, vascular inflammation, fibrosis, and arterial remodeling, giving rise to macro and microvascular complications, ultimately giving rise to cardiovascular disease. So there are various mechanisms by which the vascular complications happen in both of these combinations. So, hyperglycemia, RAS blockade, immune activation, oxidative stress, inflammation, and miRNA leading to macrovascular and microvascular complications. So coming to the management of hypertension in patients with diabetes, because it has to lower the risk of ASCVD events. Risk of cardiovascular complications is higher in hypertensive patients with diabetes, more than the individual hypertension. So every 10 millimeter of reduction of systolic hypertension in diabetic patients is associated from various studies. It is associated with significantly reduction in the cardiovascular complications, like 12% reduction in complications pertaining to the diabetes itself, 13% reduction in microvascular complications, 15% reduction in mortality due to diabetes-related complications, and about 11% reduction in the risk of myocardial infarction. So a few points about blood pressure monitoring. Morning, Dr. Narsingan beautifully concluded his talk about a cartoon where a doctor is outside the door, patient is outside the door and, lending his hand to check the blood pressure on the forearm, not accurate. So blood pressure measuring accurately has to be told to all the physicians that we, and then ABPM, that is ambulatory BP monitoring, is recommended for patients with, particularly for diabetes and hypertension combined. And then this will reduce the risk of post-treatment complications and overall improvement in the blood pressure control. Now, it is also recommended to opt for standing position during monitoring the elderly patient's BP. And calibration and validation of BP measurement instruments also must be considered. This is what we forget in our day-to-day practice, but this should be remembered. Now, coming to the ADA recommendations, BP must be monitored at every office visit in patients with diabetes. And if a patient is always an anxious type of a person, you must also advise them to monitor the BP at home. Now, in patients with elevated BP, multiple readings must be taken before you brand them as hypertensives. I would like to talk about RSST recommendations which were given in 2022 in of managing the hypertension in patients with diabetes mellitus. First and foremost, as we have been talking from morning, it's about dietary and lifestyle recommendations. then we need to know and tell all the physicians that we deal with, including the patients, the goal of BP control and initial drug therapy, then pharmacotherapy for hypertension management in diabetes recommendations and individual classes. Now, short I'd like to just mention shortly the dietary and lifestyle recommendations. We have been talking about it from morning. So the office-based BP, as recommended by RSSDA, it should be to diagnose BP it should be more than 140/90 office, but home it may be 130/80. That's what the highest value to diagnose a patient with diabetes as hypertensive. Now, if a person office-based BP is more than 140/90, it is recommended to initiate pharmacological therapy with lifestyle modification. Systolic BP target the value between 120 and 130 and must be achieved in patients with coexisting diabetes and hypertension. So for non-diabetics, you may wait till 140/90, but for people with diabetes, it should be less than 130/80, and through combination of dietary and lifestyle interventions, and then nutrition nutrition education about role of diet and knowledge of healthy food choices has to be discussed with the patient, and key dietary recommendation includes low sodium diet. So Dr. Narsingan has already shown us a picture of DASH diet and low sodium intake. Physical activity in the form of brisk walking sessions for 50 to 60 minutes a day, at least 3 to 4 times. And I would really suggest that it should be done every day. Pharmacotherapeutic recommendations in diabetic hypertension, individual profile of the patient and their response to the treatment must be evaluated for the selection of most suitable treatment agent for hypertensive management. So combination therapy of ARB and CCB is recommended to be initiated in hypertensive patients for better BP control, reducing risk complications, and better patient adherence. Now ARBs, either alone or in combination with CCBs, can be used for BP control in diabetic patients, and ARBs must be preferred over ACE inhibitors in diabetic patients with hypertension, telmisartan or azilsartan being selected as the first line of agent. This is what is recommended by the RSSDA again. Now, in patients at the risk of CVDs, renal disorders or cerebrovascular disorders, combination therapy must be preferred for the reduction of patients' mortality right from beginning. Now, CCBs must be preferred over beta blockers and thiazides in combination. Cilnidipine molecule as compared to the conventional CCBs like amlodipine for the use of because of their potential to cause cardiovascular events and hyperglycemia respectively. Now, monitoring of electrolyte levels, serum potassium particularly, and creatinine levels. Now coming to individual class, RAS blockers in diabetic hypertension, ARB and ACE inhibitors, most widely used antihypertensive drugs, we all know. ARBs preferred over the ACE inhibitors because they reduce cardiovascular, there's an evidence that it reduces the cardiovascular and cerebrovascular risks and renal complications, hence minimizing the morbidity. Losartan are most effective choices for reduction of cardiovascular risk. Beta blockers preferably not started as the first line agents particularly, but if with the previous history of CVDs like myocardial infarction, heart failure, coronary artery disease and stable angina, they might be added as antihypertensive agents but not as first line agents. Calcium channel blockers, cilnidipine is the first line release an action, so diabetes may be aggravated. So selective diuretics, like Dr. Narsingan mentioned, it should be indapamide or the other diuretics that are available. Low-dose spironolactone is recommended. Combination therapies, as recommended by different. Just 1 minute, please. Recommended by.
Thank you, Dr. Lilly, for giving us insights on management of HTN and diabetes. To move further, I request our chairpersons, Dr. Suresh KJ and Dr. Raja Selvarajan, to please come on the stage. I request Dr. Ganpati Bantwal,
So the effect of snack is strictly time, molecular size, and concentrated dependent and fully reversible. Approximately just 1% of oral semaglutide is absorbed and the rest is degraded by the GI tract, and this is enough for bringing the effects. Similarly, you have this desmopressin tablets, only 1% is absorbed. Oral insulins, 1 or 2% is absorbed. So all these things are just 1%, but good enough to bring about the effects. You had pioneer trials. So pioneer 1 was with placebo diet and exercise, 2, 3, 4, and 7 with OADs, 2 was with SGLT2, 3 with DPP4, 4 with GLP-1 receptor agonist and placebo, 7, we'll go to 6, which was basically a CV safety one. So if you see across the pioneer trials, pioneer 1 to pioneer 8, up to 1, %, MI, 10% for microvascular complications. So oral semaglutide can also produce blood pressure reduction of up to 1 to 6 millimeters. What about lipids? Yes, you are eating less, triglycerides comes down. You control the glucose, triglycerides comes down. Triglycerides comes down, the HDL improves. And not only that, you can also bring down the total cholesterol by around 10 to 15%. If that happens, even the LDL cholesterol comes down by around 10 to 15%. It also reduces vascular inflammation. So results. They got a benefit with this. So beyond the benefits already demonstrated, multiple phase 3 studies are going to further examine the disease-modifying effects of GLP-1 receptor agonist across the spectrum of cardiorenal metabolic disease.
Body, whether it is chest, finger, for basis peak, we will not go into details. For example, freestyle Libre is something which we are all aware. And similarly, the cloud-based systems are, we know that they are very much popular devices. And technical features of wearable, so primary device, they can measure the blood pressure, monitoring some physiological parameter. They can check heart rate variability, or interbeat interval of the heart. Sometimes galvanic skin responses can be measured by a wearable device, blood volume, pulse, acceleration, plantar pressures, temperature. And we know that all these measurements have some kind of values of immense value when it comes to management of people with diabetes. Data can be transferred by different modes of transfer which are available nowadays. And these are the sensing technology, just to list so that you have a complete and how different types of these sensors are used and placed in smartly in the device is also available. And while in other parts of the world, it is the Freestyle Libre 3 which is available. Eversense, which is an implantable CGM device, is again available. And Dexcom is one of the a very popular CGM device which is available globally. So they may be varying in different abnormality, and a person can simply know any aberration in the rhythm and can get the notification. We all know that people with diabetes, they're at risk of developing heart diseases, CAD, heart failure, arrhythmias, and one of the very common arrhythmia is atrial fibrillation. So, and a wearable device can measure. It is just about showing the technology. I'm not saying that each and every patient with diabetes should be wearing an Apple Watch. This is not the concept, but many of these sensors may be available in near future, maybe in relatively cheaper versions of the watches also. But the technology is there which can sense and tell you that the atrial fibrillation is there. This is just an example which is quoted by Dr. Jyoti Dev again, and how he was able to save the life of a patient only by getting an ECG from the Apple Watch, because he was able to see certain changes, though it is not validated for the detection of any MI or the cardiac events except atrial fibrillation, but still he was able to apply his knowledge and skills and save the life of this patient. All these parameters like activity, body measurements, tracking of the menstrual cycle, hearing by a wearable device. So multiple devices are available. Some of them are validated. Some of these devices are still in the process of validation, but they are available. And now these things can be monitored very easily. Heart rate variability is something which we talk about, the cardiac or autonomic dysfunction, and can be measured with the use of a wearable sensor. Blood oxygen saturation, we know that is something which is very easily doable. But there are different types of activities which can be tracked, right from the walking to a very high intensity training. And this and the nudges which comes with these wearable sensors can sometimes motivate you for doing the activity. This is something very, very important, like sleep I talked previously. So sleep is something which can be monitored by a wearable tracker. One of the and there are wearable devices which are specifically designed to monitor sleep, and they are able to tell you that whether the sleep was sound or was there a possibility of any obstructive sleep apnea. So these are the devices which are available. Again, this is something we know that diabetes also affects hearing. I'll tell you some of the future things which are coming. So what is a smart cloth? Smart cloth is a fabric which has embedded digital components or a sensor, and this is called a smart fabric. So using interactive fabric technology, these smart textiles are able to communicate information like the body temperature, heart rate, blood pressure, and wearer's location. And this is just an example that this Hexoskin is one of the example which I could found, and this is available, and this is used. Research for this is, there is a shoe which is launched by Nike, and it is a self-lacing shoe. So you need not to tie your shoe, the shoe automatically ties the lace. So we are concerned about that shoe may not be too tight in patients with diabetes. So I am saying that this may not be, these are the technologies. You may say that it is very expensive, everybody may not afford that. I agree with that. But we need to understand, so every second day we are not going to launch a rocket on the Mars or the moon. But the technology is there. So just another example. And one of the major advances which has now happened is a wearable BP monitor. And this is one of the first FDA approved device which is a cuffless device, and it is a wearable device. So many of the times we want to do a ambulatory blood pressure monitoring. So I think these devices are going to change the future in way we look at these things. Lot of talk is happening in around the chronomedicine. So now their devices, US company has launched world's first circadian health wearable. So now if you are an Apple user, now your watch has an update where it will be recording that how much time you have spent in the daylight. So this feature is now available in your Apple Watch. So the circadian health is something which is also now being taken care in the wearable devices.
Thank you, Dr. Amit Gupta, for giving us such wonderful information on the role of wearable devices and apps. Up next, I welcome our chairperson, Dr. Karunesh Kumar HS, on the stage. Let us welcome our speaker, Dr. Palaniyappan V.
It's my pleasure to call upon Dr. Palaniyappan. So many accolades for him, so many memberships and so many conferences he has conducted, and chairperson, scientific committee, lot of conferences. He has presented many papers. So I request him to, the topic is glucocentric to cardiometabolic approach in diabetes.
In diabetes management. So what do you mean by cardio-reno-metabolic approach or risk? So when the patient is having diagnosed as a type 2 diabetes mellitus, they will be associated with hypertension, diabetes, dyslipidemia, obesity, everything. On top of that is already genetic causes, environment causes, and that's a lifestyle inadequate, that's a work-life imbalance, and decline in the beta cells and endocrine, various endocrine disorders, and neural metabolic disturbance, visceral adiposity, ROS, and inflammation, and microbiota, and glucolipotoxicity. You are getting cardio-reno-metabolic risks are there. So you have to identify the cardio-reno-metabolic risk, atherosclerosis, and heart failure, and acute coronary syndrome. Metabolic hyperglycemia, insulin resistance, obesity, dyslipidemia, and NAS and NAFLD. Renal means decline in the EGFR at this step itself to prevent future macro complication. So cardio-reno-metabolic risk, CRM risk, what all the component prevalence in the CRM risk? There are 5 components are there. That is, 1 in 5 patients, they are having cardiac autonomic neuropathy, 1 in 4 NAFLD, 1 in 2 LV diastolic dysfunction, 1 in 2 chronic kidney disease, 2 in 3 obstructive sleep apnea they develop. So how to control these all 5 problems prevalence? Only if you give SGLT2 inhibitor timely in the early step itself, if you institute, definitely you can prevent all these complications. And CAN, that is cardiovascular autonomic neuropathy in type 2 diabetes mellitus, is very common in Indian population. It is equivalent to Caucasian population. In newly detected type 2 diabetes mellitus patient, presence of CAN is 7%. Every year chances for getting CAN is around 5%. So Asian population high risk group, you have to address properly. If you diagnose CAN, if you put them on SGLT2 inhibitor, so if you can reduce the CAN prevalence in the mean estimation of the vasovagal syncope, you are getting lesser vasovagal syncope when you are using SGLT2 inhibitor and comparing to the non-SGLT2 inhibitor user. And this SGLT2 inhibitor reduces the insulin resistance. What are the mechanisms behind that? It reduces the anti-inflammatory polarization, inflammatory cytokines, and reduce the T cell accumulation. NAFLD, that's NLRF expression is reduced, and it reduces the mTOR pathway oxidative states all reduced by SGLT2 inhibitor, as well as it increases the adiponectin and increases the fat browning and increase utilization of the free fatty acid. This is all the mechanism behind it reducing the insulin resistance, SGLT2 inhibitor. And SGLT2 inhibitor, it reduces the clinically relevant liver fibrosis, CRLF. So this has been studied in 2021 and published. Out of 601 diabetic patients, incidence of hepatic steatosis, NAS is 84%. 84%. Routinely I am doing ultrasonography, this remains same. In this, that is NAS patients, 70% people they are having elevated SGPT and 50% people they are having elevated SGOT. In my master health checkup, routinely I do SGPT as well as TSH in my routine master health checkup. And if you use HLD2 inhibitor, especially empagliflozin, the liver content, fat content in the liver is reduced by, if you use empagliflozin, 4% placebo corrected reduction in liver fat, and if you use in dapagliflozin 3.74 reduction will be there. So fat content in the liver is reduced. So there is a glucotoxicity and lipotoxicity also it's reduced when you are using SGLT2 inhibitor. And fat content in the liver, histologically also it's reduced. How is there? Steatosis improvement, low blood inflammation, ballooning is improvement, hepatocellular ballooning improvement is there. NAS resolution without worsening the fibrosis, it reduces the fibrosis and reduces chance of fibrosis resolution also there. Nowadays game changer is MRA. The liver, that is cardiac fibrosis, cardiac inflammation and kidney inflammation fibrosis is reduced by MRA. Like that, HLD2 inhibitor, liver fibrosis reduced by HLD2 inhibitor, and progression to cirrhosis also very much reduced when you are using HLD2 inhibitor. And instance of the LVDD, LV diastolic dysfunction in type 2 diabetes mellitus is 46%. In my experience, I am routinely doing echocardiography. It's around 75% in type 2 diabetes mellitus. LVDD, very common, even younger age group, 40 years, 30 years also, I am coming across. And progression of the diabetic kidney disease, it increases progression from stage 1, 2, 3A, 3B, 4. If the diabetes incidence also increases, duration increases, this stages also it increases. So in HLD2 inhibitor, if you are using, it's a Scandinavian real world study says, if you use HLD2 inhibitor and comparing with the DPP4 inhibitor, that is 58% lower risk of kidney progression, serious kidney events reduction is there. 58% reduction is there when you are using the SGLT2 inhibitor and comparing with the DPP4 inhibitor. And new onset OSA, obstructive sleep apnea, is reduced when you are using SGLT2 inhibitor by means of change in the reducing the weight, systolic BP, by improving the hematocrit, improving the anemia. It reduces the new onset OSA in type 2 diabetes mellitus. And these are all the prevalence of cardiovascular disease. Cardiovascular disease in type 2 diabetes mellitus, this is all the prevalence. 1 in 13 patients there have more prone to develop stroke, 1 in 10 myocardial infarction, 1 in 7 heart failure, 1 in 5 coronary artery disease, 1 in 3 all any cause CV disease. And so morbidity, mortality benefit and morbidity benefit, there are two things are there. Only two SGLT2 inhibitor, that is the empagliflozin and canagliflozin, well proved. It reduces the CV death, CV mortality benefit, as well as neutral effect on the HHF, hospitalization of the heart failure. And 3-point mass reduction also there, benefit with the canagliflozin and empagliflozin. And declaratomy, dapagliflozin, hospitalization of the heart failure is reduced. SGLT2 inhibitor, it has got a benefit in 3-point mass as well as cardiovascular mortality, especially liraglutide, semaglutide injectable form, and albiglutide and dulaglutide. And other drugs, that is especially DPP4 inhibitor, all except saxagliptin and alogliptin, it cannot be used. And other gliptin you can use, and weekly once is a neutral effect on mass as well as hospitalization of the heart failure. And oral semaglutide also, and once weekly exenatide and lixisenatide, there is a neutral effect is there. So this SGLT2 inhibitor, it has been widely tried especially to reduce the cardiovascular disease, CVD, in various studies. It shows, actually it reduces the cardiovascular death reduction with the SGLT2 inhibitor. It's proved in CVOT, driven by EMPA-REC outcome trial. It reduces the death, CV death, as well as in the ASCVD, either with ASCVD or without ASCVD, it reduces the CV death and CV death. And consistently improvement in the hospitalization, the heart failure also, whether in the presence of ASCVD or non-ASCVD, both. And in the presence of ASCVD or non-ASCVD, it has got a consistent improvement in the kidney outcome also there. And the cardiovascular morbidity and mortality benefit is there. With the empagliflozin, it had a major adverse CV events reduced by 14%, CV death by 38%, all-cause mortality reduced by 32%, HHF reduced by 35%, CKD reduction by 46%. CANVAS trial only 18% risk reduction, and HHF 32%, CKD progression reduced by 42%. And declared TIMI, that is dapagliflozin, no cardiovascular death benefit, only HHF reduced by 22%, CKD progression reduced by 45%. Vertis CV, no cardiovascular mortality benefit, only HHF and CKD progression. And with the SGLT2 inhibitor, it improves the heart failure patient, whether HFrEF or mildly reduced ejection fraction or HFpEF patient. All patients, it has been well proved. It reduces the CV death as well as HHF by relative risk reduction is 25% when you are using in HFrEF patient. Mildly reduced ejection fraction 29%. HFpEF patient relative risk reduction of CV death and hospitalization of the heart failure is 17%. It has been well proved. And comparison of the dapagliflozin and empagliflozin, these are all studies done. In that is dapa and empagliflozin, regardless of the type 2 diabetes mellitus, whether the presence of type 2 diabetes or without type 2 diabetes, type 2 diabetes mellitus, robust results are there, consistently reduces the risk of CV death and hospitalization of the heart failure. And regardless of the ORNI use, when the patient is having with ORNI or without ORNI, the empagliflozin and dapagliflozin especially empagliflozin reduces the CV death and hospitalization of heart failure with or without ORNI usage. And in HFrEF patient, SGLT2 inhibitor consistently reduce the risk of clinical kidney outcome reduction, kidney further progression of the CKD is prevented when you are using SGLT2 inhibitor in the presence of HFrEF patients. And it has been well proved DAPA, it reduces the serious kidney events are prevented by DAPA as well as Emperor reduced trial as well as Emperor preserved trial also. It shows it reduces the serious kidney events has been reduced, retarded by SGLT2 inhibitor, all SGLT2 inhibitor. And this has been tried, that is empagliflozin can be used when the EGFR is 20 to 90, any stage you can use, or 45 to less than 90 and urine albumin creatinine ratio more than 200. And dapagliflozin 25 to 75. Now recently there is a CKD, whether the presence of T2DM or not T2DM, you can use SGLT2 inhibitor, especially empagliflozin, that even at the EGFR of 20 itself. Cretans, it can be used 30 to 90 and UACR more than 300. These are the various trials, KidneyGo category. And SGLT2 inhibitor, actually kidney disease progression is reduced by 38% and kidney progression is reduced by 38%. So CKD patient, initially BP control, RAS inhibitor drug, and third one is SGLT2 inhibitor. Now recent arrival, that is anti-inflammatory, anti-fibrotic action in the kidney as well as heart, MRA, finerenone. All 4 drugs if you use, definitely you can prevent or retard the CKD stages and you can give a very good longevity for these patients. And if you use SGLT2 inhibitor and type 2 diabetes mellitus, incidence of the acute kidney injury is reduced by 21%. But acute kidney injury, once established, you should not use SGLT2 inhibitor. You have to wait, withhold the SGLT2 inhibitor. But if the patient is T2DM on the SGLT2 inhibitor, definitely it reduces the incidence of AKI by 21%. Relative risk reduction. EAC, European Society of Cardiology 2023 guideline says all type 2 diabetes mellitus patients, they have to screen for presence of target organ damage, microvascular or macrovascular complication. It's a class 1A indication. You have to screen for the presence of atherosclerotic cardiovascular disease. It's a class 1B indication. If the patient is having target organ damage as well as atherosclerotic cardiovascular disease, you have to screen for cardiovascular disease risk. What is the risk? Less than 5% or more than 20%, you have to screen. It is a class 1B indicator. This is all the risk. Accordingly, you have to manage, and according to the glucose-centric approach also, if the patient is overweight or obesity, GLP-1 receptor or HLT or combination GIP and GLP-1 receptor. Hypoglycemia also GLP or HLT inhibitor, and access cost is a problem. A sulfonylurea, glitazone or glinides. After that one, the next drug. Severe hyperglycemia also HLT inhibitor or GLP-1 receptor agonist. And nowadays he can use not a single drug, dual, 2 drugs or 3 drugs, 4 drugs, 5 drugs. Depends upon it's a purely patient-centric. And complication related also, the patient in ASCVD, number 1 drug is HLT2 inhibitor. After that only it comes metformin. Heart failure also HLT2 inhibitor, stroke GLP-1 receptor agonist or pioglitazone, CKD patient HLT2 inhibitor or GLP-1 receptor agonist or combination. After that only you have to select the other drug. And other thing is the obesity, depends upon the BMI stage 1, stage 2, stage 3, and you have to screen for the ABCD presence like HFrEF or HFrEF or left ventricular hypertrophy or remodeling, obstructive sleep apnea or NAS or NAFLD or GERD, urinary incontinence, subfertility or PCOS or osteoarthritis, all the things, ABCD management. ABCD complication you have to assess in all type 2 diabetes mellitus, especially in Indian population 23 to 25 is overweight. Here also you have to address. In this, drug is not needed. After that, if it is more than 25, definitely drug is needed. And quality of sleep is around 6 to 8 hours. At least 7 hours it's needed. Sasang has told 5 to 10 hours. You can choose. I used to sleep for 9 hours. That is good. Sometimes some people need 5 hours REM sleep. That means it's quite okay. Alcohol moderation, smoking cessation, everything is very important. And this all the thing, weight reduction, that's semaglutide injectable form, 15 to 18% reduction, liraglutide 5 to 6%, oral semaglutide 5% reduction, and orlistat 4% reduction is there. So you have to use judiciously in overweight or obesity class 1, 2 or morbid obesity. You can choose the drug. If it is morbid obesity, you can add bariatric surgery also. So whatever the stage, prevention is better than cure. You have to screen for CRM, cardio-renal metabolic risk. If it is present, you have to address and select appropriate therapy. So prevention is very important. Here also CRM screening and appropriate management. Regression, once developed, attacks everything, you have to treat properly and retard the progression to prevent the morbidity and mortality. And even the recent study that is 20 years it's presented in 2020, the presence of ASCVD or cardiovascular disease, usage of the HLT2 inhibitor or GLP-1 receptor or both, the only 21% people are using. It has to be, it is underutilized. It has to be overutilized and properly you have to utilize. Then only holistic approach is very, very important. Presence of various complications, according to that only you have to select the drug. To conclude my talk, the AAC 2023 guidelines wise, if you are a fantastic diabetologist means it's a metabolic, you should be a metabolic physician. Nowadays, previously, if you know syphilis, you know medicine. Nowadays, if you know diabetes, you know medicine. In future, if you know metabolics, you know medicine. So, two important things. When you are using the drug, proper drug, weight reduction will be there, no hyperglycemia. And you have to address, screen for the presence of the CKD or coronary artery disease or heart failure or obesity. According to that, only you have to select the drug. Nowadays, previously A1C, nowadays it has moved on to the time in range and glucose monitoring index, two important things within 1 month. Glucose GMI and TAR is very important rather than A1C. And fasting and postprandial blood glucose. 1 hour PPG is also very, very important. Many times fasting postprandial normal, still A1C is high. Why? Half an hour, 1 hour PPG is high. You have to address properly, select the drugs judiciously. CGM, intermittent CGM also cost effectiveness, and SMGG also you can use, avoid hypoglycemia and meet the target, glycemic target, BP target, lipid target within less than 6 months. Thank you very much for the patiently listening. Thank you.
Excellent talk with extensive information and commitment. I could see your commitment and the way you practiced it practically
Thank you, sir. Thank you, sir. Thank you. Excellent. Thank you. Yeah, I'm done.
The last 3 photos was
Okay. Yeah, I know.
Okay, superb.
Thank you, sir, for your kind introduction. And I thank Dr. L. Srinivasamurthy mainly for his invitation, and I'm proud to be here today. My talk is on lipid lowering in diabetes. So after listening to all the talks today, probably this is important because the overall management of diabetes includes lipid lowering too. As you all know, lipids are essential for life. Bilateral cell membrane and the energy source to heart and skeletal muscle, the substrate for hormone production by adrenals and gonads, a part of surfactant, a part of the myelin sheath, and signaling molecules, ligands for receptors are all made of lipids. So dyslipidemia means this imbalance of lipids, and it is either due to lipoprotein overproduction or lipoprotein deficiency. And consequence of abnormal lipoprotein metabolism, there can be increase in total cholesterol, increase in the LDL, that is the bad cholesterol, the increase in the triglyceride, and decrease in the good cholesterol, that is HDL. In India, dyslipidemia is a widespread concern, and see, the prevalence of dyslipidemia is very high in India, with 79% of the subjects have at least one lipid abnormality. And the prevalence is because there is a rapid increase in cardiovascular diseases, and coronary artery disease manifests almost a decade earlier in India than in Western countries. Incidence of CAD is increasing most rapidly among patients who are younger than 40 years of age, and about 10 to 25% of myocardial infarctions in India occur before the age of 40 years. More than 50% of CAD-associated deaths in India occur before the age of 50 years. So it's a huge burden. And the Indian scenario as per IDF Atlas for Diabetes in 2019 showed that in 2019 there were 43.9 million individuals who were undiagnosed with diabetes. So this is a huge burden. And prevalence of cardiovascular diseases as a complication to diabetes, any cardiovascular disease around 32%, and even strokes occur in around 7.6% of these diabetic individuals. And there is racial and ethnic differences in dyslipidemia patterns, and Indian population is considered one of the high-risk ethnic groups for the development of atherosclerotic cardiovascular disease. And in Indians, it is different from the Western populations in terms of high prevalence of high LDL, low HDL, and high triglyceride. So what are the health risks I'm alluding to? Atherosclerosis, coronary artery disease, peripheral arterial disease, cerebrovascular accidents, pancreatitis from high triglycerides, and gallstones. So this atherogenic diabetic dyslipidemia includes the high TG, the low HDL, and also the high values of small dense LDL. The LDL level is not that much important in these cases, but the high levels of small dense NDLs are more atherogenic, and these three is the triad of atherogenic diabetic dyslipidemia. And as you all know, non-HDL includes all other atherogenic lipoprotein classes, including VLDL, LDL, the lipoprotein A, HDL, and all. So non-HDL is something which is very important to us when we are treating our diabetic individuals. And the atherogenic lipoproteins, the non-HDL, the ApoB100 containing ones are quite important. To summarize, this is the pathophysiology of the dyslipidemia of diabetes. I will be alluding to a bit in my next few slides, but I will not bore you with the details. As diabetes individuals, as I said, the LDL is not usually high. The preponderance of the small dense particles, which are more atherogenic, is very important. And insulin affects on liver apoprotein production, the regulation of lipoprotein lipase enzyme, the actions on the CETP, that is the cholesterol ester transfer protein, and peripheral actions of insulin on adipose tissue and muscle. So to summarize, as from the previous diagram, hypertriglyceridemia is both decreased, there is increased production and decreased clearance. Insulin resistance leads to increase in VLDL1 levels, which are triglyceride rich, and also of the small dense VLDL2, which worsens the hypertriglyceridemia. Other than the increased secretion of VLDL, there is decreased clearance too, due to the decreased hepatic uptake and impaired activity of the lipoprotein lipase. And hypertriglyceridemia increases the activity of cholesterol ester transfer protein, as I mentioned. The transfer of triglyceride from triglyceride-rich lipoprotein to HDL and LDL increased triglyceride content of HDL and LDL. Whilst the LDL cholesterol is not overly increased, the small dense LDL particle comes into the picture, and the increase in chylomicrol and VLDL remnant particles are atherogenic too. Dyslipidemia is highly prevalent in Indian diabetics. Some studies showed it's about 90% and more. And the two major sequelae are premature atherosclerotic cardiovascular disease from the high apolipoprotein B carrying particles, and pancreatitis with those with a hypertriglyceridemia of more than 500 or 1000 even. So the challenge of coexistence is important, because they coexist because mainly of the insulin resistance, the genetics, the unhealthy lifestyles, like as is common for both dyslipidemia, hypertension, diabetes, and all these lifestyle-related diseases. And the higher cardiovascular disease mortality because of heart attacks, strokes, and other related mortality are very important. And the combined impact of diabetes and dyslipidemia on cardiovascular disease risk is often greater than the sum of their individual effects. So that's the importance of diabetic dyslipidemia, and probably that's the reason why Dr. Srinivasa Murthy gave me this topic, because this needs a bit of a discussion. And the Lipid Society of India also, Lipid Association of India has also come up with an expert consensus statement which said that in disease has increased insulin resistance, and genetic factors probably play a bit amount, because these are the characteristics: the thin fat Indian, the high visceral fat, the higher insulin resistance, the high inflammatory markers, high small dense LDL, the low HDL, the early beta cell destruction, early onset of diabetes, and higher risk of diabetes complications, along with more risk of cardiovascular deaths. So this is a very important thing about South Asians, particularly the Indian phenotype. So early and appropriate treatment is very important for these lipid abnormalities, and we have to integrate dyslipidemia into the risk assessment when we are encountering a diabetic patient, because dyslipidemia significantly contributes to the cardiovascular risk, and that is the point where the damage has already started. So who are the very high risk categories? The patients with diabetes with established cardiovascular disease, or those who have already established target organ damage. Three are major risk factors are early onset type 1 diabetes, because in those patients with type 1 who had an early onset of more than 20 years duration, they are high risk for cardiovascular risk, very high risk. The high risk ones are diabetes with more than 10 years without target organ damage, plus the risk factors like smoking, sedentary lifestyle, and all. And the moderate risk are those young patients of type 2 diabetes less than 50 years and the diabetes duration of less than 10 years without other risk factors. But overall, these high risk, when pancreatitis due to severe hypertriglyceridemia, that is one important point, because hypertriglyceridemia leads to pancreatitis, and that causes much morbidity and mortality, and to reduce the risk of macrovascular complications. So what is the approach to the management of dyslipidemia? The subjects with dyslipidemia increasing the usage of statins, increasing the adherence to statins in suitable subjects, focus on LDL cholesterol goals achievement, and very importantly, we should identify and apply the lipid markers like lipoprotein A, ApoB, and for risk stratification and control of vascular inflammation. So the management starts with dietary modification. We have to have foods which have more in omega-3 fatty acids with high fiber foods like garlics, onions and all. And we have to avoid refined sugar-based foods, packaged or processed foods, hydrogenated fats which mainly contain trans fats, and too much alcohol and too much caffeine should be ejected. Now, along with this treatment, the first thing is physical activity, because sedentary lifestyle should be avoided. A total of 60 minutes of physical activity is recommended, but if not, at least 30 minutes of moderate intensity aerobic activity like jogging, brisk walking, bicycling, and very importantly, aerobic activity should be performed in bouts of at least 10-minute duration, not less than that at a bout. Adults should increase their moderate intensity aerobic physical to even up to 300 minutes per week. We should engage in 150 minutes of vigorous intensity aerobic physical activity per week, and an equivalent combination of moderate and vigorous intensity exercises can be recommended. So the lifestyle interventions are paramount, but after that come the drugs. We have various drugs nowadays in our armamentarium to fight dyslipidemia. Overall dyslipidemia management is not much different for those we are treating for diabetes with dyslipidemia. So initiation of statin therapy depends on the targets, and the targets are based on the average risk scores. We know that if we need to have more than 50% reduction from the baseline, we'll have high intensity statins in the form of rosuvastatin 20 to 40 milligram per day or atorvastatin 40 to 80 milligram per day. If we target less than 50% reduction but more than 30, we can use a lesser dose of rosuvastatin and atorvastatin like 10 to 20 milligram of atorvastatin and rosuvastatin 5 to 10 milligram per day. So a high level of RCT evidence supports the use of an initial fasting lipid plan and is very important. For this, one thing I want to emphasize is we need to continue lifelong, because it's not like that we're targeting, we're stopping the medications and again we are restarting. We have to recheck after 4 to 12 weeks to know whether the patient is adherent to. And thereafter we can have assessments every 3 to 12 months. But very importantly, this assessment is to see whether the patient is adhering to our treatment plans. So the common lipid-lowering medications include statins, fibrates, ezetimibe, PCSK9 inhibitors, which are the newest kids in the block, and EPAs. Statins are the first line. Fibrates primarily target the triglyceride levels and also can raise HDL cholesterol. And ezetimibe is commonly used along with statins, and it's a cholesterol absorption inhibitor. So these are the dosage, and some side effects have been mentioned. Like for ezetimibe, there is abdominal pain, flatulence, diarrhea, and muscle-related symptoms can be given if it's given with statins. Bempedoic acid is another one, given 180 milligram orally daily. Hyperuricemia and gout is very important. These things we should keep in mind, because most of our patients present with comorbidities like gout also. So statins, as you all know, they inhibit the 3-HMG-CoA, and this is a rate-limiting state in the synthesis of cholesterol in the liver. And the moderate and the high intensity statins should be prescribed as per patient's requirement. The side effects are myalgia, around 5 to 10% of patients, but that mostly doesn't need to discontinue. In certain cases, only you need to discontinue after measuring the CPK and all. In very rare cases, there can be necrotizing autoimmune myopathy and rhabdomyolysis. Ezetimibe inhibits the intestinal absorption of cholesterol, but it should be in combination with statins. First, we should try to go to the maximum tolerable limit of statins. Then we should use ezetimibe to have the risk reduction, because the target, if the target is not reached. The combination of studies showed that combination of ezetimibe with simvastatin has shown to decrease the risk of recurrent ischemic stroke when compared with simvastatin. So it's another important point. For fibrates, as you all know, fenofibrate is the most common one. But one important precaution is that fibrates are metabolized in the kidney and should be avoided or used with caution in patients with CKD, because some patients have increased CKD prevalence, and that is very important. And major indication is to more than, if the triglyceride is more than 1,000, or some studies say it's more than 400. Niacin is another important point which helps in increasing HDL. But the combination of statin and niacin did not show any additional cardiovascular benefit. One important thing is there can be a significant increase in new onset diabetes, bleeding, and infections. So probably in diabetes with SCBD, the niacin-based regimen is not recommended. There are bile acid sequestrants like cholestyramine, cholecylamine, and all. They are contraindicated if the triglyceride is more than 400 because they can increase the risk of pancreatitis. Even omega-3 fatty acids like eicosapentaenoic acid and docosahexaenoic acids can be used. Now the latest kid in the block is the PCSK9 inhibitor, not very commonly used in our country because of high cost, because it's very expensive, but it can have a very significant decrease in LDL cholesterol as a monotherapy or even in combination with statins. It, very importantly, it induces atheroma regression and decreases the atheroma volume. Newer molecules, lerodalcibep, and vaccines against PCSK9 are in the pipeline. Last part of my talk is regarding, does high TG contribute to cardiovascular risk? The triglyceride and the cardiovascular disease risk. I have 3 minutes, sir. I'm saying I'll finish before that. The hazard ratio has been shown that it is more than 5% for these with myocardial infarction, and even coronary heart disease, heart hazard ratio is around 3.2 if there is hypertriglyceridemia. So high TG increases the CV risk by 3 to 5 times. This was well published around 10 years back in Lancet in 2014. The results, and very importantly, the other studies also show that the coronary heart disease in presence of diabetes and the ischemic stroke in patients of diabetes shows that there is 2.13-fold hazard of stroke in participants with diabetes and 1.5-fold greater hazard for coronary heart disease. So a high fasting TG level in combination with a low HDL level was associated with the increased risk of incident CHD and ischemic stroke, particularly in those with diabetes, independent of other atherosclerotic CVD risk factors. So the targets, definitely we have to target the LDL, in certain cases the HDL also. The recommendations as per guidelines, see, way back in 2013, it has shown that the high, moderate, and low intensity statins should be calculated as per the risk scores. Even 2017, the targets were revised, LDL less than 100 for the high risk, even less than 70 for the very high risk, and extremely high risk one is less than 55. ADA in 2019 mentioned where to use the moderate intensity statins and high intensity statins. Diabetics come into the picture in every field of moderate intensity statin use because diabetes itself is a cardiovascular risk factor. And ADA 2023 has given guidelines when to use, when to initiate statin therapy even in diabetes. Most importantly, above 40 years of age, more than 40, and there are more than, the risk factors go on increasing, more or less statins should be initiated. ESC also have guidelines which mentioned since 2019 has incorporated diabetes mellitus and age of more than 40 years but less than 75 years as an indication for using of moderate intensity statin. In this calculator also see diabetes is an important factor. So the last few slides are regarding the all various guidelines, and all have recommended statins in patients, even in asymptomatic patients who are having risk factors. We should start with statins, and where needed, we can add on other molecules. So what are the benefits of early initiation of statin? LDL should be lowered, endothelial function should be restored, inflammation is reduced, vulnerable plaques are stabilized, ischemic episodes are reduced, and cardiac events should be reduced. I thank you all for your patient hearing. I conclude my talk here.
Sir, I request you to come for a picture. Thank you, Dr. Sen, for sharing your insights on lipid lowering in diabetes. I welcome our next chairpersons, Dr. Pratyush Miglani and Dr. U. Venkata Krishna Rao, to please come on the stage. I hand over the mic to our last speaker of the day, Dr. Kannan Natarajan, who will be talking about artificial sweeteners and diabetes. Over to you, sir.
No password, no password. And also like to thank my good friend and my brother, Professor Ellison, for giving the great opportunity. Today my topic is on this very interesting. So the patients and patient attenders, even doctors have some sort of inertia because there are different school of thoughts, whether it can be beneficial effects or ill benefits like that. So this is the area we want to consider in clinical practice, and we want to educate the patient accordingly. So see, India is predominant for the carbocentric. Even though India is second capital for the diabetes prevalence and ultimately the epitome for the cardiodiabetic complication. Why? We are totally carbocentric. We love carbs, we love salt, we love this one sweets. That is the main reason we have the high cardiometabolic complications. And added sugars may up to 50% calories in the food varieties consumed by Indians. All our Indian-based traditional this one celebrations are mainly based on the sweets and extra savories, and also sweets plays an Indian herb. It's nothing but this one metrics, how much sweetness we are supposed to use in our clinical practice, ADI, so-called acceptable daily intake, and no observed adverse level. So what is the maximum limit the human body can accept this without having 29, 13? Aspartame, see, aspartame, there are multiple myths over there because aspartame causes cancer, aspartame causes some respiratory depression, some urine bladder cancer, and so on and so forth. But they're clearly demonstrated by means of 4 waves. One is seeing the NOEL, the second is seeing the ADIA, and third is seeing the estimated daily intake. If the estimated daily intake is less than the ADI means, it's very, very useful. And therefore, the clearly hypotheticated that this compound aspartame can be easily utilized in our type 2 diabetic patients, especially in replacing the sugar substitute in their food or in their coffee or tea routine in the lifestyle. So, but the quantity is very, very important. So these are the simple characteristic features we have. We have aspartame, neotame, saccharin, sucralose, and stevia. Aspartame is the only molecule we are using frequently. We have high sweetening substance, and ASK also we are using, but that contains somewhat bitterness, and therefore there are some blending with the ASK, especially with the sucralose as well as the aspartame to give the richness of the sweets as well as the this one 0 calories. Very interesting cartoon. We have multiple receptors in our tongue with the manipulated by means of genetic as well as progenetic. We have sweet receptors T1, R1, T1, R2, and T and R3. So these receptors is prevalent all over the substances of human biology. Brain we have in pancreas, we have intestine, and we have in this one gut microbiota dysbiosis. So these are the receptors will inculcate with the high dose of artificial sweetener. There are some sort of impairment in the metabolic control, and therefore, if you see the brain and the look of the food itself, there are some sort of signaling over the brain that is attaching signaling with the gut, brain, and pancreatic axis will go for cephalic insulin secretion and so on and so forth. This is a recent cartoon which was produced by Professor A.K. Singh, Professor Mishra, and Professor Sasank Joshi. They counter-induct the effects of NS in adiposity and glucose metabolism. See, after the ingestion of these artificial sweeteners, this enters the this one GI tract. In the GI tract, we have multiple receptors involving both sweet receptors as well as the sour receptors. This interfere with the whole metabolic control of the hypothalamus, that is gut-brain axis. This gut-brain axis will have the high dose. If we take high dose of NSS, this picture shows only regarding with the high dose of NSS, which have the burden on adiposopathy and glucose metabolism. In India, we have ABC, that is adipose-based chronic diseases, and also we have glucose-based, diabetes-based chronic diseases. So if you see this cartoon, it suppresses the satiety in higher levels, and ultimately there is some adipogenesis. There is increase in the, already Sasank was telling about this one SCFA, it is fatty acid, abnormal short chain fatty acids also, and thereby going for the dysregulation in the dysbiosis, and going for alteration in the gut biota, and so on, so forth, producing for insulin resistance, impaired insulin sensitivity, and thereby go for the fasting sugar elevation. So this is the hypothesis. was clearly implicated by WHO also and endorsed by US FDA, but our AK Singh was clearly entitled this, if it's taken low doses, there are no problem. But the only thing, if the patient having the early form and going for the high doses, these are the culprits that we have to place in our lifestyle with the type 2 diabetic patient. So saccharin, we know saccharin is one of the oldest form of artificial sweeteners. It has some bitter taste. It is stable. It is mixed with all the foods. And we have aspartame. Aspartame one of the highest sweetening agent, more than 400 times it is more sweetening than the routine this effective sugar, and is mixed with all the food substitutes, and is usually practicing in India also. ASK is somewhat bitter, and therefore it is mixed and amalgamated and integrated with the sucralose as well as aspartame for the synergistic effect as well as sweetening effect. But there are some impact on the kidney substance also, because this potassium will interfere with the nephrons and thereby go for some sort of kidney impairment in the uncontrolled diabetes mellitus if you go for this high doses of ASK. Sucralose, once again, it is mostly used compound in India for any food making substance. Highly sweet substance, is stable, water soluble, no metabolized, totally released in the urine and feces, and therefore it easily can be given in low doses. 88 doses can be given. It is mixed with any type of food, including the desserts, baked foods, and ice cream, and so on and so forth. This is nothing but the second generation of stevia glycosides. This is novel sweetener, latestly approved in 2006 and 2009 in US FDA also, and all parts of the other countries, Europe, we are practicing, Canadian and Japan. Even Japan colleagues, Japan peoples also with type 2 diabetes, they're taking this novel sweetener, stevia, in their food product, because stevia is a plant-based product, and it has some property on the atherogenesis, and it has some property reducing the vascular inflammation also, and therefore it's somewhat very useful in comparing with the previous compounds, as I mentioned, as ASK, as well as aspartame, sucralose, and saccharin also. If you see the side effects, health concerns, recently WHO published health concerns regarding artificial sweeteners, maybe neurodegeneration like Alzheimer's disease, maybe some cognitive impairment, disrupted metabolism, carcinogenic, addictive, CVD burdens have shown. They have shown the gut microbiota going for insulin resistance, insulin sensitivity, and kidney disease. But if you see the underline there, only in high doses, not in the ADI doses or NOE-filled doses. We have to keep in mind. These were the latest WHO guidance and recommendations released latest 2022 by 210 dossiers pages. They clearly entered with the multiple meta-analysis, organizing both with the randomized controlled trial as well as the prospective cohort study. See, they have done one side with the randomized control trial, and other side with the prospective cohort study. In the short randomized control trial, they couldn't be able to see any problem regarding the possible biological impairment. But in the large cohort study with the lengthening usage and excessive usage of this compound, will have an impact on the cardiovascular manifestation, respiratory manifestations, kidney manifestations, as well as the brain manifestation, including the improper diabetes control. So this can be continued, but only the dose is the matter, ADA is the matter, NOFEL is the matter. So we need further research, because they don't have any Indian-based data. They have other ethnic populations like Caucasian population, they have the European population they have, but they didn't study regarding the Indian population. All the global societies, including the American Heart Association, ADA, clearly hypotheticated that this can be used, but the only dose is important. Another thing, British Dietetic Association, very, very important association, they clearly emphasize that this is the management of weight as well as the health conditions such as diabetes, individuals, but a tailored individual approach is very, very important. That is, ADA measurement, even with aspartame also, sucralose also, ADA measurement is very important. 50 milligram or 50 grams like that we consider daily usage should not cause more than that. Even Canadian Association, our own association, RSC, also clearly hypotheticated the need of the artificial sweeteners, but maybe consumed in recommended amounts, and including ICMR also, and including our European, Endocrine Society of India. This another interesting cartoon was published by Dawood. You have clearly entered that these receptors have the 3G coupled protein receptors, and if you take the excessive amount, there is a growing concern about the potential harmful effects associated with the NNS concern, this non-nutritive consumption, going for gut dysbiosis, interface with the sweet receptors, and ultimately to go for the adipogenesis, lipogenesis, increase in the SCFA, and going for gut microbiota disalteration and dysregulations, and so on and so forth. Even though some patients will go for the early implementation of the Alzheimer's disease as well as this one Parkinsonism disease, including cognitive impairment among the children population. This data was given by published in Newton's 2020. It's a randomized double-blind crossover study. They were finding with the prevalence of the gut microbiota imbalances on usage of these compounds, so-called as, one side they tried with the aspartame, on the other side they tried with the sucralose. They were easily finding that after the 8 weeks to 9 weeks, the total number of patients, only a small population, 17 population, but they couldn't be able to see any abnormalities over the gut microbiota dysregulation or disalteration or anything regarding with the sucralose also. If you see on the other side, there is improvement in the gut microbiota abundantly. They found with the 17 patients over the period of 6 weeks to 8 weeks or 6 months to 9 months also. So there are no changes in the gut microbiota structure were detected, and this one short chain fatty acids also was unaffected by aspartame as well as the sucralose consumption. Our own key opinion leader, Professor V. Mohan, last year they published a data in American Diabetic Association regarding the usage of this one sucralose, one of the commonest usage in India, on the gut microbiota one side with Indian patients, in type 2 diabetic patients, and also they were seeing the burdening of the CV risk factors among the adult population with type 2 diabetic patients, and also they were analyzing with the over and obesity population in the CV risk factors with the type 2 diabetic patient. See the conclusion, 2 to 3 cups of tea coffee, each cup 1 pellet, which gives 6 milligram of sucralose, produced no significant change in gut microbiome in Asian Indian adults with type 2 diabetes, but helped in reduction of body weight also on body fat. So ADI is a matter, that is dosage dependence is a matter. On other, if you see the cardiometabolic risk factors, there also they couldn't able to see any abnormal outcome with the low dosage, but they not tried the high dosage, but the low dosage in overweight and obese participants. Replacement with the NNS, that is the non-nutritive sweetness, helps in reducing the adiposity, this visceral adiposity as well as the subcutaneous adiposity indices, along with the improvement in cardiometabolic parameters. They were tried with the 150 for adults over the period of 12 weeks, almost the age duration between 25 and 50 years. So this statement was given by WHO in 2022, reanalyzed by the British Nutrition Foundation, and they consider hypothetically emphasize the critics across the globe, considering see the last 3 lines, considering the conditional nature of the recommendation of the fact that all the sweeteners in our food supply were being rigorously tested for safety. It seems sensible to continue to make use all these tools. There are no problem with the low dosage. So this data was given by IARC and endorsed by WHO and US FDA also regarding the cancer prevalence. They tried with the aspartame molecule because aspartame converts into methanol and deposits in the liver, which is highly this carcinogenic they consider. But the panel trial they concluded that aspartame was not of safety concern. The current aspartame exposure estimates or the ADI of 40 milligram per kilogram is very, very tolerated, and therefore there are no the impact of the carcinogenic effect of the aspartame or sucralose in the human subject have been clearly demonstrated by IARC in their own guidelines by July 2023. So these are the myths and facts I will clearly clarified. NNS is associated with high risk of cancer, though it has been cancelled by US FDA and American Society Cancer Society in 2020 with the nominal dosage. Once again, gut microbiota, and clearly the American College of Gastroenterology clearly described there are no abnormality of the gut biota. There is improvement in the gut biota also, and therefore there are no impairment of the insulin resistance, the insulin sensitivity, but the dose, once again the dose is the matter. Regarding the CKD also, the National Kidney Foundation planning for the emergencies. A guide for the people with the chronic kidney diseases recommends adding in artificial sweetness as a part of the emergency diet plan. See the wording that mentioned here. So these may be helpful among the kidney disease patients also to replace the sugar along with the artificial sweetener, especially with the aspartame or sucralose that is usually practicing in our India. Is there already our previous speaker regarding the diabetes food myths? They clearly described Does all this diabetic sugar food are regarding is really sugar free? Are regarding really a sugar, zero sugar, added sugar? No, it's totally adulterated. Is sugar-free labeled products are really sugar-free? No, we should not become fooled. We should not advocate the patient for that. So we educate the patient, emphasize the patient. Education is the ultimate key for all type 2 diabetic patients and even type 1 diabetic patients, including the GDM also. So this usage of this aspartame, sucralose are all dose dependent only. Recently, our AK Singh and whole team, Professor Shashank Joshi and Anup Mishra, are deciphering the total outcome of the WHO was released guideline previously 2022. They found that in the randomized control trial with the short duration, they couldn't be able to see any problem. But there are some impairment on the weight, there are some impairment of obesity, in cardiovascular morbidity and mortality, cardiovascular burden, including the kidney also, with the this one long-term prospective COCA study and comparing with the acid. This we have to keep in mind. Therefore, this artificial sweetener can be given, but dose is once again I'm repeating the thing, dose is the matter, and we want to educate 1 pellet or 2 pellet morning or evening, not excessive over there, even maybe sucralose or aspartame or SK, so on and so forth. So my dear friend, to conclude, we need more Indian scientific data to fully understand the health implications of artificial sweeteners. It is best to cut down on non-nutritive forms of sweets such as desserts and sodas and switch to nutrient-rich ones. Reducing the amount of added sugar as well as artificial sweeteners in our diet eventually decreases our sugar cravings, and that inductively better than worrying about these effects. When consumed in moderation, they are safe. This conclusion was given by Professor Mi Mohan and Dr. Cheryl Salis, one of the good nutrition in Mumbai. So this is our human evolution. We have to turn and we have to return. So since 50 years, we are like this only, homo diabetic, homo obesity with a huge belly and visceral adiposity. So by means of effective lifestyle, and Shashank Joshi was telling about the healthy eating pattern, we follow that, and we want to turn around, my dear friends, turn around fellas, and we got it all wrong. Thank you very much for giving the great opportunity. Thank you very much.
Thanks, Dr. Kannan, for excellent talk. So I think to conclude, as sir presented, there is some data on artificial sweeteners increasing the insulin resistance, but the benefit is also palpable. So the decision has to be taken based on patient's profile. If they are having difficulty quitting sugar, this could be used as a stop-gap arrangement. But again, dose-dependent effects, and that is why we should use it wisely where the patient is trying to, it's a de-addiction. So if patient is going through sugar de-addiction, this can be used wisely.
Thank you for the opportunity.
I request our chairperson to hand over the memento. Thank you, Dr. Kannan, for sharing us wonderful information on artificial sweeteners. What an uplifting and productive day it was. We extend our sincere gratitude to all the speakers and participants for making this conference a great success. We hope you've gained valuable knowledge and made important connections during the day. We look forward to seeing you again at our future events. Have a safe journey home. Goodbye and thank you.